Hello, check testing, mic testing, check. One, two, three, check. Hello, hello. Hello, check testing. One, two, three, check. Hello. Hello, hello, hello.
Hello. Hello.
భాస్కర్ ఉంటాడు ఇది ఎట్లా డిస్ప్లే చేయడం
Hello, hello, hello. Hello, hello.
Good morning to all. A warm welcome to all the delegates to this scientific session, which is being conducted by the Department of Medicine, Kurnool Medical College, along with the SID Society. We'll start with the sessions. I'll introduce Dr. Surekala. She will be the coordinator for the academic session in the morning. Thank you.
Good morning everyone. On behalf of Department of General Medicine, Kurnool Medical College, Kurnool and Clinical Infectious Disease Society, AP Chapter, I extend a warm welcome to all the distinguished guests, speakers, chairpersons and delegates to this infectious disease CME. We begin the program with the scientific session. It gives me great pleasure to invite our first speaker for today's scientific session, Dr. Teja Vasireddy Madam. Let's Madam has completed DM Infectious Disease from School of Tropical Medicine, Kolkata. Now she is consultant at Medigo Hospital, Tirupati, Infectious Disease Consultant. Madam areas of interest are multi-drug resistant organisms, management of carbamazepine producing gram-negative bacteria and methicillin resistant Staphylococcus aureus. Pediatric immunodeficiency related infections and congenital infections, transplant infectious diseases. And also, Madam is a member of prestigious societies including IDSA, ESCMID, ISHAM and CIDS India. Now I request Madam to start workshop on antimicrobial susceptibility testing interpretation. Dear Madam, workshop.
So good morning everyone. Any microbiology PGTs or only medicine PGTs I have here? Do we have microbiology PGTs? Majority are medicine PGTs. Okay, so before going into in-depth of AST interpretation, anyone who could point out what is the mistake in the culture report which has been shown here? For PGTs. Any PGT who could interpret this blood culture report or who could say what are the wrongs in this blood culture report? I think everyone sees blood culture report. For at least in ICU cases, we send blood culture reports and early morning, I don't know, in our infectious disease round, early morning we go for blood culture sensitivity reporting and we'll assess the report. If anyone is seeing here, what is the mistake in this report? What do you want in a blood culture report? Only sensitive or resistant, or you want more information from the blood culture report? Ma'am is saying something. What do we want from a blood culture report? Urine culture or blood culture report, any culture report, what do you want? Yes. Yes. Do you see any MSC value here? So the first mistake you recognized is the MSC value. Next, what is the other wrong thing they have done? They didn't mention about the resistance. No resistant antibiotic was tested. Every antibiotic is sensitive. But what is the other wrong thing they have done? So any blood culture report, the first thing anyone wants is the MIC report, which has been missed in this. So how do we report a blood culture? How do you get an MIC? Do anyone know how do we get an MIC? From where do we take an MIC or where do we interpret the blood culture report? So we'll learn how to interpret the blood culture report in the next slides. Antimicrobial susceptibility testing is defined as a process used to determine the effectiveness of antibiotics against specific bacterial strains. Employing methods, I think everyone know how do we do AST. How is it done here? Someone from microbiology. Disc diffusion, everyone knows that the first thing they do here is disc diffusion. Everyone knows cribribroid disc diffusion. I think everyone saw the discs at least. Microbiology, at least microbiology students can say that they do the disc diffusion and early morning you see the discs and see whether what is the zone diameter, what is that, everything. So the first initial method we do is the disc diffusion. What is the advanced method for AST interpretation? Vitek reporting is the advanced method. So you could see below everything is there, the Vitek, E-test and the disc diffusion methods. So now the previous AST we have seen and now the AST we are seeing, what is the difference? What is the difference from the previous AST report to this AST report? Someone asked for the MIC values. So could you see MIC values in this report? MIC values are visible in this report. So the previous report didn't mention about any MIC values. It just gave it is sensitive or it is resistant or it is intermediate. So in here we could see MIC values, which criteria they have followed for the MIC values. So how do you get an MIC value? So we'll move on. So first, before determining an MIC value, we'll have a break point. So what is a break point? Break point, I think microbiology people know about the break point. Break point could be clinical break point, microbiological break point, and epidemiological break point. So finally, to get an MIC value, we need specific samples like 100 to 200 break points, which gives the clinical data, entire clinical data, the pharmacodynamic and pharmacokinetic, as well as how the patient is resolving with an antibiotic and how the microbiological characters are there. So you could see here, what are the parameters required for determining an MIC is, MIC distribution data is required, PKPD data is required, and clinical outcome data is required. So everything adds into your final reporting of AST. So I think everyone knows what is MIC. It is the lowest concentration of drug at which growth of organism is inhibited. Only the growth is inhibited, not the complete organism is not eliminated. MBC and MIC difference is, in MBC, entire organism is eliminated. It is only for bactericidal drugs. So what are the types of AST reporting? You could see this report didn't have MIC. That report is given with MIC. So how they are following, what are the bodies or guideline committees from which you take the MIC values or the breakpoint values and give the report. Does any student know what are the guideline committees you follow? A US based organization which gives report based on the breakpoints and all, and the MIC and the clinical distribution. UCAST is a European organization which gives data, even the epidemiological data, not only the clinical data. They test the wild strains and give the epidemiological data. So according to these AST categories, everyone know, I think, S, I and R. What is S in the report? S in the report of AST is sensitive. I in the report is intermediate. R in the report is resistance. What is SDD? Susceptibility, dose dependent is SDD. So according to CLSI, how many groups of reporting we have? Group A is primary test and it is reported for everything. Group B is optional test. If the primary test antibiotics are resistant, then we opt for group B antibiotics. Group C is supplemental and it is only selectively reported if we ask for the reporting of those antibiotics. Group U is only tested for urinary organisms. Group I is not approved by US FDA, they are still investigational drugs. And group O, other clinical indication, if you want any other antibiotics, they will report it for you. So these are the reporting. So group A, we have primary test and report. The group A antibiotics are ceftriaxone, ceftazidime, ciprofloxacin and gentamicin. Group B, additional antibiotics are amikacin, piptase and meropenem. Group C, the special antibiotic is colistin. If it is identified as salmonella, we require additional antibiotics like azithromycin, chloramphenicol. If we ask them, they will report that. And for urine, if it is an urinary organism, we ask for nitrofurantoin, norfloxacin and all. So these are the UCAST reporting. In UCAST reporting, there will be susceptibility intermediate. One thing which is missing from UCAST and CLSA is ATU, that is area of technical uncertainty. So I request one of the PGT to interpret this report. So if you could see, the report is urine culture report. The organism is Klebsiella. The colony count is 10 power 5 colony forming units per liter. So how could you interpret this report? What type of Klebsiella is it? So how will you interpret any blood culture report? What is the first antibiotic you want to give to a patient who is having gram-negative infection? Klebsiella is gram-negative or gram-positive? I think this everyone could say, gram-negative organism. So what is the first antibiotic anyone would give to a Klebsiella, simple Klebsiella urine infection? From which antibiotic we would start? What is the simple antibiotic anyone want to start for an UTI infection? Think the patient is in urosepsis. Simple antibiotic anyone want to start from seeing this report? You could say any antibiotic which you are seeing. Don't see this report. Normally in your mind, if there is a Klebsiella infection, what antibiotic you would think? I don't think you would think linezolid or something like that. What would you think for a gram-negative infection? Nitrofurantoin. Okay, nitrofurantoin, someone is saying nitrofurantoin. For lower urinary tract symptoms, yes, nitrofurantoin we can think of. Next antibiotic, if it is upper urinary tract, patient is in sepsis, septic shock. Piptaz, piperacillin tazobactam we would think of. So what is it showing? You start from the piptaz. What is the report showing for you? Piperacillin tazobactam, the MIC is more than 128 and the interpretation is resistance. So the piptaz, the initial antibiotic which you are thinking is resistance in this patient. So what will you call this bug? Antimicrobial resistant Klebsiella. Which type of resistance it is harboring? ESBL, very good. It is harboring ESBL. So next drug, if it is ESBL, Klebsiella, what would you think of the next drug? We will think of carbapenems, meropenem or imipenem. So next drug we think of is carbapenem group, that is the imipenem or meropenem. So if you could see what is the imipenem interpretation here? Resistance. What is the interpretation for meropenem? Resistance. So what type of Klebsiella is this? From ESBL, what is the next Klebsiella we are seeing here? What is the next resistant pattern we are seeing in this Klebsiella? Carbapenem resistant Klebsiella we are seeing. So this now interpret this complete report. Everyone has helped you. I think every PGT for PGT, every sir has helped you. Carbapenem resistant Klebsiella pneumoniae in urine. So what is the drug of choice for carbapenem resistant Klebsiella pneumoniae in urine? So you interpreted that report. You have seen meropenem is resistant. So it is carbapenemase producing organism. So what are the most, what is the most common mechanism of resistance in Klebsiella? Enzyme production is the most common mechanism of resistance. So the enzyme produced here are carbapenemases, because of which meropenem is resistant. So if we interpret this report, as sir said, it is carbapenem resistant Klebsiella pneumoniae. Anyone who could say what is the drug of choice for carbapenem resistant Klebsiella pneumoniae? How common you see these reports? At least during your daily rounds, how common do you see? I think piptaz resistant everyone sees, if I am not wrong. Daily in rounds you could see piptaz resistant, at least up to piptaz resistant, then you will give meropenem. At least till then I think everyone knows. If piptaz is resistant, you will give imipenem or meropenem based on the sensitivity of the report. How common do you see carbapenem resistant, meropenem resistant Klebsiella? Even if not in urine, in blood or in sputum, any report. You are very lucky, in your hospital you are not seeing CRKP. In our hospital daily we are seeing only CRKP. One source is daily CRKP. So what is the drug of choice? Anyone, any PGT could answer what is the drug of choice for carbapenem resistant Klebsiella pneumoniae? Azithromycin, tigecycline, colistin, polymyxin. I think Nireen sir should help. Only ID people could help. Among these all answers, azithromycin, polymyxin, tigecycline, colistin. Main drug of choice has not yet come from anyone's mouth. Siderophone, new antibiotic sir is saying, which has not yet released in India. according to IDSA guidelines, one drug is there which could act in India. Someone is saying it. Yes, ceftazidime-avibactam is a drug of choice for carbapenem-resistant Klebsiella pneumoniae. For urinary infections, we could try whatever antibiotic someone has said, like colistin and all. If they are sensitive and it is only lower urinary tract infection, we could try antibiotics. So if you could see in this report, how is colistin reported? So someone has said colistin, right? If meropenem is resistant, I would give colistin. So how is it reported here? What is the report you are seeing for colistin? I'll help you with it. Colistin less than 0.5, it is shown as intermediate. So would someone give a drug which is intermediate to the patient? How would you give the drug? Think the patient is in urosepsis with septic shock. Would you give only sensitive or would you give intermediate antibiotics also to the patient, or only sensitive antibiotic? Anyone wants to give the antibiotic which is intermediate? Anyone wants to give the antibiotic which is intermediate? Think the patient is not in urosepsis, think only is in lower urinary tract symptoms. He is just having fever with chills with lower urinary tract signs. Would you give colistin if it is intermediate, if the carbapenem is resistant? Anyone want to give? So no one wants to give colistin here. So is colistin reported sensitive in these reports? Microbiology should say. Colistin is never reported sensitive in Vitek reports. This is the Vitek report or the initial report which we get. So what we have to do for the sensitivity of colistin or sensitivity of something which could not be determined by Vitek? So Vitek can give intermediate or resistant if I am not wrong. So Vitek is giving you intermediate here. So how would you test for colistin? If you want to give only colistin, how would you test for colistin? BMD is the method of choice for testing colistin resistance. We'll go for broth microdilution and see if the colistin is sensitive or resistant. Then we can plan if the patient is responding to colistin, and if it is sensitive in BMD, we can continue with the colistin. So the sensitivity has been removed from the CLSI for these organisms. For Enterobacteriales, Pseudomonas and Acinetobacter, colistin is reported only as intermediate or resistant in Vitek reports according to CLSI. And for Enterococcus faecium, daptomycin is reported only as SDD and resistant. So you have to remember, whenever someone is seeing a report of intermediate, I have seen giving higher doses. If you give higher doses, it works. So there is no S category in Vitek reports of colistin. Don't think intermediate means if you increase the dose of the drug will work. There's nothing like that. The S category has been removed from the Vitek reports. We could only see intermediate or resistant. If you strongly suspect resistance, you have to do broth microdilution for that drug. Yes. Removed the S category, sir. Yes, yes. That is the main reason they have removed, because the meropenem which we are seeing, rampant use has been because of the sensitivity reports. So they have purposefully removed from the CLSI and UCAST criteria the S. So if we want to do S, we have to do broth microdilution, not the simple disc diffusion tests. So there are some area of technical uncertainty in reports. So for the wild type reports, we couldn't get all the breakpoints or MIC. Some antibiotics doesn't have breakpoint or MIC according to the reports. They are reported only as epidemiological cutoff values. Like the newer antibiotics, daptomycin and daptomycin, or Sir has said, cefiderocol, ceftazidime-avibactam, they may not have all the clinical criteria which are required. So we'll have epidemiological cutoff values for those. So any PGT who could assess these terms in blood culture reporting. What is MDRO? Multi-drug resistant organism. What is the definition of multi-drug resistant organism? Anyone who could say what is the definition of multi-drug resistant organism? At least 3 antibiotic classes should be resistant. Class of antibiotics, not 3 antibiotics. 3 different class of antibiotics should be resistant. So the report here shown, does it fit under multi-drug resistant organism? So what is one class of antibiotic? Beta-lactams. So here you could see piptase is resistant. What is the next? You could see fluoroquinolones. Ciprofloxacin is resistant. What is the next? You could see amikacin. Amikacin is resistant. So 3 classes of antibiotics are resistant. So this report which is shown could be multi-drug resistant organism. So what is XDR organism? Extensively drug resistant. So what is the definition of extensively drug resistant organism? So it should be more than multi-drug. So what would be the definition of XDR? So only 2 sensitive antibiotic classes. If we are seeing only 2 sensitive antibiotic classes, remaining every class is resistant, it is called XDR organism. So this organism, does it fit under XDR organism? Phosphomycin is sensitive, so 1 class is sensitive. Colistin is sensitive, so 1 more, if we take intermediate as sensitive, so 1 more class is sensitive. So we are seeing 2 antibiotics as sensitive, so it could be extremely drug resistant organism. What is DTR organism? Difficult to treat organism. So this, does it fit under difficult to treat organism? Could you see any antibiotic which could work for it? What is the report? Urine report, Klebsiella, you could see only intermediate to colistin and sensitive to phosphomycin. If the patient is in urosepsis and septic shock, is there any other antibiotic which is reported here which you could say is sensitive? I think no one could see, so it could be under difficult to treat organism. So what is BLBLI? Beta-lactamase inhibitors. So what is beta-lactam? What is beta-lactamase inhibitor? So what is beta-lactam group of antibiotic among these? Piperacillin is beta-lactam. What is beta-lactamase inhibitor? Clavulanic acid, tazobactam, those are beta-lactamase inhibitors. So example of BLBLI could be, piptase could be the most example. What is ESBL? Madam has said ESBL, extended spectrum beta-lactamases. So is this ESBL Klebsiella or not? How would you see in any report to say it is an ESBL organism? What is the antibiotic you would see to stamp? If I am not giving any information, you are seeing the report. By seeing the report, how could you say this organism could be ESBL? Madam could help, microbiology. 3rd generation cephalosporin. So among these 3rd generation cephalosporins are ceftriaxone. Ceftriaxone is, what is in that report? Resistant. So if ceftriaxone is resistant, it could be ESBL organism. So this Klebsiella could be ESBL organism. What is CPO? Carbapinamase producing organism. So what we have to see in this report, to say it is carbapinamase producing organism. Imipinam, meropenem, any carbapinam we have to see. If you could see ertapenem, imipinam, meropenem are resistant. So it could be carbapinamase producing organism. What is CRE? Carbapinam resistant Enterobacteriaceae. So this Klebsiella could be carbapinamase resistant Enterobacteriaceae. Next, MRSA and VRE, I think everyone knows. What is MRSA, what is VRE? At least for this, MRSA is methicillin resistant Staph aureus. VRE is vancomycin resistant Enterococci. So we'll move on with the cases. This is the case 1. So his blood culture or sputum culture. Think the patient is having pneumonia, admitted in ICU with a sputum culture report of Staphylococcus aureus. Now you interpret, any one of you can interpret this report. So is it gram? First what you will interpret in a blood culture or urine culture or sputum culture report, what would you see in that report? First thing you would see. From where the sample has been collected. Here it is written, has been collected from the sputum. So you are now knowing the syndrome of a patient. If you are thinking of pneumonia, the sample has been collected from the sputum. So next what would you see? Organism. So you are seeing the organism as Staphylococcus aureus. So you have in mind Staphylococcus aureus is gram-positive bacteria. So what are the antibiotics which work for gram-positive bacteria? What are the antibiotics which work for gram-positive bacteria? This everyone could say. What are the antibiotics which we give for gram-positive bacteria? What are the antibiotics which we give for gram-positive bacteria? Penicillin, next. You also can say. PGTs also. You'll give for gram-positive bacteria, right? We'll cover gram-positive coverage. We are only covering gram-negative. So what are the antibiotics which we cover for gram-positive? Third generation cephalosporin. Next. Beta-lactams. Everyone is saying gram-positive bacteria, third gen. You could see the report at least. Someone had said penicillin. Other than penicillin, what would we give for gram-positive bacteria? For Staph aureus, what you would give? Or MRSA, you have said methicillin. If it is methicillin resistant, what is the drug of choice? Vancomycin, very good. You could see here vancomycin. So, vancomycin is gram-positive bacteria. Methicillin is gram-positive antibiotic. Next antibiotic, if it is even vancomycin resistant Staph aureus. Linezolid, you could see there, linezolid. Linezolid is gram-positive antibiotic. So this Staph aureus, first thing what would you see? Methicillin. So could you see any disc which is showing methicillin or which is resembling methicillin? So you have to see whether this Staph aureus is methicillin sensitive Staph aureus or methicillin resistant Staph aureus. Initial thing which we would see. If it is methicillin sensitive, it would be easy or it would be difficult. So MSSA, is it MSSA or MRSA? Anyone, at least say for me that is it MSSA or MRSA? I'll leave there. MRSA, someone is saying it is MRSA. How did you say this is MRSA? Oxacillin screen, it is showing resistance. So for the methicillin, what antibiotic which we are seeing? Oxacillin. So oxacillin is showing resistance, so possibly this could be MRSA. What is the drug of choice for MRSA? Vancomycin. So what is the vancomycin here? Resistance. So what is it? From MRSA? VRSA, vancomycin resistant Staph aureus. What is the next antibiotic which we would see? Linezolid. What is it reported here? So linezolid is sensitive. So what is the pneumonia he is having? Patient is having syndrome of pneumonia. Yes or no? You forgot the syndrome. Only you remembered VRSA. So syndrome is pneumonia. So patient is suffering from Staph aureus, which is gram-positive, which is reported as VRSA. So patient is suffering from vancomycin resistant Staph aureus pneumonia. So what is the drug of choice? Linezolid. If linezolid would have been resistant here, what is the drug of choice? Daptomycin would you give for pneumonia? Sir is laughing there, Nirin sir. Madam is saying something. Yes, the daptomycin is inhibited by pulmonary surfactant. So it is not the drug of choice for pneumonia. If anywhere is there the infection, the drug of choice is daptomycin. But for linezolid resistant Staph aureus pneumonia, what is the drug of choice? Are there any other antibiotics which you could see here? Someone is saying doxycycline, if I am not wrong. We could see tigecycline, we could see tetracycline. Tetracycline is sensitive. Doxycycline also is sensitive. Would you give rifampicin? Rifampicin will work or not for Staph aureus? How many will give rifampicin for pneumonia? You'll follow the report, no, it is showing sensitive. I'll write rifampicin, what is wrong in it? 5 to 10 days of rifampicin, he will get out of from it. So we'll leave it here. The VRSA drug of choice is linezolid. If it is linezolid resistant Staph aureus, anyone have heard of ceftaroline? So ceftaroline is also MRSA antibiotic. Cefepime doesn't work for gram positive. Cefepime has good gram negative coverage, but less gram positive coverage. 4th generation has less. 5th generation again has gram positive lesser than 5th generation. So 5th generation has more gram positive coverage than 4th generation. Ceftaroline, ceftibiprole are the drug of choice. So what is the second case? So someone is having abscess. The sample has been taken from the nasal sample. So what is the bacteria which we have got from the nasal sample? Is it gram positive or gram negative? Gram negative. So what is the first antibiotic you would see for a gram negative patient? Piperacillin tazobactam. Next. What is piperacillin tazobactam in here? Sensitive. Next. Before piperacillin, what would you see? Smaller antibiotic than piptaz. First which we could, everyone forgot ceftriaxone from community. Everyone is directly giving piptaz. So what is ceftriaxone showing here? You could see here, cefotaxime, ceftriaxone, cefepime, everything is not ceftazidime, cefotaxime, ceftriaxone, cefepime. Here, ceftriaxone, cefepime, everything is resistant. So if it is ceftriaxone resistant, what E. coli it is? Previously we have learned the terminology. So what E. coli it could be? ESBL E. coli. So what is the drug of choice for ESBL E. coli? The report is helping you. So how cefoperazone sulbactam. Okay, what is cefoperazone sulbactam here? Sensitive. Next, your favorite drug. Piptaz. Piperacillin tazobactam is sensitive. So this patient is having ESBL E. coli nasal abscess. What is the drug of choice? Piptaz, piperacillin tazobactam or cefoperazone sulbactam. So the case 3. What is the sample here? Urine. What is the organism? Klebsiella. So possibly patient is having urinary tract infection. So what type of Klebsiella it is? What would, Klebsiella is gram positive or gram negative? Gram negative. So what is the antibiotic first thing you would see here? Ceftriaxone. So what is ceftriaxone showing here? Resistant. So it is ESBL Klebsiella. So next, what is the drug of choice? BLBLI, that is piptaz or cefoperazone sulbactam. What is it showing there? Piptaz is resistant. So it is more than ESBL. So next, what would you see if piptaz is resistant? Carbopinamase. So meropenem is resistant. So it is urinary tract infection with Klebsiella pneumonia with carbopinamase resistant Klebsiella pneumonia. So what is the drug of choice for carbopinam resistant Klebsiella pneumonia? I think I have previously said this. Ceftazidime avibactam. So what is ceftazidime showing here? We are having ceftazidime or not? So they didn't test for ceftazidime. So if ceftazidime is shown as resistant, what would you add in it? What is the disc would you add? Avibactam, if ceftazidime is resistant and if you are adding avibactam, it is showing as sensitive, so it is carbapinamase resistant Klebsiella pneumonia. If it is resistant to ceftazidime avibactam, then what is the drug of choice? Sir also has helped you. You think aminoglycoside is also resistant? I think it is extensively drug resistant, not even extensively, pan drug resistant. Phosphomycin is also resistant. Not in this report. If I am saying everything is resistant, what is the drug of choice? Monobactam, what is the monobactam? Azithromycin, plain azithromycin, or you have to give it something? Azithromycin, avibactam. If we think azithromycin, avibactam also is resistant. What are the most common mechanism of resistance in Klebsiella? Why we are adding avibactam or why we are adding sulbactam, everything. The most common mechanism of resistance is enzyme mediated. So we are killing the enzymes. If we are thinking enzyme mediated, more than that, what could be the other mechanisms of resistance? Efflux pumps and loss of pouring channels. Think this Klebsiella is working with pouring channels or efflux pumps. Azithromycin avibactam is resistant. Even ceftazidime avibactam is resistant. So then what would be the drug of choice? High dose of meropenem is already resistant. Meropenem, even ceftazidime avibactam is resistant. Tigecycline doesn't work for blood culture. If patient is in sepsis, in blood tigecycline won't work. Clindamycin will not work for Klebsiella. Cefiderocol is the drug of choice which is not available in India. Upper, patient is in septic shock. If it is lower, phosphomycin is sensitive. We could give phosphomycin. Everything is resistant. Do we have any drug which is produced only in India? I am saying everything is resistant, sir. If we do BMD, colistin is also resistant, phosphomycin is also resistant. Even the newer antibiotics, ceftazidime avibactam is resistant, azithromycin avibactam is resistant. The normal resistant pattern which we are seeing enzyme, that is also resistant. It is working in pouring channels and efflux pumps, then what could be the drug of choice? Cefiderocol is not available in India. Sir is helping there. Cefepime zidibactam is the drug of choice for pan drug resistant Klebsiella. Cefepime zidibactam. So this is carbapenem resistant Klebsiella pneumonia in urine, urinary tract urosepsis, which could work with ceftazidime avibactam. So we'll move into next case. So what is it? A swab. Think of about wound swab or something like that, cellulitis. So the organism is Pseudomonas aeruginosa. What is the organism there? Gram positive or gram negative? Gram negative. So what would be the antibiotic you would see? Ceftazidime is, what is it showing here? Next piptase, what is it showing? Sensitive. Next amikacin, what is it showing? What is tigecycline showing? If tigecycline is sensitive, how many would give tigecycline to a Pseudomonas patient? Madam has helped you. Tetracyclines are intrinsically resistant to Pseudomonas. So they are not the drug of choice if you are thinking Pseudomonas. Whenever you are escalating an antibiotic, you would escalate, next we will escalate to tigecycline or that. Keep in mind, if you are thinking of a Pseudomonas or a hospital-acquired infection, if you are thinking most common organism in our hospital could be Pseudomonas, please don't escalate to tigecycline if you want to cover Pseudomonas, because it is intrinsically resistant to Pseudomonas. This is very easy for you. Piperacillin, it is showing sensitive. For Pseudomonas, it's not like Klebsiella. Whatever the phenotypic test is showing, if it is showing sensitive, because what is the most common mechanism of resistance for Pseudomonas? Efflux pump and pouring channels are the most common mechanism, not enzyme mediated. So we couldn't rely on genotypic testing. For it, phenotypic testing, that is the Vitek report, whatever shows sensitive, we could give it. So next organism, what is it? What is the sample you are seeing? ET suction. So what is the organism? Acinetobacter baumannii. So it is gram positive, gram negative, gram variable. Gram variable. We'll think of gram negative. So what is the most antibiotic you would see here for gram negative? Start from ceftriaxone. Ceftriaxone is piptaz. Piptaz is resistant. Sulbactam. Cefoperazone sulbactam. Meropenem. So it is carbapenem resistant Acinetobacter baumannii. What is the drug of choice? You could see there. Colistin. Next, how would you treat carbapenem resistant Acinetobacter baumannii? With single drug, with dual drug, with triple drug? The site of infection, I think everyone knows. Ventilator associated pneumonia. ET suction you are seeing, ventilator associated pneumonia with carbapenem resistant Acinetobacter baumannii. What is the drug of choice? Piperacillin is resistant here. Carbapenem resistant Acinetobacter baumannii. Colistin is one drug. You will treat with single drug or we will treat with dual drug, Acinetobacter baumannii. How many will treat with single drug? So we should treat with dual drugs. So the drug of choice for carbapenem resistant Acinetobacter are colistin, minocycline, high dose sulbactam, plain sulbactam, not cefoperazone sulbactam, plain high dose sulbactam. Yes, sir, triple drug, that's what I was saying. Colistin, minocycline and high dose sulbactam. Those are the drug of choice for Acinetobacter. Triple drug. You will initiate with dual drug, patient is not responding, triple drug. For Acinetobacter baumannii, the better thing is to initiate with triple drug combination. So for antifungals, antifungal also has susceptibility report. You have to see what type of antifungal it is, what are the groups of antifungals available and what is the bug. So don't give everything liposomal amphotericin B. You could see in this report what is amphotericin B shown here. Amphotericin B is intermediate. So for everything, amphotericin B is not the drug of choice for any fungal infection. Amphotericin could be intrinsically resistant or it could develop resistance. Keep in mind. Okay, see if everything is showing sensitive, how would you select? You see, this is a blood culture from E. coli. You will select meropenem, imipenem, amikacin, gentamicin. How would you select? Everything is sensitive. So what is the drug of choice? Think patient is not in sepsis. He is just having blood culture showing E. coli with pneumonia, you can think. The syndrome is pneumonia. So every antibiotic is sensitive. How would you select? So if every antibiotic is sensitive, everyone says you will select with. So if everything is sensitive, there is something called therapeutic index. It is calculated as susceptibility breakpoint by current MIC. So breakpoint by MIC is required to do, not only seeing the report, just seeing MIC, we can't give a drug, whether it is, even if it is sensitive. So these are the learning points. Whenever selecting an antibiotic, pharmacokinetic property of drug and lipid solubility should be seen. Site of action should be seen. Daptomycin doesn't work for pulmonary, so site of action is very important. Spectrum of antibiotics, does it cover gram positive, gram negative, everything should be seen. Thank you.
Thank you, ma'am. Thank you for your excellent and insightful presentation. Now I request Senior Physician Dr. Nagaraju sir, Retired Professor Medicine, Karnool Medical College, Karnool, to present memento to the speaker.
నెక్స్ట్ చైర్స్ రెడీ. చైర్స్ కావాలా? భవానీ ప్రసాద్ సార్ సార్ టాపిక్ ఏమైనా చైర్స్ కావాలి చైర్ పర్సన్స్కి. ఓకే.
Move on to the next session. I request Dr. Devanand sir, retired professor of medicine, Karnool Medical College, Karnool, and Dr. Ravi Kalada Reddy sir, professor and HOD, General Medicine, Vishwabharati Medical College, to kindly chair the session. It gives me great pleasure to invite Dr. G. Bhavani Prasad sir, retired principal, professor and HOD, Karnool Medical College, Karnool, to deliver his talk on approach to fever.
Introduction of the It's a great honor to introduce Dr. G. Bhavani Prasad sir, who is my teacher as well as my mentor. Sir's educational qualification, both MBBS and MD from Karnool Medical College. Present designation, Professor Emeritus, Department of General Medicine, Karnool Medical College. And he is the Vice President, Karnool Heart Foundation. Areas of interest, management of diabetes mellitus. Awards and achievements. Sir retired as additional DME and Principal of Karnool Medical College. Best Doctor Award last year from Dr. NTR University of Health Sciences, AP. And Best Doctor Awardee for 3 times by District Magistrate, Karnool. Sir, we welcome sir. Thank you.
Good morning, ladies and gentlemen, my teachers, my professor, and my colleagues, and my postgraduates. It gives me an immense pleasure to share some of my thoughts about the fever, which is a dynamic chapter for any physician in their life. So I will try to introduce some of the important points. This is Dr. Ramasubbayya Garu, a great physician of Anantapur. When I worked as a house surgeon in 1978 at Anantapur, who has inspired me. And the way his style and smile and the way he approaches. So he told that you should become a physician in 1978 before I joined my MD General Medicine. A great professor and recently passed away and paid my tribute to by attending his funeral. A great physician. Of these, by far the greatest and by far the most terrible is the fever. Now this is William Osler. The way he quotes about this particular thing, you can imagine how difficult to treat a patient of a fever. It is a dynamic challenge for any physician to have this sort of management of the fevers. Acute fever is an elevation of the core body temperature above the daily range and is one of the most common presenting complaints to the physicians in primary care and outpatient departments in anywhere in the world. It has a wide spectrum of differential diagnosis from infections to non-infections. Now you can see the thing that all the fevers, and the 33% is shared by the infections, and 25% is shared by the neoplasms, and 13% is shared by the connective tissue diseases. So, which the problem that we are having, we will see the thing. The fever versus, before going to the fever proper, a fever versus hyperthermia, these are the two words that we will come across. So fever is an elevation of the body temperature that exceeds the normal daily variation and occurs in conjunction with increase in the hypothalamic set point. So hypothalamus is having a thermostat mechanism that I will show you in the next slide. So whereas an hyperthermia is characterized by uncontrolled increase in the body temperature that exceeds the body's ability to lose height, the setting of the hypothalamic regulatory center is unchanged. In contrast to fever, in infections, the hyperthermia does not involve the pyrogenic molecules. The exogenous heat exposure and the endogenous heat production are two mechanisms by which the hyperthermia can result in a dangerously high internal temperatures. The pathogenesis of the fever. So anyway, the pathogenesis of the fever, the infection, the microbial toxins, the mediators of inflammation, immunes, all the pyrogenic cytokinins, interleukin-1, interleukin-6, tumor necrosis factor, and entering the hypothalamic endothelium stimulate the prostaglandins and keep the thermostatic mechanism of the hypothalamus at an elevated point. And if you keep the thermostatic mechanism of the hypothalamus at elevated, now you have to reach that temperature means that you have to put in a vigorous rigors, the way the patient is having in a rigors, and he tries to improve the temperature as though it is in a normal one, and if it is approximately 101, so the patient will have a severe rigors until he reaches the 101. So the classification of the acute fevers may be acute febrile illness due to the localized infections with the system-specific signs. So the patients will come to you with a fever and some of the important specific system symptoms. So where you can find it out that where is the focus of sepsis. So the patient is having a respiratory tract infections, cough and dyspnea, and urinary tract infections, dysuria, hematuria, intra-abdominal infections, the abdominal pain, diarrhea and vomiting, and subcutaneous tissue infections, abscess and cellulitis. That means you are now reasonably sure from where the infection is coming. But now the second time is acute undifferentiated febrile illness. This is recently coined the term as acute undifferentiated febrile illness. This is having an acute onset of fever of more than 101 from 2 days to 40 days without organ system specific signs at the onset. So this category of the fever is undifferentiated fever, having from 2 days to 14 days of 101 temperature without organ specific symptoms. The fever of unknown origin, so that defined as a fever of 101 for more than 21 days that remains undiagnosed after hospital workup. So these POs, now we are not going to allow any patient present days to have 21 days of a fever, and definitely we are having all the investigations at our site, and usually we will try to clinch the diagnosis before the thing. But for the definition, if the patient is having 21 days of fever still, so it are the very dangerous conditions that the patient may be having. So the malignancy, the colorectal cancer, the leukemias, and the rheumatoid arthritis, systemic lupus erythematosus, Crohn's disease, sarcoidosis, and vascular syndrome. So these are the only where you may be finding a difficulty to reach in 21 days. But otherwise, most of the times, we'll be reaching the diagnosis. Now I will talk about acute undifferentiated fever. So I told you acute undifferentiated fever means the temperature is more than 101, and the temperature is between, the days is between 2 to 14 days. So you, without an organ specific symptoms. So this is the particular problem that we will come across. Most of the times the acute febrile illness most of the times there is classified as malarias and non-malarias. So now everywhere the malaria is a standard drug or a standard disease that we will know in the latter part. And the viral diseases, the arboviruses, dengue fever, chikungunya, Zika virus, and Japanese encephalitis, and influenza viruses. the bacteria, the enteric fever, and the Staphylococcus aureus and E. coli, and the zoonotic diseases. Now they are going to take in a big burden, the spirochetal organisms and the leptospirosis, scrub typhus, and murine typhus, and spotted fevers. And the parasitic one is the hepatic amoebiasis. So these are the undifferentiated fevers. Now how you find that out? So any fever, that most important thing is the patient evaluation of the medical history of the patient. This is a very important, the history taking is a very important item, and a thorough clinical examination from the head to toe, and evaluation of the clinical features and assessment of the disease severity, and perform the diagnostics. So these are the 4 headlines which we'll be having. So the review of the past history, previous fevers or infections that the patient had, and the known conditions that increase the infection risk, and assess the patient-specific factors, especially the age, the immunosuppression, the pregnancy, and the comorbidity conditions like diabetes, kidney disease, malignancy, autoimmune diseases. So you have to take a detailed history where you are landing the proper diagnosis. A thorough clinical examination of the patient is a preliminary examination should involve the assessment of the respiratory rate, hydration status, mental status, and oropharynx, conjunctiva, skin, chest, heart, and abdomen. That means you are checking from head to toe. And the review of the systems that you should make it, that the review of the systems include the seizures, the headache, the sinusitis or meningitis giving any clue, nose or congestion, cough or wheezing, pneumonia or bronchitis, ear pain, waking in the night with the signs of the discomfort, otitis media, and the abdominal pain, especially the gastroenteritis and abdominal abscesses, the back pain, especially the pyelonephritis, and joint swelling, redness, and osteomyelitis. So what we want to tell is the clinical examination of the patient is a very pertinent where you have to, if you are missing something, then we are missing the entire gamut of the diagnosis. So the malaria, so an acute onset of high-grade intermittent fever, paroxysms of fever, shaking, chills, sweats, and the patients may be having a benign tertiary malaria or maybe repeating 72 hours depending upon the species. So the manifestations may be a severe malaria may manifest within various spectrums of the diseases like cerebral malaria, severe anemia, metabolic acidosis, acute renal failure, ARDS, and shock. So a standard where the malaria will be presenting. Now going to the dengue, this is an acute onset of a high-grade continuous fever of the onset of the symptoms, and usually a dengue fever, 80% of the patients will be having a spontaneous recovery where the dengue fever may be having from 2 to 7 days, where having a headache, retroorbital pain, the myalgia, arthralgia, sometimes may find out in a leukopenia, thrombocytopenia, or no evidence of plasma leakage. So a general mild dengue where we may not have much of the things except that the patient may be having a leukopenia. And if the patient goes into the next stage, if dengue hemorrhagic fever, the criteria of the DF plus a tourniquet test. So if you do the tourniquet test, put the BP apparatus between the systolic and diastolic and maintain for 5 minutes, and in the square inch area, if you have 10 spots, that you are having a tourniquet test positive, and the evidence of plasma leakage. This is something that the sonologists always, they will tell you that the patient is having a bilateral pleural effusion, and ascites always indicates that the patient is having a plasma leakage. And thrombocytopenia with a platelet count less than 1,000 and hematocrit rise more than 20% over the baseline. This is a very important thing that every physician, when they are treating the patient, they must have a chart of a hematocrit. What is the hematocrit today? What is the hematocrit in the evening? Next day like that. A rising hematocrit is a very dangerous sign. Because this is the patient suddenly will collapse, then we will be in a most difficult situation. And the DHF2 second category, if you go, the patient will have some evidence of spontaneous bleeding. The bleeding may be coming from the eyes, bleeding coming from the gums, or the patient having a melena. So always you look up at the patient is having a bleeding symptoms. And the patient may be going into dengue hemorrhagic fever, 3rd grade, where in a dengue shock syndrome, very difficult situation, and where the patient is having a narrow pulse pressure. A narrow pulse pressure less than 20 mm is a very dangerous sign. Once again, you must maintain a chart about the pulse pressure and see that where the patient is going on. Because there are certain clues where the patient will be having, because in a dengue shock syndrome is a very difficult situation, and whatever the inotropes that we are having, still we find out difficult to manage. And I have lost my friend's daughter who was an intermediate with a dengue shock syndrome in spite of shifting to Hyderabad and making so much of the thing. So allowing the patient to take a dengue shock syndrome is a very dangerous sign. So where you find out some of the important clues that the patient is having. And now the dengue, that is the thing that the patient is having a high grade temperature, a very resistant temperature. You put the patient on a paracetamol, which is a weak antipyretic drug, the temperature is not responding. That gives you a clue that am I dealing with a dengue. And for the 3 days where the patient will have a very high temperature, and now the potential clinical issues or the dehydration when the patient temperature is 40 degrees, and the patient may land in a shock, bleeding, and organ impairment. These are the dangerous signs that the patients may be having in the course of the dengue. And the laboratory changes, now I already told you. Now the hematocrit. Now you can see the hematocrit one. Oh, sorry. Samar. The pointer I couldn't. That's okay. ఇక్కడ పాయింట్ ఇది ప్రెస్ చేస్తుంటారు సార్ ఇది సార్ ఓకే సో నౌ యూ కెన్ సీ ద potential issues of dehydration and shock and bleeding and organ impairment. They are very, very dangerous thing. Now the laboratory, already I told you, you must have a diagram like this, the hematocrit. Now how the hematocrit is rising, giving you a dangerous signal that something is happening. Now at the same time, you can see the platelet count, how drastically the platelet count is going on like that, and slowly they are recovering. And the serology is a very important test where the patient is having an viremia in the first 3 days, and slowly the IgM and IgG are raising. So always when you see in a rapid test, you will find out the NS1 antigen, which is a detector from the day one, and a high specificity of 98% detected by ELISA rapid diagnostic test, detected in saliva and urine, cannot differentiate serotypes. So what are the warning signs that you are having? The abdominal pain or tenderness, the persistent vomiting, the clinical fluid accumulation, I had told you already, bilateral pleural effusion and ascites, a mucosal bleed, and lethargy or restlessness, and the liver enlargement more than 2 centimeters, and the laboratory increase in the hematocrit. Always the hematocrit is coming with a rapid decrease in the platelet count. They are the warning signs where you must be careful of the thing. Factors favoring the hospitalization. So always dengue doesn't mean that it requires an admission. As I told you, 80% of the cases will have a spontaneous recovery, but you must fulfill some of the important criteria, having an ascites and pleural effusion, abdominal pain and vomiting, mucosal bleeding, increased hematocrit, and decreased platelet count to 30,000. Dengue in a pregnancy must be admitted, and the patient having a renal failure must be admitted. And sometimes the family concern and anxiety we should understand. Patient with a fever and leukopenia must be tested for a dengue. So because whenever the patients are coming, we will order for an CBP and see that immediately that is a leukopenia is there. So treating any patient of fever without doing a complete blood picture is a sin, because you don't know what is happening, and you try to say that it may be that the patient having a viral fever. Really we may land in a danger. So don't treat any patient of fever without undergoing the CBP. So what not to do in dengue? What not to do in a dengue? So what to do in a dengue? I don't have any specific disease for a viral thing. So I try to protect the patient and allow the nature to take its course. And definitely if I don't do any harm to the patient, definitely the patient is going to survive. So what not to do in dengue? Do not use non-steroidal anti-inflammatory drugs because they are impairing the platelet function. Do not use IM injection. Do not use steroids. Do not use antibiotics. Do not use a 5% dextrose, it is not a volume expander. Do not use nasogastric tube. Do not use papaya thinking they may produce some sort of a gastritis, much more problem. Do not use a central cannula. Do not go for the early intubation because you may land in a problem. Do not transfuse platelets prophylactically. Now you come coming to the chikungunya. So post-seasonal thing that the patient is having a high-grade continuous fever, rash, malaise, arthralgia, myalgia. But sometimes this sort of the patients also may be going for a respiratory failure, meningoencephalitis and acute hepatitis, but it is a self-limiting disease. Leptospirosis is an acute onset of a disease once again, a moderate to high-grade continuous fever, and this leptospirosis having two important categories. One is an icteric leptospirosis, and number two is an icteric leptospirosis. So anicteric leptospirosis is an abrupt onset of fever, chills, headache, and myalgia, abdominal pain, conjunctival suffusion, and a transient skin rash. Number two is the icteric leptospirosis. The patient is having a jaundice, proteinuria, hematuria, oliguria, and uria. These were the problem maybe sometimes we may be facing. Now you find out these are the cases of infective hepatitis, and then you may miss the thing. So what is the difference between infective hepatitis and leptospirosis-induced jaundice? Leptospirosis-induced jaundice always will have a leukocytosis and the renal involvement. The patient is having a proteinuria, and this renal impairment always clinches the diagnosis that whether you are dealing with an infective hepatitis or the jaundice of a leptospirosis ictiohemorrhagica. The pulmonary hemorrhages, ARDS, and myocarditis complications are also will be seen, where the patients may be having some conjunctival hemorrhages. A scrub typhus is now the presently talking the thing, and anyhow, our next speaker is also going to talk about the scrub typhus, and just I will push through the thing. And the patient is having a headache, fever, headache, myalgia, breathing difficulty, delirium, and overwhelming pneumonia with ARDS-like presentation, hepatitis, aseptic meningitis, myocarditis, and disseminated intravascular coagulation. As nowadays news are everywhere that is coming with a scrub typhus, definitely we should know about it, and the next speaker may be putting the thing, and you find out that in a typical eschar tissue necrosis, almost in a diagnostic point, doesn't mean that every patient should have an eschar to make a diagnosis. And enteric fever, so the patient, the first week, the patient is having a fever, headache, and relative bradycardia, which we not going to see the patient like that to find out the relative bradycardia. And in the second week, the patient is having an abdominal pain, diarrhea, constipation, hepatosplenomegaly, encephalopathy. These are the second week where the patient is having. And the third week, intestinal bleeding, perforation, and multi-organ dysfunction syndromes. So now the preliminary investigation test, what we are going to clinch the diagnosis. Once again, I am telling you the hematocrit. A rising hematocrit is diagnostic of a severe dengue. Leukocytosis, once again I am telling you that in a leptospirosis, the patient is having a severe leukocytosis, a very important clue that what we are having. And leukopenia occurring early in the illness and associated with thrombocytopenia is suggestive of a dengue fever. Lymphocytosis may be seen in rickettsial diseases. Thrombocytopenia, many of the times we'll come across, thrombocytopenia may be seen in all common undifferentiated fevers, a poorly discriminated value, but if the patient is having a thrombocytopenia with splenomegaly, you are dealing with a malaria. But if you are dealing with a thrombocytopenia with a bleeding, you are dealing with a dengue. The peripheral space sometimes may give you a malaria, filariasis, can be make a diagnosis, and a complete urine examination. This is once again the proteinuria and hematuria seen in leptospirosis. It gives you a hint, because where you find out a clue for an underlying diagnosis, we don't know, but unless you carefully monitor all these sort of the things, then only you will find out the clue. The liver enzymes, they are raised in several undifferentiated fevers, so no diagnostic value. But sometimes in severe dengue, they may be rising about more than 1,000 also. The bilirubin, so the bilirubin, once again, a raised bilirubin plus modest rise of transaminases, and the raised CPK is a diagnosis of leptospirosis. So you must have the thing, but there is an every chance that you may go on the out of track thinking that the patient is having an jaundice, mild elevation of the transaminases, and you may go in the wrong way. And the renal function test, acute kidney injury is common in malaria, scrub typhus, and leptospirosis. Any tropical country, the patient is having a fever with a renal impairment, must be thought of a malaria unless proved otherwise. The chest X-ray, the scrub typhus pneumonia is most common systemic involvement. The bilateral opacities progressing to ARDS may be seen in a scrub typhus, leptospirosis, malaria, and pleural effusions may be seen in the dengue. The ultrasound of the abdomen, once again the ultrasonologist, when I write the patient ultrasound, immediately he writes ascites, pleural effusion, gallbladder edema, associated with severe dengue. He himself writes the viral hemorrhagic fever, the diagnosis. So only the thing is, you may find out something somewhere, some investigation to find it out. And acute acalculous cholecystitis and acute pancreatitis has been reported in all cases of acute undifferentiated fevers. The malaria, we are having a rapid test, and also you may find out a smear, a diagnosis of the malaria. But if the patient is having a rapid diagnostic test also negative and also the peripheral smear negative, always it is the clinical judgment. A common disease is common first. An uncommon manifestation of a common disease is the second. So always we lie on this sort of the malaria to start the treatment for this sort of the patients. And the dengue, so always now we are having a rapid test, make the diagnosis much more easily. And the scrub typhus, once again you are having a rapid diagnostic test and ELISA test, or the patient may be confirmatory test, Wheels-Phillips reaction, or the patient immunofluorescent assay, IFA test may be done, but usually current gold standard expensive one. The leptospirosis, once again the rapid test may be there, and the IgM ELISA is there to confirm the diagnosis of leptospirosis. In all these sort of the patients, we are having a mechanism by which the doxycycline, because doxycycline is one of the important drugs that I'm using in all these sort of the fevers, the anti-inflammatory and the immunomodulatory effects. So the doxycycline is having a special action of an anti-inflammatory and immunomodulatory effects. It down regulates nuclear factor kappa light chain B pathway and it decreases the release of the cytokinins. And I showed in the first slide how the cytokinins are very aggressive in producing this sort of a thermostatic mechanism. The matrix metalloproteinase inhibition inhibits the MMP2, and antiviral drug activity inhibits the dengue virus replication. So always in leptospirosis also, and doxycycline 100 milligrams twice a day for 7 days, or pregnant or lactating woman should be given an ampicillin 500 milligrams 6 hourly. But nowadays the problem always comes when the patient is coming and we admit the patient he doesn't want to have all the sciences that I am teaching. Now what he wants is that, sir, my son should be all right. So what I have to do when I am not able to identify the organ involvement? So always a third generation cephalosporins and the doxycyclines covers the rickettsias, leptospirosis and enteric, because sometimes we are forced, because I cannot wait for science to make a diagnosis because the patient is suffering. A doxycycline with an artesunate always will give it for malaria. And empirical, if sir, I am staying in a primary health center, what drug you want me to give for this sort of the patients? Always I suggest you that you give a doxycycline. So whenever you are approaching the fevers, so you must remember the age of the patient, the height of the temperature, the severity of the illness, the presence of a focus of infection, and white blood cell count. So the height of the fever more than 40 degrees indicates the patient is having a severe fever, where we have to bend our head to find out what is exactly the cause. The toxic appearance, the patient, the way he comes in front of us, having a high grade fever, lethargy, evidence of poor perfusion, cyanosis, hypoventilation, hyperventilation, tachycardia, all these sort of the things must be taken into the count. And the white blood cell count is always gives you a definite thing, but it is not that 100% correct, if more than 15,000, but it definitely gives a clue what is happening. An elevated WBC therefore is reasonably specific, but not sensitive for an infection. So high-grade fevers, what are the high-grade fevers that once the patient coming to the casualty, you should find out. The patient may be having a meningitis, encephalitis, sepsis, malaria, or viral hemorrhagic fevers, or a neuroleptic malignant syndrome. All the important causes of the high-grade fever you have to keep in mind. Now this is a Vidal test, so always it should not be done before the 1 week, and even if it is positive before 1 week, it is a false positive. A single Vidal test has no value, and a negative Vidal test has having a good predictive value, and a typhoid dot test that has come of an immunological is relatively better compared to the Vidal test. So what we want to tell you is that the way the patient come and you try to order for a Vidal test, now you are landing in a very big situation where immediately the technicians gives you 1 in 80 positive. So then the patient will ask, sorry, my son is suffering from a typhoid fever. And you will tell that, no, this titer is not a big titer, and so don't worry about it. But the mother will not live like that. Sir, now the doctor is told it is 180 positive, and he says that not to be worried, I am worried. Because of these worries, if you do a Vidal test, you are landing in a problem. Never do the Vidal test in the first week. Even if you, why all this sort of scrub typhus and the newspapers are coming with a big thing? Because of you make a diagnosis of Vidal positive and forget the dangerous diagnosis of scrub typhus, and then who has to hold the responsible? From the time immemorial, this Vidal test even done in all the labs, and the labs never test whether the patient is in the first week or not, and immediately write it, and the second day, third day, immediately they will write it, and immediately lab diagnosis job is over by giving you 1 in 80 positive, slightly pregnant. So this is something that is happening. Please don't do this sort of the thing. As a physician, we land in problems. A fever with the shaking chills, the patient gives you some amount of evidence where the patient is having a pneumonia, abscess, or pyelonephritis, or filariasis, there the patient will be having. Fever lasting more than 4 to 7 days is rarely due to self-limiting disease. The patients will come to us and ask us, sir, is there any problem that my son is having a fever? Most probably nothing will happen, and it must be, appears to be a viral fever. But the 3rd day, 4th day, but then what do we have to do? So always, if the patient is having a 4 to 7 days, rarely due to self-limiting, and it needs investigation. So you must be careful, the patient may be having. And a fever lasting for more than 2 weeks indicates a serious underlying problem and needs a thorough investigation. So this is something that you should find it out. A fever in alcoholic patients, a delirium tremens, hepatitis, and the important causes may be there. The life-threatening infections associated with diabetes is rhinocerebral mucormycosis, malignant otitis media, and emphysematous cholecystitis, and emphysematous pyelonephritis. So now you can see any uncontrolled diabetes coming with a black coloration around the eye. Always you should make a diagnosis, even for the first time, that mucormycosis. And now you can see that the patient is having an emphysematous pyelonephritis. You can see the kidney this side, that side, and where the patient is having an emphysematous pyelonephritis. So the fever in the intravenous drug abusers, the HIV and infective endocarditis, and the fever in adults. This is something just I will take in 1 minute. And the patient, apart from the investigations, that you must consider the TSH, ANJ, and the ANCA and HIV virus. So we had a big problem where the patient had a fever of 21 days of fever, never touched at any given point of time of baseline, and the patients are exhausted and having a CT scan from the CT brain, CT chest, CT abdomen, what not, all the blood cultures and every investigations are proved. The patient is exhausted and really we don't know what we are having. And when we are struggling, suddenly, when we carefully examine, suddenly I find out the patient is having a goiter. And then I sent the TSH, that was the case of a thyrotoxic crisis. So what I want to tell you is, in the life of a physician, we will be teared into pieces because of the complex of the diagnosis of these patients. So when there is no clear indication, they may do an abdominal or pelvic CT scan, and the ESR elevated, anemia, more than 65 years, temporal arthritis, and the biopsy is going to confirm. And if the patient having a liver function test elevation, hepatomegalia, you may have to go for a liver biopsy. A pancytopenia and high calcium, always maybe suspecting of a multiple myeloma where I may have to go for a bone marrow. So WBC, if it is more than 50,000 to 1 lakh, you are dealing with an leukemia or myeloproliferative diseases. So always I will tell you that the patient is having if you look at the peripheral smear, you find out plenty of metamyelocytes, myelocytes, and you find out different pigments. Always I describe as a ladies at beach is a diagnostic of a chronic myeloid leukemia. You don't have the entertainment of looking at the peripheral smear, the present day generation, because we enjoyed the thing, the peripheral smear is a diagnostic of chronic myeloid leukemia. And now you find out all the premature cells. So the lymphocytosis may be there, the pertussis and other things, and also the chronic lymphatic leukemia is one of the important thing where the peripheral smear is studded with all the lymphocytes. Always I describe as in children at convent school. Studded with all the lymphocytes makes the diagnosis of a chronic lymphatic leukemia. Fever with the leukopenia, already enumerated the thing, and ESR having a temporal arthritis, polymyalgia rheumatica, and possibly rheumatoid arthritis, and multiple myeloma, and TB, and collagen vascular disorders, and multiple myeloma. Fever plus jaundice. Fever, if the patient is having a fever plus jaundice at the same time, so that is the clinical problem. The patient is suffering from malaria, cholangitis, cholecystitis, liver abscess, or leptospirosis. Now, if you have a jaundice minus fever, I have told it is jaundice minus fever. In infectious hepatitis, once the jaundice appears, fever subsides is the rule. Please remember this one is single sentence. You must carry in your lifetime. In infectious hepatitis, once jaundice appears, fever subsides the rule. Because you are having a fever plus jaundice, some of the conditions, and a fever, jaundice minus fever, some of the other conditions. Fever plus coma, my postgraduates must be there in the casualty. You must have to make a diagnosis of cerebral malaria, encephalitis, brain abscess, typhoid, and scrub typhus fevers. Fever plus pregnancy, an immunocompromised condition where all the terrorists want to engulf that pregnant woman by way of urinary tract infections and malaria. So fever plus rash, so just I will rush through the thing there. Now fever plus acute kidney injury, that is very important, the complicated malaria, leptospirosis, scrub typhus, and dengue fever. Thrombocytopenia, this is 8 conditions which I have written, you must remember, because every time that the patients will be coming to you with the thrombocytopenia, so whether you are dealing with dengue, malaria, hepatitis B, hepatitis C, HIV, cirrhosis of liver, and ITP and malignancy, must be remembered all the physicians. Anemia plus bleeding plus infection is equal to leukemia. These are very small important clues. A patient referred by the ophthalmologist with a vitreal hemorrhage with a fever, I checked the temperature 101 and the patient, the peripheral smear sent. Immediately my technician told that, sir, this the cell counter giving us that the polymorph 0, lymphocyte 0. Immediately that one immediately recognized that the patient is having premature cells, and we stained the thing. It was an acute myeloid leukemia where I have lost the patient within 24 hours. So fever plus a significant bony ache. So always port spine, paravertebral spasm, paravertebral abscess, and psoas abscess, myeloma, metastasis always has to be thought. Antibiotics contraindicated in pregnancy, always there. We are having a dilemma which antibiotics to be started. So contraindicated is quinolones, fluconazole, sulfonamide, tetracyclines, and chloramphenicol. And relatively contraindicated is the aminoglycosides and metronidazole. And not known to be harmful, but you use it diligently. Acyclovir, cephalosporins, clarithromycin, clindamycin, erythromycin, linezolid, meropenem, penicillin, and vancomycin. So just I will, here is a 19-year-old girl diagnosed to have an infective endocarditis because she had a fever, pallor, and a systolic murmur. Repeated cultures were negative, and she did not improve with antibiotics given for subacute bacterial endocarditis. After 4 weeks, she was skin and bones and febrile. That time, once again, I have taken a repeat X-ray. Now you see that what is happening. What I want to give in a message is, the patient comes early, you take an X-ray test, it may be normal. If the patient is having a fever of a 10 days duration, please repeat the X-ray test. Definitely you will land in an biliary tuberculosis, where a common disease affecting any system. All diabetic patients must be screened if a complaint of cough is present, and all patients of tuberculosis must be screened for an HIV. A 45-year-old man returned from Mumbai, where he was working as a taxi driver for the past 12 years. He was admitted with a low-grade fever and cervical lymphadenopathy. He was undergoing treatment from various hospitals for irritable bowel syndrome since the last 6 months. Now you see the thing, a ground glass appearance of the lungs, and where the patient is having an abscess and the bases are clear, the diagnostic of an pneumocystic coronary. So see that this is a very specific thing, that the pneumocystic coronary having this sort of the thing. And having the thing, you find out the ring enhanced lesions of the toxoplasmosis to make a diagnosis of an HIV. A 30-year-old policeman came with recurrent episodes of abdominal pain and abdominal distension, loss of weight and loss of appetite, and had an hysterectomy on 2 occasions. He was weighing only 32 kgs, abdomen was soft, no hepatosplenomegaly, and what was the thing that you find it out? Typical cobblestone appearance and the string sign where you find it out. What I want to tell you is, it is a small clue from the frontal lobe that is coming out, that what might be the thing that the patient may be having, the Crohn's disease. A 45-year-old male present with the fever and lower abdominal pain was admitted to the hospital, and appendectomy was performed. 3 days after the operation, he complained of fever and shaking, chills and headache. After blood culture, treatment with ceftriaxone was initiated, and 4th day developed a change in his mental status. Please remember, that is the thing. One of the laboratory tests we have done where the patient is having some small, definitely the clue is not coming. The diagnostic clues are fever, shaking, chills, abdominal surgery, and confusion. The lumbar puncture and CT scan brain were negative. Now you can see what is happening. The repeated peripheral smear showed that the patient is having a false for malaria. Once again, what I want to tell you is that always remember, a common disease is a common first, an uncommon manifestation of a common disease is second, a rare disease is rarely or correct. So the take-home message, fever plus anemia is equal to malaria, fever plus jaundice is equal to malaria, fever plus renal failure is equal to malaria, fever plus coma is equal to malaria, fever plus ARDS is equal to malaria, fever, anemia, jaundice, renal failure plus coma, multi-organ dysfunction is malaria or sepsis. Thank you very much for your patient hearing, and I might have taken a little extra 5 minutes. So I thought that this is a very important for my postgraduates, where they have to be, so must have that enterprising thing to make a diagnosis and take it as a challenge in your life. Thank you very much for giving me this opportunity to stand before you.
Thank you, sir. Thank you for such practical and clinically relevant talk. Sir. Now I request the chairpersons to present memento to the speaker. Dr. Ravi Kaladar, sir, and Dr. Devanand, sir. Now I request Senior Physician Dr. Bhuva Gopal sir, retired Professor and HOD of Medicine, Kurnool Medical College, Kurnool, to present memento to the chairpersons. Now we start the next session. I request our chairpersons, Dr. Abdul Rahim sir, Professor of Medicine, Kurnool Medical College, Kurnool, and Dr. Rajesh sir, Professor and HOD Pharmacology, Kurnool Medical College, Kurnool, to chair this session.
పిలిచేద్దును. సార్ వాళ్ళకి హ్యాండ్అవుట్ ఇచ్చారా?
Institute of Medical Sciences, Mangalgiri. His areas of interest are antimicrobial resistance, antimicrobial stewardship, neglected tropical diseases, infection control, and biomedical waste management. His achievements are he is an recipient of European Society of Clinical Microbiology and Infectious Diseases funded observerships to Oxford University Hospitals, UK. And he is an awardee of member of National Association of Medical Sciences in 2019. Over to Dr. Debabrata Dash.
Thank you, sir. Till the technical glitch comes out, thank you very much, organizers, and I am very privileged to be here. And a hearty gratitude from AIMS Mangalgiri. We are in a valley, and we are blessed to be in the feet of Lord Narasimha, so blessing us. And when we talk about AMSP, it is 10:51. We are running almost 1 hour and 20 minutes behind the schedule, and in AMSP, timing is important. So, when we talk about AMSP, my topic is AMSP, how could you contribute? Now, I was a bit confused that how could you contribute means what? I messaged Dr. Niren that what am I supposed to tell here? Whether what a microbiologist can do for AMSP or whether the clinician can do for AMSP. He told that, sir, just told what could be the interaction between the microbiology and the clinical persons to check for your AMSP. Now, when we talk about this AMSP, why is this topic in the first hand? Of antibiotic prescription is for your ID specialist and medical microbiologist. You will be surprised to know that medical microbiologist does have OPDs also. Now, when we talk about our country, in our country, anyone can prescribe antibiotic, whether of a medical background or a non-medical background. So our problem is a bit different. Now when we talk about a different in problem, we cannot have the same Mona Lisa that we are or the European countries are so proud of. Meaning to say, we can't have the same guideline as the Western countries. So, we need to change our Mona Lisa, isn't it? We need to modify as we modify the everything for our country. But I apologize, I may get a bit bitter while going to the truth of the situation. Now, what is the antimicrobial stewardship myth that we possess, that there is a threat to clinical autonomy if we practice AMSP, and it is always to curtail the higher antibiotic use. So we think, our mindset is like that we think that we cannot use higher antimicrobial if we are practicing antibiotic stewardship. Now, the statement what we does is, you can see, though we have culture, at least in the medical colleges and corporate hospitals, the culture guided de-escalation were reported in only 24% of cases. This is a case from your report from your China and Thailand. Next is the IDSA. So there is a modifying or behavioral statistics that comes up, and what they come up with is this. Among the many challenges facing ASP is the dilemma of managing the outlier physician. An outlier can be defined as a physician whose observed behavior is markedly different from that peers. Now the problem with us is this outlier justifies their treatment that my patients are different. In my experience, guidelines are non-specific, so on and so forth. And what should we do when the norm is outlier? So we have many minds here. We think in a certain way, and we think that our patient is important, and we neglect the advice given by our peer. So, what is antimicrobial stewardship? When we talk about this, I think of this meme that when we talk about what is antibiotic stewardship, this should come up. Now, what exactly scenario in India? This is TDAP, now it has been renamed as World Health Trust. We are the champions. We are the champions in everything, and we are the champions in producing AMR also. So what can we do? We can do that here. This is a study from the PSEC that training in infectious disease and prescribing antimicrobial drug is insufficient among many of the clinicians. Okay, so to curb that, what we use, and to be in the safe side or the just in case approach, prescribe the broad spectrum antibiotic. Now what does that feel? Now when we talk about this AMSP actually mean this is improving patient care. It is to reduce the collateral damage, and then of course the cost is a factor. Cost can be placed as a business case. But when we talk about this AMSP, anyone or whosoever is talking about this AMSP, we are thought to be the moral policing or antibiotic police, who have unsolicited oversight over their patient. Now, coming to how could you contribute? So what does you write when you write in the present history? To start with, isn't it? So here, to start with, what we can do, make an AMS team or make a AMS leader who has that value of Shaktiman, who can produce or can bring about the change in their colleagues or subordinates. So what first to do? Educate them. Let's face it, when we pass the second MBBS, we rarely read microbiology or pharmacology unless we are doing PG in it. That is the true fact. So, for anything and everything, we used to tell gram negatives means E. coli is similar to Proteus. But that is not the same thing. We have to make everyone understand there is different protocol for different organism. For treatment of bacteremia to treatment of pneumonia, all can be same, but that is not the same, and most don't know is the 5 moments of hand hygiene. We rarely practice these 5 moments of hand hygiene. So before you become a good AMSP steward, you learn to become a diagnostic steward. So what is a diagnostic steward? Anyone? TGTs? I won't kill much time. So, in case of diagnostic stewardship, it is the guidance and intervention to improve the outcome and appropriate use of microbial test in particular and any investigation in general. You have to have some of your differential diagnosis, then only you should go for any test. It is not like that you have a battery of tests and then you are writing everything, and after getting the test you don't know what to do. So on such cases, be a antimicrobial steward and diagnostic steward. Remember this phenomenon, garbage in is garbage out. Anything you are sending, it bound to give some result. It does not necessarily mean that it has the disease. As in the previous talk, sir was saying about the Vidal test. It should have been obsolete by now, but we are using that. Even in the first session, madam was talking about ET aspirate crab, but when to treat crab or carbapenem resistant Acinetobacter, are you seeing a chest x-ray? Are you seeing any CT? Is there any lung consolidation? Or is it a colonizer because it has ET tube and it is open to the environment, isn't it? Now, you need to check what the right sample is. Is it the right patient? Right collection methodology, because we get a lot of your coagulase negative staphylococcus aureus, coagulase negative staphylococcus in blood culture. You need to know what is the order of draw. That order of draw is nothing but which sample to be sent first. Now, talking of the order of draw, just remember that blood culture should be drawn first. So, any sepsis case, any infectious disease, it is the blood culture which should be sent first rather than any other parameter. Now remember some of the don'ts and swabs. Any swabs except throat swab or your high vaginal swab should not be encouraged, because what we get in case of swabs is the colonizer or the common cell of the skin if we take out the swabs. The other things that is important here is in swab, if it is a cotton swab, it tends to inculcate the gram-positive cocci inside its fiber. So even if it is a staphylococcus infection, even if it is a streptococcus infection, you may miss out the diagnosis because it will not be releasing from that cotton fiber. Don't send catheter for culture. Why? And here we mean the Foley catheter. Foley catheter should not be sent for culture, because if you are thinking that Foley catheter is the cause of your catheter associated UTI, you have already removed it. What is the use of sending that culture of the catheter tip? Don't refrigerate the blood, CSF or any body fluid. Don't culture or don't send culture. This is practically not possible, but try to send a microbiological test before starting off the antimicrobials. If it is already been started, try to get sample before the next dose so that the plasma concentration of that antibiotic at the lowest level. Now this one is TRF. Now how many of you are aware of this TRF, test requisition form. Now in test requisition form, again, I beg your pardon, I have to be a bit harsh. When you are sending a biopsy, you are writing everything that patient has gone through. But when you are sending a culture, you are just writing urine. We do not know whether it is a cystitis or it is a pyelonephritis. Blood, we do not know it is for sepsis. The presenting system, whether it is pneumonia or a meningitis. And don't confuse infection with colonization. Now, what next can be done? Start a dialogue. This is very important. Your microbiologist or your microbiology department is just a phone away. Try to get that culture, especially for PGTs, to get along with your colleagues of pathology, microbiology and biochemistry and radiology, so that you can have a discussion on individual test. Know the critical values. What is the critical values? Any organism or pus cells in a CSF is a critical value. Malaria is a critical value. Your gram negative in blood is a critical value. So those you need to remember. Ask for advisory services. What is that advisory services from the microbiology department? What is the drug to be used? You can ask. I will come with that with some reports of ours. Reports of MDRO we have discussed in the preliminary session. Establish AMR recording. You should have your own antibiogram. You cannot rely on some other hospitals' antibiogram. Remember, antibiogram is for empirical treatment, not for specific treatment. So to start with, you need to have an antibiogram and hold regular case discussion. Now, what we did in our centers, a blood culture positive cases of that week we take out and we discuss with the departments that have sent that blood culture to know more about the condition of the patient. Ask for antibiogram, and for microbiology colleagues, never reject a sample blindly. You should have the number of the sending physician, talk with them what exactly made them send that culture. Now we need to have some behavioral changes also. So undergraduate curriculum, persons around 18 to 25 years, then internship and professional training. So when we are talking about establishing an AMSP, we need to practice ourselves as faculty, because student will see and learn what we are actually practicing rather than what is being written in the book. So, and this, it is never-ending procedure. We have to learn and relearn. Now, some of the things that we can do or educate the educated, like Madam took in the first session. Gram positives, what are the antibiotic that can be used? Gram negative, what can be used? And anaerobic, what are the coverages? So this we need to talk. Now, just for knowledge sake, when we are talking about cephalosporin, first generation cephalosporin, better coverage of gram positive than gram negative. Second generation coverage, second generation cephalosporin, again gram positive is more than gram negative. Third generation and fourth generation more have gram negatives, and fifth generation again have gram positive. Now we need to tell what is the MRSA, what is a BRE, what is ESBL, and what is CRAP, because it has some intrinsic resistance. Then we have a set of intrinsic resistance like enterococcus. Why can't we use cephalosporin in case of an enterococcus infection? Because it is intrinsically resistant. So as for cotrimoxazole, we cannot use for enterococcus infection. Similarly for Pseudomonas, so many drugs, and the latest addition is gentamicin. Remember, we cannot use gentamicin in Pseudomonas aeruginosa. Then, what not to be prescribed? In case of urine and blood, tigecycline should not be used.
Time is up, please.
Yeah, so 5 minutes. Aminoglycosides should not be used in case of Salmonella anaerobes, and nitrofurantoin is only for urine. Now one particular thing is MC. MC beta-lactamase producer. You may see some of the blood sample came as Klebsiella or Enterobacter aerogenes, and it was ceftriaxone susceptible. You start with ceftriaxone, but after 3 days, the patient is not responding. There where we need to check about the MC, and in case of this organism, Enterococcus, Enterobacter and Citrobacter, Providencia and Serratia, cefepime is the drug of choice even if your third generation cephalosporin comes positive. Next is your ceftazidime avibactam. So we just not need to know about the carbapenemase, rather than we need to know what are all the organisms, what all the mechanisms for this enzyme production. There are 5 types of carbapenemase. And now the kit is also available because for some of the enzymes, the ceftazidime avibactam may not work. So we talk about this ceftazidime avibactam plus aztreonam complex, or treatment with ceftazidime avibactam plus aztreonam, because in case of metallobeta-lactamase, the dreaded NDM or New Delhi metallobeta-lactamases, the aztreonam is susceptible, but aztreonam in case of NDM, it tend to produce also ESBL, which can eat up the aztreonam. So we are linking the avibactam with the aztreonam. Ceftazidime is the bystander because we don't have avibactam aztreonam as of now. So this is what we can go for, that ceftazidime avibactam class A and class D, not class B only. Ceftolozumab, tazobactam, meropenem, aztreonam and cefepime. I am just keeping it, and I can share this PPT in the group so that you can also have this one. Now what we do actually in our setup, we do have a 24/7 hour microbiology. Anytime anyone can send the sample and the report is being generated. Sundays and holidays we also do reporting. There are 2-tiered reporting. First one is done by resident and then your faculty. We have full automation and we do get your yearly antibiogram. So some of the tests, just 2 minutes sir, I beg your pardon, that this is a blood report. Staphylococcus, I am sorry for the fonts, Staphylococcus aureus, that is MRSA. Now remember, when you are getting Staphylococcus aureus from your blood, it is a descending infection. The seed is somewhere else, and in such cases it is ideal to go for a echo, and more particularly transesophageal echo, to check whether endocarditis is there or not. Similarly, breakpoint, what madam have told as therapeutic index, we name is at breakpoint to MIC quotient, and it is the same, that breakpoint for the divided by the original breakpoint, we get some numbers, and based on that we can get the result. Similarly, other things are there. I am not going in detail with it. This is how our report looks like. And In case we also have, if you see, gram stain no pus cell. So what we do in absence of inflammatory cells, possibility of colonization cannot be ruled out. This note we usually send. Another one, brucella. So these are few actionable ideas that you need to have a 24/7 microbiology lab. Reporting is important and rapidly searching for certain diagnosis. This is one experience we have from the ENT department of our institute. Before AMSP practices, you can see the antibiotics prescribed and where and not prescribed. And after publication, you can see the change in the antibiotic usage and the drastic change in amoxicillin. In this case, this is our own data. So one last word that you need to remember, that degree does not imply full competence. Competence achieved once does not imply lifelong competence or license to practice, and training does not just mean passing an exam. You have to learn in a learning phase all your life once you have entered this field. Thank you. The last word is to discuss and discuss, because AMSP is a team job. Thank you.
Thank you, Dr. Debabrata Dash. Definitely, your presentation might have broken a little ice in the minds of the clinical physicians, and definitely ASP will not stand as a threat to the physicians. It is a sort of a liaison in safeguarding patients' healthcare system. So it is good one only. Thank you.
Thank you, sir. Thank you for excellent and informative talk. Now I request chairpersons to present memento to our esteemed speaker as a token of appreciation. Now I request Senior Physician Bhaskar sir, retired Superintendent, Professor and HOD of Medicine, KMC Kurnool, to present memento to the chairpersons. Thank you, sir. Thank you.
In the early years of 21st century, India grappled with formidable challenges in the realm of infectious diseases. Driven by the shared objective of waging a concreted battle against infectious diseases, the SIDS emerged as a beacon of hope, collaborative platform and a repository of expertise dedicated to comprehensively addressing the burden of infectious diseases in India. During the COVID-19 pandemic, SIDS demonstrated leadership by conducting numerous CME programs and providing evidence-based guidelines amid uncertainty. SIDS played an active role in promoting infectious diseases education in the country, facilitating subspecialty fellowship training, and influencing the incorporation of infectious diseases in undergraduate and postgraduate curriculum. With their mission to combat infectious diseases in India by educating healthcare professionals, disseminating new knowledge, advancing research, and advocating for the highest quality care for patients. The journey of SIDS is a testament to the collective determination to create a healthier and more resilient India in the face of infectious diseases. On behalf of the Department of General Medicine, GGH Kurnool, it is my privilege to extend a warm welcome and our sincere gratitude to the members of SIDS AP chapter. I now invite Dr. D. Sriramulu sir, Professor and HOD, Department of General Medicine, GGH Kurnool, Organizing Chairman of today's CME program, onto the dais. It is my immense pleasure to invite our chief guest, Dr. P. Chandrasekhar sir, Vice Chancellor, Dr. NTR University, onto the dais. We are truly honored by your gracious presence, sir. I cordially invite our guest of honor, Dr. Chitti Narsamma Madam, Additional DME, Principal, KMC Kurnool, onto the dais. I cordially invite Dr. Venkateshwarlu sir, Additional DME, Superintendent, GGH Kurnool, onto the dais. I kindly invite Dr. Prakash sir, Director, State Cancer Institute, Kurnool, onto the dais. It is my privilege to invite Dr. Kalyan Chakravarti sir, President, Dr. Neeren Ravela sir, Treasurer, SIDS AP chapter, onto the dais. I heartily invite Dr. P. Rajesh sir, Professor and HOD, Department of Pharmacology, APMC Observer for today's CME program, onto the dais. I cordially invite our Dr. K.B. Krishnamohan Memorial Orator, our mentor and teacher, Dr. Sudhakar sir, retired principal, Professor and HOD, Department of General Medicine, onto the dais. I invite Dr. Viren Ganta sir, Secretary, SIDS AP chapter, onto the dais. We will now begin the inauguration program by invoking the blessings of Lord Ganesha with a prayer song.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डखण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
I now request the dignitaries to proceed for the lamp lighting ceremony. I invite Dr. Sriramulu sir to conduct further proceedings.
One oration is speaker for Dr. Christopher and Dr. P. Rajesh, APMC observer, esteemed faculty and speakers, senior professors and my teachers, distinguished delegates and postgraduates, ladies and gentlemen, good morning. It is great honor and privilege to welcome you all to this infectious disease conference as a chairman of this event. I am delighted to see such a distinguished gathering of clinicians, researchers, microbiologists, and public health professionals brought together by a shared commitment to advancing the science and practice of infectious disease. Infectious disease continues to pose complex and evolving challenges to global health. The emergence of new pathogens, the re-emergence of old infections, the growing threat of antimicrobial resistance, and the ever-present risk of outbreaks remind us, and our field remains dynamic, demanding, and critically important. These challenges require not only scientific innovations, but also collaboration, vigilance, and ethical responsibility. The conference has been designed with the cooperation of Clinical Infectious Disease Society AP chapter as an academic platform to foster evidence-based discussions on the current emerging infections. Advances in diagnosis and therapeutics, vaccination strategies, infection prevention, and public health preparedness. Such dialogue is essential to ensure that research translates into meaningful clinical impact and to improve patient outcomes. I extend my sincere gratitude to CIDS AP chapter and our esteemed faculty and speaker for sharing their expertise and insights. Their contributions play a vital role in shaping the clinical practice, guiding policy, and inspiring the next generation of infectious disease specialists. I also commend the organizing committee for developing a scientific program that is both academically rigorous and clinically relevant. Their dedication has made the important gathering possible. To all delegates, I encourage active participation, engage in discussions, exchange experience, and build collaborations. The collective knowledge of this hall represent our strong tool in combating diseases. With these words, I warmly welcome you all and wish this conference a great success and meaningful academic deliberations. Thank you. Now I request Dr. P. Rajesh, APMC Observer, to say a few words about this CME program.
Thank you, sir. Good morning to you all. Respected dignitaries on the dais, faculty members, delegates, other medical professionals, and postgraduates, I welcome you all to this continuing medical education on infectious disease organized by Department of Medicine, Kurnool Medical College, Kurnool, in collaboration with the Clinical Infectious Disease Society AP chapter. So this gives a stage for all of us to know about the new things and the recent advances in the medicine, which will be of helpful for helping the patient safety and for healthcare system. So for attending this CME, you will be awarded 2 credit hours, and CME certificates for you will be provided exclusively through email in the form of e-certificates only. No physical certificates will be issued. You should be present for all the sessions in order to get the certificate, and registration is compulsory. I urge especially postgraduates to be present for all the presentations, because the topics are very interesting and informative. So at this outset, I want to appreciate the Department of Medicine for organizing this CME, and I wish them good luck for smooth and successful conduction of the CME. All the best. Thank you.
Now I request Dr. Prakash, Director of State Cancer Institute, to say a few words.
Respected sirs and madams, I thank you for inviting us to this conference and I thank organizers for conducting this conference. It is useful not only for the physicians but also for all departments for making a policy of microbial uses. I thank the organizers for conducting this informative conference. Thank you very much.
Now I request our Superintendent Dr. Venkatesh Shogalu to say a few words.
Respected dignitaries on the dais, I'm very happy to see all my senior retired physicians. So thank you, sir, for coming this CME. I just want to say a couple of words about them. They are not only known for their clinical acumen, but also their love for teaching. So thank you, sir. Thank you for coming to grace this occasion. And also thank all the speakers who have come from different parts of the AP and also the country to grace this occasion, to share their experiences, because in no textbook or no YouTube, these things are available. So it's a blessing for the students to have you, all of you, sir. All my dear faculty members and all students, a very good morning to you all. At the outset, I want to congratulate Dr. Sriramulu, sir, HOD and Department of Medicine, all the faculty, to take up this topic, infectious disease, as a topic for conducting CME, because as an orthopedic surgeon, I know what is infection. So for an orthopedic surgeon, anything is okay, but for infection. I know how many days I have had sleepless nights when my patients had infection, because apart from other departments, our department there is some foreign body inside. So it is very difficult to deal with both the foreign body as well as the infection. I will just tell you how I am able to deal with infections as an administrator and also an orthopedic surgeon. I myself has evolved because as you all know, antimicrobial resistance is maximum. Recently I read an article in the newspaper also, antibiotics abuse maximum in this country. You all know the reasons, because all the highest antibiotics, the most advanced antibiotics are available across the counter. Anyone can go and buy. So any new antibiotic coming into the market, it is available to the RMPs. So all the post-op, the combination was for all the surgeries after surgery, ampicillin, gentamicin. Then taxim has emerged, cephalosporin, so which switched to taxim. We used to write for almost 10 to 14 days. I don't know, because I never understood it, that I thought it was a norm to use antibiotics for such a long period. I became assistant professor in 1998. We switched to ceftriaxone and amikacin. So you know the effects of amikacin, how bad they are, how nephrotoxic they are, but still, because nobody told me that this is not the way to use antibiotics. In 2007, I went to National University Hospital, Singapore, as an observer in the Department of Adult Reconstructive Surgery for 2 weeks. There I have learnt. First day I went to operation theatre. There was a case of revision total hip replacement. Usually it takes, normal THR takes 1.5 hours, it takes 3 hours. So I was watching. So they have given 1 gram of cefuroxime 30 minutes before the surgery. And their protocol is after 1.5 hours, if the surgery extends beyond 1.5 hours, another dose of cefuroxime. Post-op, only 1 dose of cefuroxime after 12 hours, and next, not even oral antibiotic. So then I just verified the records. What is the infection rate? It was 0.01%. So then I totally, after coming back, I changed my perspective. I started giving only for 2 weeks, 2 days only. After that I stopped. I didn't find any change in infection. So what I've learned is, if I find any source of infection, say 5th day I'm doing dressing, if there is oozing, there is no point in continuing the antibiotics. So take the patient to the operating theater, go to the bone, go to the implant, thoroughly wash, debride everything, put antibiotics beads. So at that time, antibiotic beads was very expensive, some 8 to 10,000 rupees in the market. So what I did was, so we had a bone cement, it cost around 2,000 rupees, and over a stainless steel pipe, which was autoclaved, I added 2 vials of tobramycin and prepared antibiotics on the table. So after thorough debridement, we used to put them, after 1 week, we used to discard them, 2 weeks. I found wonderful results. Totally all infection got controlled. We could save a lot of money antibiotic wise. So that I taught my own PhD students. Even now it is being followed. It is giving wonderful results. So that's what I have involved myself as an orthopedic surgeon, how not to abuse antibiotics. Coming to as an administrator, so thank you for giving an opportunity for sharing my experience. Thank you so much.
Now I request Dr. Kalyan Chakravarti, SIDS President, to say a few words.
Good morning, everyone. Respected dignitaries on the dais, I initially thank Department of Internal Medicine, Kurnool Medical College, Head of the Department, Dr. Sri Ramal Garu, and Dr. Somappa Garu, whom we had an association in the form of SIDS for more than few years, and Dr. Chandrasekhar Garu, Vice Chancellor, Dr. Chitti Narasimha Garu, Additional DME Principal, Venkateswarlu Garu, Additional DME Superintendent, Satyanarayan Reddy Garu, Prakash Garu, and my colleagues Veeran and Neeran. I am here as a part of SIDS. More than that, as a physician initially, not as an infectious disease specialist. I was like you, all of you. Probably a decade ago, I was practicing internal medicine, where as many of us have after practicing for a few years, there will be an interest into a given field, which I would also say because there are many postgraduates here in internal medicine. So I could tell them, if you love something, you can do it later also, not that you need to immediately jump into DM or whatever course you want to. And like that, I even got into infectious diseases. So I'm a person, unlike Veeran and Neeran, who are exposed to infectious disease from day one of their practice. I'm like you guys, who was a physician and then an infectious disease specialist. So perspective will completely change as you learn new things about a given specialty. You know more cardiology, neurology, gastroenterology of all of us sitting here. So, but unluckily, in a country where infectious disease is predominant, we do not have that specialty as one of the major departments developed. And I would like to take this to Vice Chancellor, sir, that we need to focus on bringing in more and more ID consultants into the field. So what happened, luckily, I got into this program with University of London, a small 1-year program with the help of a director in that department. And then after that, the whole process of understanding science of infectious disease has changed. So today morning, while speaking, Dr. Bhavani Prasad sir was saying, I heard his lecture was saying, at the end, okay, we are in an urge to start an antibiotic because the patient has come, he has got fever, probably you think he is in sepsis, and the BP is not there, he is on noradrenaline, and you want to start something. No, you want something, a cocktail, right? You don't want to miss anything. Okay, what's the best cocktail that covers everything? Enteric, malaria, typhoid, dengue, or XYZ. So you have a cocktail, 3rd generation cephalosporin with doxycycline, right? Now, Dr. Teja was actually presenting in her first talk itself, total drug resistant. You don't have anything. Then I think where Neeran was saying cefdierocol from that end and zidibactam from this end. So this, okay, something they're saying today, after some time, Dr. Nandini will be today telling about some newer molecules that are there which will help us shortly. Now what is this? We as a seniors, we are advocating, okay, start with smaller antibiotics and look into it, and then on the other end, senior physicians or ID consultants are saying nothing is working, you have to be careful, you have to understand science better. So why is this happening? So somebody was asking, Why is this happening? Why antibiotics are not working? Antibiotics will not work. Now, even the Zidibactam will not work. Okay, so what is it? Because bacteria are there before us and bacteria will be there after us. So we need to know how to live with them. Just now, couple of minutes ago, sir was saying in Singapore General Hospital where he has seen, he was saying that hardly there was any antibiotic used during the surgery, post-operatively. I can say this boldly, I have recently underwent bypass surgery. Out of the blue, suddenly I got into trouble and then I was just given 3 days of antibiotic. Very simple antibiotic. I was worried because I work in an intensive care units and I am exposed to MDROs. So we should know that the back them. And the second most important thing, to sort this out, I think probably we need to understand when you get a chest pain, when we get a chest pain, all of the PGs are here, immediately they take an ECG, they want to prove whether it's an MI or not. They do TROPI, they do CT angio. Then if not, conventional angio, then you confirm. Or if you say to give a oral hypoglycemic agents, just because somebody is having polyuria and they come to you, sir, I am passing urine lots of time. Okay, you have got diabetes, take. But it is not the same way with infection. Why are we giving antibiotic? Just because there is a fever. So this culture will change only if more and more specialists are out there making us understand what is the problem is, and more importantly, trying to make a diagnosis of infection, which is of very, very important. In the morning, as the lecture was going on, I really could understand when people were saying ESBL, AMC, OXA48, these things are very much important now for the generation to understand how they use, and the next few lectures probably will help you a lot in understanding them pretty quickly. So I would like to end by saying, requesting administrative authorities, like in our meeting on antimicrobial resistance few months ago in Guntur, the health minister was also there. I was asking, please include something in cinema hall ads. Every time you get into the theater, you see that mandu tagite hanikaram, cigarette tagite hanikaram. So if you see, if somebody is drinking alcohol, it affects his liver only. If somebody is smoking, probably that family is affected. If somebody is taking an antibiotic without requirement, it's affecting the whole society. So it's a sincere request, sir, Vice Chancellor, sir. I think this should be brought forward to the governments as well. And this should be included in the understanding that antibiotic usage is most harmful or more harmful than anything else. And by 2050, I think we have now a very clear-cut indication that sepsis will be the leader killer ahead of sepsis.
Very good morning to Chandrasekhar sir, Superintendent sir, and all dignitaries on dais and off dais and all the PGs present here. First of all, I congratulate Sriramulu sir for selecting the very, very important topic. Previously, nearly before Corona, the infections are to some extent seen below or neglected, and everybody used to talk about non-communicable diseases are the more important and always insisting the stress. But nowadays, the non-infectious diseases and infectious diseases, and along with that, antibiotic resistance, are the three important hurdles in front of the society. Once we recognize these are the three what we have to face, and all the PGs has to prepare themselves to the requirements of the society. So, while prescribing antibiotics, you have to be careful. Not only you to be careful, it is the very, very important thing is to explain the patient and patient relatives. Once we are not explaining, just giving some antibiotic and telling come after 2 days, the patient will go to the other doctor because this doctor given only 1 tablet, 2 tablet and given only investigation. So you have to explain. Not only you yourself to be educated or conscious about the antibiotic resistance, our responsibility to explain the patient. Then only we can improve the situation. Thanking you for giving this opportunity.
Now the time is very short and VC sir has to leave for Vizag. I request Dr. Chandrasekhar sir to give his message.
Good morning, respected Principal Chittina Samagaru, Dr. Venkateswulu, Superintendent, and Organizing Chairman, Dr. Sri Ramulu, and Kalyan Chakravarti. I'm happy that you brought the infectious diseases CME to the Kurnool, and also the other dignitaries on the dais, my teachers, Dr. Bhaskar, Bhavani, and everybody, and also the senior faculty members, also professors, associate professors, assistants, students, my dear students, and members of the press. I'm happy that I've been associated with this CME program. As you know that I'm the product of Kurnool Medical College. Almost by another 2 years, of NTR Health University, and also most of the members are from APMC, and also the Director of Medical Education is also my student Raghunandan, who has studied at Tirupati. Then he was there as a faculty and all. I will agree with Kalyan Chakravarti. This is a burning topic. That is the reason I heard the lecture of urinary tract infection, how the resistant bacteria and all. I think everybody should know. And these type of continuing medical education programs are really essential to update the knowledge. So when I joined in, after my DM, 97 I came, I joined here in October. I thought every year I should conduct. So 98 it is not possible, but from 99 onwards I have conducted regular cardio CME 99 to up to my retirement last year. So this is very, very important. I've been encouraging that at least Sri Ramulu has started this CME program, at least from the different like infectious diseases, definitely it is one. And I request all the principal to advise all the departments to conduct one CME every year, so that every month one CME will be there, so that it will be updating. Suppose if the medicine department is conducting, you take a subject, one cardiology, one neurology, gastroenterology, like this. So like this, if every department conduct, the knowledge will definitely, anyhow, we are imparting the knowledge for postgraduates, journal CMEs and all. But apart from this, like calling eminent persons, like these type of things are definitely useful. And I promise you, Kalyan Chakravarti, that you will start a postdoctoral fellowship on infectious diseases. If you are willing, I think there is reforms in the university, what we have planned. So we have planned in a different way, particularly on the research. And we wanted our health secretary, Saurabh, and also health minister, very, very positive, and also Honorable CM. And recently the NMC chairman has come, Abhijit Seth. He is also cardiothoracic surgeon from Gujarat, and he is very positive. He has listened to the problems, and he said he will be cooperating with the present university and all. So the sea of changes are there. I am happy that we wanted to share that recent EC meeting. We have decided to increase the research, and research day, first time in the history of Dr. NTR Health University, we have started the research day on 12th January on the birthday of Yella Pragada Subbarao. We have installed the statue of Yella Pragada Subbarao. From every year it will be there. So like Doctor's Day and all. So this is the thing, we have to encourage these people, those who got, and 120 applications have come, out of which 55 people have been awarded, like certificates and from this one, and also Dr. Lokesh Sajja, CT surgeon, eminent CT surgeon from Hyderabad, received Yella Pragada Award. So this is a sort of encouragement, so that everybody is happy that I wanted you, this medical college, you should be the research friend. We will provide you for all the government medical colleges, irrespective of the region. we are giving 50 lakh rupees every year. So that is the thing that we have decided. And also apart from this, you should, we'll see the strength and the grounds. Particularly, we have been like GSL Medical College, that's a very good playground is there where been associate both men's and women's team, and also our, they have also conducted a Southern Zone shuttle badmintonship for women, and our boys also gone to some other place for a national inter-university tournaments and all. So we wanted to increase the sports also around 25 lakhs every year to each medical college. And part of it, I think 10 lakhs immediately will sanction to improve the grounds. So Chittinansama has got the funds, but only thing is she is not utilizing it properly. And I request her to see that the funds has to be utilized, and we will start this one. Apart from this, the alumni associations, what the Chandrababu Naidu is planning, P4 system, will give 10 lakhs for each government medical college to start the alumni meetings where we invite all the people. Like we got eminent persons like Nagesh Reddy, AAG, and also Jagannath. So many people are there, but they are the one. If we invite them, I think we will release immediately 10 lakh rupees for the alumni association. I think the things are in a positive direction. I think we are going to start definitely a knowledge center in future, and we are there with you. Utilize this opportunity and all. So these are all the
పూలపత్రి శరీరంలో సహజీవించడానికి పనితీరుకి సహాయపడుతున్న గీసా నాకు తెలుసు షుగర్ స్పైస్ నిర్వహిస్తుంది. ఇలాంటి 11 ఆయుర్వేదిక్ పదార్థాలు ఉన్నాయి. కపివా డైటరీ జ్యూస్ చక్కెర స్థాయిని సహజంగా నిర్వహిస్తుంది. కపివా సైన్స్ ఆఫ్ ఆయుర్వేద.
Definitely we will do the best for all the parties. I think the present administrators are very, very positive. So the even Honorable Governor is also very positive. Even if they give, we have asked about
thank all the dignitaries for gracing today's event.
respected dignitaries, esteemed teachers, students, and ladies and gentlemen, a warm good afternoon to all of you. Some lives are measured by years, some lives are measured by the achievements, but some lives, they are measured by the generations they continue to influence. Today, it's a great opportunity for me and an honor for me to introduce and to speak about one of such a great life that is celebrated over the years, Dr. K.B. Krishnamohan Garu. He's born on 31st January 1927. Dr. K.B. Krishnamohan Garu showed an exceptional intelligence in his studies, during schooling, in his college. His academic excellence has extended even into his medical education, which he pursued at the esteemed Madras Medical College. During his study at Madras Medical College, he achieved many of the awards. He got the first class and he passed everything in the distinction, which has culminated into the achievement of a gold medal, which is the very esteemed of those days, the gold medal of Raja of Panagarh gold medal, which is presented to the best outgoing student, which is a rare and remarkable thing to people those days. His excellence did not just end during only his academics. When he appeared for the UPSC exam, he was the top ranker and he joined as assistant civil surgeon and began his service career, and that took him to leading to many medical institutions across the country, like Madras, Visakhapatnam, Hyderabad, Tirupati and Kurnool. As professor and head of the Department of Medicine, as well as physician principal, he served with dedication for decades. Dr. K.V. Krishnamohan Garu was a teacher in the truest sense. He did not merely impart medical knowledge. He shaped character, discipline, and compassion to his students. The Brilliant Teacher Award that is conferred by the Indian Medical Association in 1989, it reflects the deep respect he commanded among the students and colleagues in those days. His contributions extended also into the medical research with publications in many important conditions in the medical era. And his role as examiner, chairman, and senate member in several universities helped to strengthen the medical education standards and to raise them above the par. Even after retiring in 1993, his influence continued through the institutions and lives he shaped over the many years. Dr. K.V. Krishnamohan Garu left this world in 1997, but his life reminds us that true success is not measured by position, but by purpose and impact. Legends, they do not die. They live in institutions. They live the lives of the students that they build. So today, a silent, powerful question his life speaks to students is that, are we striving merely for success or for significance? To the teachers and professionals, his life keeps on questioning, are we shaping careers or we are shaping lives? May his journey inspire all of us, and may the younger generation stay a legendary man. And with this introduction, I would like to invite Dr. Malkonda Sir Garu, Bogopal Sir Garu to come onto the dais to garland Dr. K.V. Krishnamohan Garu. And Devanand Sir Garu to please come onto the dais. All the senior physicians, Dr. Sir Garu to please come onto the dais and do the garlanding. Our HOD Sir. Let's all join our hands together and give a round of applause as we garland this great man. Dr. Sudhakar Sir, rather with the please put our hands together. It's a great privilege to introduce a personality who exemplifies academic excellence, public service, and lifelong dedication to medical education. Dr. P. Sudhakar and leader of medicine, distinguished physician and inspiring teacher. Dr. Sudhakar Sir's journey is one of courage and perseverance. His academic brilliance was evident early in life. It was his career at the Bangalore School Educate as a scholar fully sponsored by the government of India University. He completed both his undergraduate and postgraduation in Tamil College, an institution that will later enhance his leadership services. He joined the government. I request the Rashtrika sir to please come onto the dais. I request P. Srinivasa sir Garu and also C. Srinivasa sir Garu to please come onto the dais.
Respected Chairperson, my teacher, Dr. Y. Bhaskar sir.
Sudhakar?
Sir.
Just a minute.
Sir.
We are exceeding the time, little late. Let us start and talk less. Let the speaker talk more. It is important lecture. All of you know, many of the people know Dr. Krishna Mohan sir, the great teacher, eminent teacher, administrator, good administrator. And he was the teacher, examiner for me who gave the MD degree first chance at those days. So I owe a lot to Dr. Krishna Mohan sir. Regarding Dr. Sudhakar, a brilliant student, very good teacher, professor and HOD of medicine, Kurnool Medical College. I think he is an encyclopedia of the subject. He has chosen a right topic, that is sepsis, very serious problem because of the presence of the microorganisms in the body and tissues and blood. So I invite Dr. Sudhakar to talk on sepsis. Before that, I request Bhaskar sir to say a few words.
I'll speak later. Let it go ahead. Thank you. Please go ahead. Thank you.
respected chairperson, my teacher, mentor, my guide, Dr. Bhaskar sir. I was a student of Bhaskar sir, proud to say so, and proud today even more to receive this medal from him. I adore him as a physician, teacher, because very few people know the magnitude of subject he possesses, and I am the biggest beneficiary of his teachings. I am very thankful to him for all the guidance he has given. Dr. Malkonde sir, extraordinarily humble person, very talented, and I worked under him, under his professorship. I'm very, very happy to be with him on this dais. Dr. Sri Ramlu, I owe him a lot because of him and all the professors in the Department of Medicine, associate professors, I am given this honor, privilege of delivering Dr. K.B. Krishnamohan sir oration. I feel belittled because I have been a student of K.B. Krishnamohan sir at the fag end of his career and at the beginning of my career. An extraordinarily talented person. I can go on to say, and I'm sure this house will accept, that Dr. K.B. Krishnamohan sir is the best teacher ever for Department of Medicine since inception, and that is my personal opinion. I'm sorry, contradictions will always be there. I've heard his lectures. There were no internets, there were no computers, there was no communications. It was at that time the hall used to be so full when he was taking classes. That is a testimony to the way he used to teach. And one of the best teachers I think the country had. So, of course, those days were different. The publicity and other things were very less those days. And I am very thankful to Sri Ramalu and Department of Medicine, all the professors, for giving me this honor. And the sepsis is very dear to my heart, but little did I realize when the topic was given to me 1 month back that the enormous dimensions it has evolved since COVID. COVID has revolutionized the thinking about sepsis, and so much as research is going on. The scale of guidance is always the Surviving Sepsis Campaign, SSC, which usually happens every 5 years. The last update was in 2021, and the next update is due in 2026. And I am handicapped by lack of guidelines from this guiding SSC, because very little had been incorporated after COVID. COVID has revolutionized the thinking about sepsis. We have seen as physicians how we struggle to cope with the patients of COVID. We had 2 or 3 eras in COVID. The hyperinflammatory phase where a lot of people died during the pandemic in 2020. Then after 1 year, we had this immunosuppressive stage where the infections rates have increased, and after 1 year, the post-COVID syndromes. It took a heavy amount of research to look into what is happening, what exactly happening with COVID and sepsis. And believe it or not, there were 560 research papers post 2021 SSC guidelines from international reputed journals. And to go through all of them with a proper guidance of guidelines was a Herculean task. And I just put forward some of the hypotheses. My chairperson, sir, Dr. Bhaskar, sir, he has some notions. Please talk what is there in textbooks. I don't like hypotheses, I don't like theories. For everything we talk, sir will always point out saying that where is it written, which textbook is it written. I'm sorry, sir, none of this is written in any textbook. Please pardon me, because that is how sepsis has evolved since 2021. And even the latest Harrison just gives 1.5 pages of sepsis to contend with. Sepsis is very complex, and I'm going to make it more complicated. Please bear with me. This lecture is mainly targeted for the postgraduates, and I hope you will have something, if not clarity, confusion to go back and more get into the theories that are being proposed. Good morning to all of you. Good afternoon. Sepsis, how to treat early and recent advances. This complicated analogy of topic must have been given by none other than Somappa. So it is very difficult actually to know the recent advances and how to treat early. Everything is in the formative stage, and I'll start off. See, you know, sepsis is there since time immemorial. The research on sepsis started way back in 1500 AD, and from then onwards, from a symptom-based to system-based approach, the sepsis has evolved. And by 2050, someone was saying sepsis is going to take over the leading cause as death. The important thing here I want to tell you is the current WHO statistics. They tell us that 20% of the patients are dying with sepsis, and that is second only to cardiovascular system, where 30% die. I think this statistics holds good for the Western countries, developed countries, and we are handicapped by the statistics and proper reporting in our country and the developing countries. I am sure this is on par with the cardiovascular diseases in the developing countries, because people reach us late, and sepsis is all about treating early. You miss the bus early, you're getting into a complication stage where everything is late. So by definition, we still are sticking to the same definition as has been advocated by the SSC 21. Sepsis is defined as a life-threatening organ dysfunction. Life-threatening organ dysfunction caused by a dysregulated host response to infection. All of us go through infections, but we have a regulated response, and it's only the unfortunate few, either by the virulence of the organism, the amount of organism that has gone in, or by the host factors, old age, diabetes, immunosuppressive states. These are the few segments which get into the complications. Then, because as per the guideline, a change in quick SOFA score of more than 2 points baseline is the definition given. And when it is compounded by hypertension, hypovolemia, refractory to our fluid administration and vasopressors, then the definition of septic shock comes in. Severe sepsis was a term being discontinued from 2021. So a quick word about the quick SOFA. It's actually withdrawn now because it doesn't give any specificity into the categorization of the patients, who is septic, who is non-septic. But as postgraduates, we need to know that a score of 2, which comprises of altered mental status of GCS less than 15, then the fast respiratory rate of more than 22, and a low systolic blood pressure of 100. If 2 out of 3 criteria are met, then we are dealing with a definite case of sepsis. Okay, but right now in Western countries and more advanced countries, the NEWS and MUSE are the ones which have taken over for the scoring system. What are they? Before we go into that, a pictorial explanation of what is sepsis, what is septic shock, and what is modes. And if you remember here, the infection stage, the mortality is not mentioned, because at this stage, things are reversible. And once the patient gets into sepsis stage where there is dysregulated immunity, we are dealing with a mortality of around 10%. But once you surpass this stage and get into a stage of septic shock or the multi-organ dysfunction, we are dealing with 50% mortality, and mind you, this is in the most advanced ICUs across the world. You know, the advanced and non-advanced, that categorization has been nullified by the pandemic called COVID, because the amount of people who died in Western are much more than what actually happened on the underdeveloped or the less developed countries. So our understanding of sepsis needs to be revised to actually counter these cases early. I told you about the News2 National Early Warning Score. That is the current gold standard for categorization of sepsis, because there are 7 parameters in this: the systolic blood pressure, the heart rate, respiratory rate, temperature, and ACVPU. Here, one thing you need to know is the confusion state. Why this confusion has been incorporated into this is because it is a superior scoring system compared to the modified early warning score, which was prevalent earlier. Okay, so this is more specific for diagnosing sepsis. Okay, a score of 5 and more of these parameters, because the News2 is dependent on confusion, the supplemental oxygen, and the oxygen saturation of the person who presents to the emergency ward. So these are the points on which we categorize septic cases. The Muse was the predecessor, used to be there earlier. It is less challenging because you don't need to know the ABG or the oxygen status of the individual, and that's the reason why this still holds good in less developed countries, but in Western countries they are following News2. Then the difference between News2 and Muse happens to be News2 is more sensitive, and it includes a criteria called as confusion, and specifically mentions about the oxygen needs and oxygen supplementation. And this is where we get into the criticality of discussion, because unless you understand the pathogenesis of sepsis, you will not be able to diagnose it, nor will you be able to treat it. So the COVID has revolutionized our understanding of sepsis, and I am sure all of us have come across these sepsis cases in COVID, and the pictorial depictions they have given, we have all faced it without understanding it at that time, and the understanding has improved over the last 2 years, and let us dive into it. So it's a fast-moving, complex analogy of subject, sepsis, and it challenges the best of the brains in the world, because every case is different, and every individual who presents with sepsis is different. So the theory of germ being the offending agent to the host and the dysregulated immunity, that is the challenging aspect of the management of sepsis. So we go to the basics. Every person has 2 types of immunity: the innate immunity, the adaptive immunity. Innate immunity comes to us from birth, and it is generally constituted, it's non-specific. Any invading organism that enters into your body, the innate immunity immediately reacts. But after that, if the organism, why there were so many deaths during COVID is because our innate immunity was not prepared for the challenges COVID posed to the body, because it was never there earlier. Innate is what we acquire from birth across as we grow up. So it is mostly taken care of by the monocytes, neutrophils, and mast cells. Whereas the adaptive immunity is what an infection or a challenge poses, and then that is usually modulated or modified by the T cells and B cells, they produce antibodies, immunoglobulins, and the T cell regulatory cells. These two, they act in tandem, and they are the ones which take care of our immunity. Now, so what exactly happened? The beginning of the sepsis, the bacteria, the viri, the fungi, they enter into the body. They are recognized as pathogen associated molecular patterns, also called as PAMS. Okay, PAMS, pathogen associated molecular. So what do these bacteria? These bacteria, viri, fungi, they release lipopolysaccharide gram-negative and peptidoglycan, the gram-positive bacteria. So these are alien to the immune system. So once they come into this, they challenge the tissues, and the tissues react. Through that interaction, the tissues, some of the tissues get damaged, and that damaged tissues, they release what are known as damage-associated molecular patterns. So PAMS and DAMS decide the recognition of sepsis into the body. And once these enter, they are recognized, the pattern recognition receptors, they are called, they are toll-like receptors. These DAMs and PAMs sit on them, and they stimulate a very severe cytokine storm. So this is a broad flow chart which depicts an infection in the form of PAMS. It stimulates the inflazomes in the cellular cells of the body, and they release cytokines and alarmins, and after releasing them, the cell undergoes death. That is called as pyroptosis. But parallelly, these PAMs also cause vasodilation, they cause DIC because of the endothelial dysfunction, and finally, they cause warm shock, which becomes irreversible, and it becomes a cold shock, multi-organ dysfunction. So this is just a brief analogy of flowchart. We dive into the details of, so once the cytokine storm is stimulated by the PAMs and the DAMs, the pro-inflammatory phase is marked by release of the tissue necrosis factor alpha, the interleukin-1 beta, and IL-6. Okay, so these are the ones which are very aggressively secreted in the pro-inflammatory stage, and they are responsible for the hyper-inflammatory stage because they cause tremendous amount of inflammation. This segment of sepsis is called as hyper-inflammatory stage, which the patients go through. Okay. And what happens when the hyperinflammation occurs? When the inflammation occurs, entire body is getting inflamed, and part of it is the endothelium. The endothelial cells, they get inflamed, and gaps are formed between the endothelial cells. The endothelium becomes leaky, and all the intravascular blood, including the plasma, the WBC, all seep into the third space. This is called as third spacing. So the volume of blood becomes from intravascular to extravascular. So what maintains the blood pressure of an individual? It is the vasoconstriction, the stability of the blood vessel, and the volume inside the blood vessel. Now there is vasodilatation and loss of blood volume, which leads to hypovolemia and hypotension, the dreadful combination in sepsis. Okay, why does vasodilatation occur? Because the nitric oxide, you know, is a very powerful vasodilator, The microbial products which we have already discussed, the PAMs, the DAMs, the cytokines, all these, they induce what is known as nitric oxide synthetase enzyme. They induce it irreversibly, with the result there is uncontrolled production of the nitric oxide, which causes tremendous amount of vasodilatation. Okay, that vasodilatation produces warm shock. That means whenever there is vasodilatation, the temperature rises, there is warm shock, unlike the other types of shock, cardiogenic and hypovolemic shock. And once this continues, it gets into a stage of refractory shock. And what is happening here? Once the sepsis continues, the damaged endothelial cells and activated monocytes, they start releasing a factor called as tissue factor. And this is very, very dangerous because it switches on the coagulation cascade. The clotting mechanism is induced. So once the clotting mechanism is induced, microclots are formed in the blood vessels, and these microclots, and they go, and where do they get blocked? They get blocked in the thinnest part of the. There is hyperlactemia. The lactic acid gets accumulated. And what happened while the clots are being formed? All the coagulation factors are being consumed, and they are consumed to form the microclots. And so what happens to the coagulation factors? They become decreased. So there is a paradox here. The paradox is the coagulation factors are decreasing, the clotting is increasing. So that paradox is called as disseminated intravascular coagulation. And once microclots go and block the microcirculation, there is no way things will revert. Okay? All the important organs like brain, the kidney, the heart, the liver, spleen, everything gets into this trap of sepsis-induced microclot, hypoxemic, hyperlactate situation, which leads to an irreversible organ failure. And whenever the organs are challenged with lack of nutrition, with lack of oxygen, what happens? The energy units in a cell, what are they? Mitochondria. They are the ones, they receive the oxygen, they receive the glucose, and then they produce energies. But what happens here? The energy is not there anymore. So when energy is not there, the cell switches off the energy units called as mitochondria. So once it is switched off, the mitochondria enter into a stage of irreversible shock. The cells get into a stage of cytopathic, hypoxic situation, wherein the cells cannot survive. Brain. Now, this is a very important slide because our understanding and future treatments depend on this. So we have already seen that there is a challenge given by PAMPs and DAMPs, and this challenge has gone through toll-like receptors, entered into the cells, and it has produced it has challenged the innate immunity, the cytokine surge, which later stimulates the cellular immunity, which is called as adaptive immunity, and the surge continues. At one point, the body realizes it's going out of control. There is too much of inflammation everywhere. So how do we suppress? Our body has natural pro and anti-inflammatory properties. And that is when the anti-inflammatory segment of the body gets stimulated. This is a very crucial point because the anti-inflammatory, what are the inflammatory cells? They are generally induced by the T cells. This T cell, the new cells will be getting poured from the bone marrow because there are a lot of infection. To fight it, the recruitment keeps coming from the bone marrow. These myeloid cells, in combination with T lymphocytes, they fight off the infection. Like here, what you see, a myeloid cell activation and T cell activation. But if excessive fighting goes on, the body cannot take this anymore. So that is the reason why this is what happens. Every T cell has a programmed death receptor that's called as PD-1. Whether you like it or not, this is a very important aspect of our understanding. The PD-1, programmed death receptor, is there attached to every T cell. And a programmed death ligand, the lock and key mechanism, is there for every myeloid cell. When they too get into that lock and key mechanism, then there is the T cell gets exhausted, the myeloid cell gets exhausted, and that's a natural way of suppressing immunity. Natural way of suppressing immunity. And once these two get locked, that is irreversible. You remember COVID now. All of us, we went through wearing masks, everything, all. We saw people dying in the acute phase. Okay? After people have died, we have found some people surviving and happy, discharged, going back. Again, what happened? Okay. Then we started seeing them again back in the ICUs with fungal diseases. You have seen so many people coming back with fungal diseases. So we had no clue why there's sudden resurgence of fungal diseases. What exactly happened was the irreversible locking of the apoptosis of the immune cells have landed them in severe hypoimmune status and deterioration, recurrent nosocomial infection, internal viral, the CME, the herpes simplex, all the internal viral replications, and endotoxin intolerance. So these are the things which have killed in the second wave of the COVID. And that is where the understanding, a lot of research has gone into it, especially from the Europe. Surprising, because not many papers were there from US, but a lot of research went through from Nature. Is very good for postgraduates. I wish it's freely available in the net. Please go through these articles, very well explained, very well explained. I wish you go through it, because when you take a summary of this sort, you will not get to know the real understanding. You should go back and read the articles published, and I'm sure all these things will be incorporated in 2026 guidelines. And that is, so now the entire research is, can you see this anti-PD1 and the anti-PD-L1? So they are finding now monoclonal antibodies which are going to block these before they get into a permanent apoptosis or hypoimmune status. So early in the disease, they are finding monoclonal antibodies to stop off the this thing. So unless you know this pathology, the ensuing drugs which are going to get released into the market will not be able to understand. And this is another beautifully explained slide which says the pro-inflammatory response goes parallelly with the anti-inflammatory response. And what wins, the fate of the patient is decided. Okay, sepsis is a biphasic disease. The initial phase is characterized by overwhelming inflammation, followed by immunosuppression. A hemostatic balance between these two competing events is to be achieved for the patient's recovery. Some things have to be read. We cannot imitate, because so much of information is there in that sentence, we cannot explain it. These two are very balanced mechanisms where if one outweighs the other, the patient's future will be decided. And I told you, once the immunostimulatory phase is gone, the second hit happens to be the immunosuppression stage, where massive apoptosis of T cells and the secondary infections the patient is prone for. And look at this slide. How much is going on in the world of sepsis? And it is so perplexing to know these finer details, because ultimately this is the introduction of sepsis, then the cytokine storm, then all the mechanisms which counter the cytokine storm, and now this is the therapeutic strategies where we are facing the PD-L1 inhibitor, the granulocyte macrophage colony factor stimulation and interferon gamma. These are the three components which are going to take the sepsis forward to make it a more treatable condition. Your antibiotics, like someone was saying, it has no role once this cascade has started. There is nothing you can do about it. That's the reason why antibiotics have to be given within 1 hour. After that, there is no role. That's it. So that is very, very important, and that is where we miss the bus. All the developing countries, they cannot get access, the patients cannot get access to the specialist in that critical 3-hour phase. And that is where all these irreversible changes happen and the fatal results happen. The PD-1, L1 inhibitor, okay, these are the ones where the maximum research is going on now. The phase 2 and phase 3 trials are there, and they are getting very good response. And patients are recovering from very morbid condition, and they are coming out. Whether it takes the real clinical scenario, only time will tell us. So this is another important aspect of for the postgraduate, the compensatory anti-inflammatory response. That's what I was talking about, CARS, where if this offshoots, it goes into a stage of immunoparalysis. The negative feedback for hyperstimulation is the interleukin-10 and TGF-beta. So they dampen the inflammation, but at a very important cost, because they cause cellular apoptosis, deactivation of monocytes, and increased PD-1 and CTLA-4. They put brakes on the immune system. So we have got 2 phases now, till now. The 2 phases happen to be the hyperinflammation. The second phase happens to be the immunosuppression. The hyperinflammation stage is marked by the primary driver, that is the cytokine storm, and the immunosuppression by the cell exhaustion. And what are the 3 components which cause the hyperinflammation? TNF-alpha, IL-1 beta, and then IL-6. Whereas the negative interleukin-10, TGF-beta, and soluble TNF receptors, these are the ones which cause negative feedback. Okay? So the first phase is known for shock and death. The second phase for the secondary bacterial infections and the nosocomial infection. Now if you see the slide, we can get that entire 2.5 years of COVID into our mind. Initial deaths followed by the second admissions and the peaks, the third post-COVID syndromes, the post-COVID syndrome. So once the patient recovers here, the recovery is going to be only partial. Okay, there will be persistent inflammation, persistent immunosuppression, and that leads to a catabolic syndrome that is called as persistent immunoinflammatory catabolic syndrome, called as PICS. So that is the third segment of sepsis, and that is responsible for the late deaths. Okay, so what are the 3 components of PICS? We have heard so much in literature that many of the COVID patients suffered with brain fog. They are not able to remember anything. They have lost memory. I think Srinivas, as a neurophysician, must have come across so many of these cases. Early dementia, early Parkinson manifestations, they're all part and parcel of the recovery period. So the physical burnout, most important is the mitochondrial, because you have got a switch off of the mitochondrium, the patient starts to feel tremendously weak. That is called as profound, persistent fatigue post-COVID. That has been broadly named as a post-COVID syndrome. Then, if a patient is in ICU, what happens? The combination of inflammation, bed rest, and steroid use, it constitutes to almost 2% of muscle loss per day. the catabolism, and the critical illness, neuropathy. It became very rampant in survivors of COVID. Then the cognitive impairment, which I told you, 30 to 50% of people who go through severe sepsis suffer with the cognitive impairment. Okay, the microclots during DIC, they deprive the cells of oxygen, and the energy units are shut off, and there is damage to the hippocampus and the frontal lobe, causing them to suffer the cognitive impairment, which is colloquially called as a brain fog. And the prolonged stay on ventilators, the dependence on for daily needs on the nursing staff, it demoralizes the patient. He was fine till yesterday. Suddenly this COVID has taken over, and from then onwards he needs, even to move, he needs support. And that demoralizes. That is called as a post-traumatic mental disorder. It is very common in almost 20% of people who suffer with septic shock. Okay, so what we just summarize. So the cytokine release is marked by the systemic inflammation and fever. The endothelial leak, where the fluid moves out, causes hypotension and hypovolemia. The microthrombus causes tiny blocks and oxygen delivery. The mitochondrial damage, the cellular cytopathic hypoxia, and all this leads, and I told you the apoptosis. Lymphopenia. Please remember, all of us go through rounds in ICU. We always look at the neutrophil count. Counts are rising, 90% neutrophils, 85% neutrophils. We never bother about the component called as lymphocytes. Lymphocytes, lymphopenia is the one which kills the patient, not the neutrophil rise. We think neutrophilia is secondary to infection. No, it is the lymphopenia which makes the lymphocytes more in number in a peripheral smear. And this, I was talking to even Dr. Baleshwari madam, and you know, she said, I think we need to hereafter revise the way of reporting, because it's just not leukocytosis. Sorry. So it's not the leukocytosis or neutrophilia. What is important is lymphopenia. So after all this theory, what are you going to do with the patient? So are they realistically competitive in diagnosis of the patient? So now the biomarkers have come into the scenario. The biomarkers are the HLA-DR, which is a negative feedback for the monocyte. Okay, so measurement of MHLA-DR in ICUs can give you a prediction whether we are wasting time on that patient or not. If this level is very high, there is no point investing time and energies on that patient, because we are not going to recover that patient at this point of science. So that's a very important, a lymphopenia coupled with low HLA-DR is almost equivalent to death in a sepsis patient. And so after having talked about the pathogenesis, let's get into the management aspect. What is there to manage? You've got hypovolemia, you've got vasodilatation, you've got microclots, you've got interleukins, and you've got a stimulated immunosuppressive cascade. These are the places where you need. Where are antibiotics here? And we always rely on antibiotics for sepsis and septic shock. The patient is dying at one end, and we kill them with 5 to 6 combinations of antibiotics. Once everything is fixed, antibiotics have no role. It's only in the early component we need to concentrate on that. So the management of sepsis is basically divided under the 3 headings: hemodynamic management, modulation of host response, and then infection control. So fluids, this is one thing which has changed in the last 3 or 4 years. What is the fluid of choice for us? Ma, sister, Ramma, normal saline tisura, 4 bottles tisura petadam. Okay, this is the trend. I also followed that. But things have changed since then because excessive fluid, where are you pushing into? You are pushing into the third space. Already third space, there is no space. So you push the fluids into the third space, but you are not going to improve the volume. For volume to improve, you have to improve the endothelial function, which cannot be done immediately. So what you need to do is, the restrictive pattern of fluid intake has taken over the liberal fluid intake, which was the management strategy earlier. Then, crystalloids, that everyone knows. Which crystalloid is important? And earlier, as soon as the patient comes, the analogy was, give 30 ml per kg body weight. Push it, and there ends matter. But where to push, how to push, when not to push. These are the 4 things that have evolved after COVID has come. Okay? And that's why I'm already known as a COVID fanatic. Okay? For everything I'm mentioning COVID, because even in all research papers, they have told the sepsis today is equivalent to what COVID has done to world. So that is the reason why everything is related to what we have learned through the pandemic of COVID. Now, this 30 ml has been downgraded to a weak recommendation now. It was the most important recommendation way back in 2021. Now it is, just because, I'll tell you why. There is a shift towards balanced crystalloids. What are balanced crystalloids? Ringer lactate. My professors used to scold me if I put ringer lactate ahead of normal saline in a sepsis patient when I was working under them. Things have moved on. Why? Why this normal saline has been displaced with ringer lactate? So, normal saline has been studied to be associated with hyperchloremic metabolic acidosis and high risk of acute kidney injury. So please do avoid the normal saline and try to go with ringer lactate or plasmalite. Okay, so albumin, except when there is hypoalbuminemia, please do not give albumin because it is associated with increased incidence of pulmonary edema, ARDS. Then, how do you salvage in the first hour? I told you, in sepsis, everything is hour-based. There is no time. There is no time. So, you have to administer at 30 ml per kg body weight of ringer lactate, okay? But to achieve the mean arterial pressure goal of 65 millimeters. 65 millimeters. And I'm sure you know what is mean arterial pressure, okay? Then how do we achieve it? Earlier we used to look at the JVP, central venous pulse, okay? Things have moved on. Things have moved. There is no role for physical examination. There is no role for CVP now. No JVP now. Now everything is dynamic. The passive leg raising test, the stroke volume variation. You have got the point of care ultrasound, focus. That is the order of the day in every ICU. Point of focus ultrasound and the venous excess ultrasound. Okay, these are the 2 parameters which on which we rely for fluid infusion. Okay. So when you have given the loading dose, you have given 1 or 2 liters of it. So then what to do next after giving 1 or 2 liters of loading dose? What do we do now? You have to do a passive leg raising test. How do you do it? First you make the patient come up to 45 degrees, then make him lie down and passively lift the legs to 45 degrees. So at a more than 10 to 15% rise in cardiac output as measured by focus or the venous ultrasound, then only you should give further fluids. Otherwise, why you should not give further fluids? Because whatever you are given again has gone into the third space. It's no use again pushing for the fluids. So that's the reason why if you want to improve the blood pressure, fluid is not the solution. You have to go for a vasoconstrictor. A vasoconstrictor. So we are guided by, the fluids are guided by the passive leg raising test or the focus or the vexus. Now, the stabilization phase, important. Once you have stabilized the patient, please be very careful in giving further fluids, because if you do the fluid tamponade of kidneys, the AKI, acute kidney injury incidence, is doubled. So, giving excess fluids, leave alone the cardiac failure, acute kidney failure is a big complication. So then what is the, because one component you have treated, the hypovolemia, then we are going into the hypertension component of it. So vasopressors. So much is talked about vasopressors. Why do we need to give vasopressor? There is hypertension, you are giving fluids, the patient is not responding, then how do we give? So the only alternative is we go for a vasoconstrictor. And the time tested, the frontline vasopressor is always a norepinephrine, because it is a first line vasopressor. It has got an alpha-1 adrenergic potent action which causes calcium influx into the smooth muscles of the blood vessels, causes potent vasoconstriction, and it is the best drug to counter the nitric oxide vasodilatation. Okay. The other advantages are, it is not only an arterial constrictor, it is a venoconstrictor, because once the veins constrict, you are increasing the preload. Once you increase the preload, the cardiac conditioning will be better and the whole circulation will improve. Okay, so the preload will improve, the afterload will improve, cardiac output will improve. Then there is a bonus effect of norepinephrine, which is not highlighted. It has got a inotropic effect because it has got a action on the beta-1 receptor. Okay, so the beta-1 receptors are stimulated by norepinephrine and increases the cardiac output. So it has got vasoconstrictor, venoconstrictor, and an inotropic effect. Then we have got the other drugs, dopamine, epinephrine, vasopressin. So why not dopamine? Dopamine is also very potent vasopressor, but it has got a potential for arrhythmias. And epinephrine, it induces more arrhythmias than any other vasopressor, and the other disadvantage is it can increase the lactic acid levels. Already your lactic acid levels are increased in septic shock, and you can get confused with the infusion of epinephrine. Okay, and the other thing is, remaining one is vasopressin. Vasopressin, the advantage is it acts on the V1A receptors. It is a different mechanism, different pathway. So once the adrenergic receptors are saturated, it's always better to choose the other pathway. So vasopressin happens to be the other important vasopressor to maintain the mean arterial pressure of 65. Okay, and the important thing is, because it acts on a different pathway, the synergistic action will be there between norepinephrine and the vasopressin. Okay, why vasopressin as a second choice? Whenever there is a sepsis in the body counters that hypertension by giving a surge of vasopressin from the posterior pituitary. The posterior pituitary squeezes and sends vasopressin into the body. So in every sepsis case, by nature, the vasopressin is low. So if you supplement vasopressin externally, you are not only replacing the hormone, the potency of norepinephrine is augmented. So it has got a dual role. So posterior pituitary exhaustion can be countered by giving additional vasopressin in sepsis. Okay. Then, so there is always a receptor synergy. The alpha-1 and the V1 receptors, they have got synergy, and that is how they act synergistically. Now, the other important thing is, norepinephrine causes arteriolar, renal arteriolar and afferent and efferent constrictions. That means the blood flow to kidney is not improved because both afferent and efferent are constricted. But with vasopressin, only efferent is constricted. With the result, the blood flow to kidney is improved and the renotoxicity is decreased with the infusion of vasopressin. So these are the differences. Then you have given 2 drugs, still there is no response. What do we do next? So, and this happens very regularly with all of us, and what do we do? So go to some other pathway, and this is called as multimodal vasopressor therapy. The other pathway happens to be the angiotensin 2, and this acts in a completely different pathway because it activates the RAS. And remember, lungs are involved in sepsis, and lungs are the source of ACE, and ACE is low. When ACE is low, angiotensin also will be low, and that's why supplementing angiotensin 2 can obviate that natural deficiency and increase the blood pressure. So, so this is what I've already explained to you. The other thing is, it also stimulates adrenal to produce the angiotensin 2 to produce aldosterone, which causes sodium and water retention to augment the actions of increasing the blood pressure. Okay. So this becomes the last resort. We are left with no more drugs. Okay. But there is one danger with angiotensin 2, that is increased risk of DVTs. The deep vein thrombosis is severely increased, and that's why whenever you give angiotensin 2, please give anticoagulants. Heparin has to be given to alleviate the risk of thrombosis by angiotensin 2. Okay. All fail, all 3 fail. What next? So what does it indicate when all 3 fail? That means the microcirculatory failure has happened. The microclots have blocked all the organs, and you cannot overcome the shock. It's an irreversible shock due to microclots and cytopathic hypoxia. So just a quick revision of it. Initial phase norepinephrine, then you add an inotrope like duobutamine if there is cardiac dysfunction. Then you have this refractory shock where norepinephrine, vasopressin, in combination with the hydrocortisone, angiotensin 2, that is a final cocktail we have to improve the blood pressure in a septic shock patient. So we have come to the most controversial topic of use of antibiotics in sepsis. They have got the highest benefit when used upfront, but once, I want to tell all the postgraduates, we receive patients late when almost everything is over, but we go on pumping antibiotics. We can only prevent the nosocomial or the hospital-acquired infections, but the primary infection has done the damage and is gone. And you're not going to cure the earlier component once it's too late now. So what is the timing of antibiotic? Antibiotic has to be given within 1 hour. Within 1 hour, if sepsis is definite. Don't think about shock or whether it's there or not. When you suspect and you think it is probable or confirmed sepsis, give antibiotics within 1 hour. You start both fluids and antibiotics simultaneously. But when sepsis is a possibility and you are not sure that sepsis is the cause, because to confirm it, of course, we need a different type of gadgetry. We have a grace period of 3 hours if sepsis is a possibility. But if it is probable or definite, within 1 hour, we need to go for the antibiotics. Then how do we give antibiotics? See, a patient of suspected renal shutdown or renal failure has come to you. We immediately start calculating the renal doses for that particular antibiotic. But as per the latest guidelines, always use the high end of dosing range for the first dose to ensure attainment of therapeutic levels regardless of renal function. The first dose should be normal dose. Please do not titrate the reduced dose because you need to reach the MIC very quickly. You cannot dodge around. You have to give the first dose, okay? And to maximize the bacteria to be in the range of minimum inhibitory concentration, they have to be given as infusions and not IV pushes. Okay? Please give infusions of 4 to 6 hours so that these antibiotics have the MIC to take care of the sepsis. Okay? Renal adjustment should be done only after 24 to 48 hours. Then we follow the renal dose adjustments. It's a very important point. Please make a note of it. And the ADAPT trial 2025, okay, they have come up with some suggestions. Procalcitonin is used to stop antibiotics, not start. Okay, if there is a fall in procalcitonin, that means you have hit the target properly and you can de-escalate the dose or reduce the number of antibiotics. So procalcitonin is not used. It is primarily used to know whether it's bacterial, fungal or viral. That is one. But once you know it's bacterial, it's basically to de-escalate the doses, not for the initiating of antibiotics. Now we have got this MALDI TOF panels where you can get the organism within 6 to 8 hours. That is the advance that has taken place, and the matrix assisted laser desorption ionization that has taken over or revolutionized the management of sepsis in advanced countries. Okay. We are always worried. As long as the patient continues to stay for 21 days, we go on pumping the antibiotics, because the analogy and understanding of pathogenesis of sepsis is once you lose track of sepsis upfront, there is no point. Everything else is due to immunity and the host modification, dysregulation, rather than the sepsis. Okay. So shorter courses of antibiotics are recommended. 5 to 7 days are now recommended. Okay. And the longer courses are only reserved for staphylococcal bacteremias and the endocarditis and unresolving abscesses. Okay. Now, we had a discussion, interesting discussion in the morning. What antibiotics for what things? I think I'll not elaborate on this. Already enough has been discussed. For one thing, the MDR risk or hospital acquired, we go for a carbapenem with aminoglycoside like plasmomycin, or the new beta-lactamase or beta-lactamase inhibitor, ceftazidime, avibactam combinations. I was telling you about this siderophore cephalosporins. They have Trojan horse-like effect where they get into the bacteria and block the iron-seeking system. That is on which these bacteria thrive and kill the bacteria. They are very, very handy when we are dealing with MDR or XDR antibiotics. So early de-escalation. Now I told you the gadget which gives us within 6 to 8 hours the type of bacteria. So you can de-escalate the dose or come down to a lesser antibiotic if the organism is susceptible. Okay. Now there are some innovations that have come up for ventilator-associated pneumonias. There is what is known as inhaled amikacin or colistin, which attain very high concentration in the lungs. It's almost called as local therapy. The important thing is never cross the 7-day rule except for staphylococci and acinobacter and pseudomonas. For all other things, 7-day course is sufficient. Okay. So how do we use steroids? This is another controversial topic. No single trial has given clarity, because we have seen how steroids can be life-saving or detrimental in COVID. We have propagated the infections of fungal infections during the time of COVID, and that's the reason why there are aggressive views, pragmatic views, precision views, and the consensus is to go with 50 mg of hydrocortisone 6th hourly along with fludrocortisone. That has got the best results as far as steroids are concerned. So triage, we have already seen how quickly we have to go through, measure the lactate, send blood cultures, broad spectrum antibiotics, fluid resuscitation, and vasopressors. Okay, we have read about all this, and now coming to the topic that has been given to me, the current advances in sepsis management. I'll try to quickly go through. I have just underlined this aspect of it because PD-1 inhibitor, PD-L1 inhibitor, the granulocyte, macrophage, colony stimulating factor, and interferon gamma, these are the things which are being very frequently used as the latest trends in management of sepsis. And you can see the progress that is going on. At every stage of sepsis, see, you have got antibacterials at the time when the sepsis has not entered into the body, then the PAMs and DAMs, anti-LPS antibodies and polymyxin, they can neutralize at this stage only. The cytokines can be neutralized by the anti-TNF antibodies, TNF fusion proteins, then the immunosuppression. That immunosuppression you can attain by glucocorticoids and statins. Then under immunosuppression, we have already seen the PD-1 antagonist, PD-L1 antagonist. Okay, so the list goes on, and all these are on therapeutic trials, and the next 1 or 2 years is going to give a clarity in further management of the guidelines will come out. In fact, it was supposed to come out in the first quarter of this year, but because so much research is going on and finality has not been achieved, they're waiting for these guidelines to be framed. So these are all the immunomodulatory drugs which are being generally used in the sepsis. Okay. And I've already explained this slide to you a number of times. Nivolumab is the current drug which they have found exceedingly well to block this programmed receptor 1 and programmed death ligand. So these two are being blocked by nivolumab and the short-acting peptides named as compound 8. They are in experimental level, but they have entered almost phase 3 trials in the European this thing, and they are doing very well. Now, sepsis, we treat all septic patients as one, but the phenotypes have entered. After the COVID, the phenotypes, each phenotype means a set of patients who have a typical set of biochemical and laboratory manifestations. So we have got the hyperinflammatory phenotype, the hypoinflammatory phenotype, okay, and fluid responsive phenotype, vasoplegic phenotype, septic cardiomyopathic phenotype. So each one of it requires a separate analogy, separate workup, and separate treatment. I'm going to leave this presentation with you because I cannot dwell into every final detail. It is such a huge topic. I wish Kalyan Chakravarti Garu allots one full day for sepsis. It cannot be 1 hour discussion. Okay, I'm sure he knows what I am talking because he himself is a specialist in that. So much is there. Only pathogenesis will take 2 hours. Only fluid resuscitation will take 1 hour. So for to present all this in under 1 hour and to have your attention for this long, it becomes very difficult. Okay, I'm trying my best. I'm looking at everyone, all of my students. They are scared to even move away, but I'm sure you're all exhausted by now. But there no other option. Please be, I don't know how Bhaskar sir is feeling. Please put up with me, sir. Okay. Okay, sir, we are too old for that. Okay, then we have in 2018, one person in Pittsburgh, a scientist, has discovered 4 phenotypes of sepsis patients. And each septic patient has a different set of management. And we have only one standard protocol to push to everyone. And if you push one protocol to other protocol, that fellow will sure to die. So our rate of success is 25%, because 75% we are treating wrong. So postgraduates, future is yours. Please concentrate on these phenotypes, identify them. These are the 4 phenotypes. A very important slide for future of sepsis, the alpha, the beta, the gamma, and the delta. If you see, each phenotype has a different organ involved, a different manifestation, and see, if you are giving beta, the beta is fluid excess person, and as soon as it enters our casualty, we push 2 liters, he is gone. Okay? So that is when so the older patients, comorbidities, significant renal dysfunction. When do we get our serum creatinine? After 2 liters or 6 liters of fluid. That is when we get. So sepsis is a challenging management analogy, and we need to be prepared to, I don't know how our state body is going to deal with this in future. They should come out. I feel, Kalyan Chakravarti garu, you should come out with local guidelines to guide the medical colleges and hospitals, so that what is within our purview can be practiced instead of these hypothetical discussions. What can be practiced? So please bear in mind alpha, beta, gamma, and delta. Delta is one, it's almost gone, because in the best of the best centers, the mortality is 40%. So the only way you can improve delta patients is you have to go for the removal of cytotoxins. How do you remove cytotoxins? And that's what I'm going to go for. Okay? So please remember alpha, beta, gamma, and delta. Okay? And another person came up with another 2 phenotypes, the SP1, which is stable fellow, and SP2, who is hyperinflammatory. And once you categorize SP2, you have to be very, very careful with the fluid administration. Okay? Then the most important thing which has taken over the management aspect of sepsis is hemoperfusion. Because what is happening in the body? Circulation of cytokines, endotoxins, unnecessary things that are circulating which the body is not able to manage. So what is the solution for this? Pull out them from the circulation. So you have a different types of perfusion cartridges which pull out the endotoxins, cytokines, and a combination of these three. So they are there, they are being practiced, and they are available in India. Only thing is, every cartridge costs only 1 lakh rupee, and we need to use 2 to 3 cartridges, but it is life-saving. There are people who can easily afford it, but lack of knowledge makes us blind on these therapies. So hemoperfusion, within 6 hours of admission, they do this analysis of biomarkers. If they find high levels of interleukins and endotoxins, they connect them to cytosol, or I'll just show you, these are the things. The endotoxin absorbers, the cytokine absorption, and multimodal. See, taramycin is the polymyxin cartridge, which pulls out the PAMs, DAMs, and endotoxins. Then cytokine, cytosorb, it costs some 92,000. You need to use 2 to 3 cartridges per day for 5 days. and the patient is generally off either alive or gone. So the cytokine, cytosorb is a very important addition, and the oxyris is, it has revolutionized the management of sepsis in Europe because it has got bimodal. It is a, it can be used for CRRT and for hemoperfusion. I'll tell you what is hemofiltration, hemoperfusion. I think bell also has gone. What happened to the bell? Anyway, thank you for allowing me to take your time. Okay, so the current guidelines are the Asians, where a lot of research is going on with regards to these cartridges, they are allowing them, whereas USA, they are not doing anything now. Trump is focused on other things, oil and other things. There is no progress in medicine. So they are just sitting silent, and that's why they are not allowing anything to be imported. So cytosorb is a very, oxaris are the two things which has revolutionized the management of toxemias upfront. So hemoperfusion is a double-edged sword. Why? Because it is a blind way of absorbing things. It can absorb the good proteins, nutrients, and also the antibiotics in the system. So to that extent, it has got that negative impact. So that's why whenever you are putting a patient on cytosorb or oxalis, you have to escalate the antibiotic doses to accommodate the absorption and fall in MIC levels. And this is a extracorporeal immune cell therapy, very famous in Singapore. People, our politicians who take our money, they go and get treated in Singapore with this. It's very severely expensive. Extracorporeal immune cell therapy, what it does is, it pulls out the bed from the body, and the granulocyte cartridge will be there, which kills the circulating bacteria, and purified blood is sent back into the system. This is called as extracorporeal immune cell therapy. And these are all the latest gadgets you have for managing sepsis. The plasma exchange, the renal assist devices, the adsorptive therapies, the convention therapies, the combination therapies. So science is evolving, and I sympathize with the postgraduates because we never had to struggle so much to expand our knowledge. Things are getting out of control. So what is hemofiltration? We have talked about hemoperfusion. Perfusion is an adsorptive technology, whereas a filtration is through, it's a dynamic process. It filters through a membrane, and this is more useful when there is coexisting renal problem, or when there is hyperkalemia, hypokalemia, acidosis. In such conditions, hemofiltration is preferred over the hemoperfusion. So these are the differences, adsorption and convection. The large molecules is targeted by the hemoperfusion. The small molecules like urea, creatinine, electrolytes, and other things are taken care of by the hemo. CRRT has revolutionized the management of sepsis and renal failure. I'm sure if any new, people who are dealing with these ICUs, definitely CRRT has become a very important tool for us in the ICUs. Okay. Now, what is the modern approach? We do both hemofiltration and hemoperfusion, and this is called as hybrid approach. Hybrid approach. So choose hemoperfusion if you are sure about sepsis and cytokine surge. Choose both the conditions. Then the nano. Just 5 more slides. Please bear with me. Okay. So the nanotechnology has transitioned a promising laboratory research into a critical pillar of precision sepsis management. The focus has shifted from general drug delivery to active nanomedicines. Okay, nanoparticles are themselves a therapy for neutralizing the cytokines neutralizing the cytokines. Okay, so by sequestration and immune reprogramming, nanotechnology has taken over the future of sepsis management. Okay, so there are nanosponges now which act as a decoy. They are coated in platelet membranes, and they do absorption of the toxins and also decrease the bacterial burden. The nanodiagnostics, look at this. We are proud of being an Indian. Okay, we only tell that, but we don't know any Indian who does research. Okay, and here is one. I introduce our madam, Dr. N. Sandhya Rani, who has identified 10 nano sensors, biosensors, and she is from Calicut, and they are going to, she has got patent for that. They are going to release it into the market, and the beauty of it is a multiplexing nano sensors. What is multiplexing? It just doesn't sense the cytokines and endotoxins. It also senses the procalcitonin, the CRP, interleukin-6 within 10 minutes. Within 10 minutes, you put the chip, you get the diagnosis. Okay. So we are proud of Dr. N. Sandhya Rani, professor, a lady who has invented this, and they are going to come into market very soon. And you know, whenever an Indian finds out something, it's more difficult to market it because we ask questions. Whereas some Lou, some Kim, some Michael sends it to us, we take it for granted. That's the unfortunate situation. This is the, this is another, the magnetic blood purification. What is it? How it works? Tiny functionalized magnetic nanoparticles are infused into the blood. These nanoparticles, they go and absorb the bacteria and toxins, and they are pulled out through an extracorporeal circuit, and magnets are placed, and these magnets along with the circulating bacteria are pulled out of the system. This is called as magnetic blood purification. Mind you, this is going on in South Korea, Japan, and I'm sure China must be having it, but they won't tell. Okay, so this is actually given as a rescue therapy for sepsis. And this is a smart filter which has, we have seen the other filters, Cytosorb and Oxyrase and all this. This is a nano filter. This is a nano filter. It can be fit into any CRRT machine, okay? And during the golden hour, it does what we can do in the next 7 days. In 1 hour, it will remove all the filters, and it is waiting for the, approval by the Infectious Disease Committee. So we have got, I think I'll wind off, the sponge, the guided hemodynamic support, and this is the magnetic therapy where the bacteria are clinging to the magnetic beads, okay, through the filter they have incurred. These Taiwan, Chinese, the Japanese, they are very good at inventing these things, but somehow they are not endorsed by the rest of the world. And look at the bacteria clinging onto that, and that's the easy way of filtering the sepsis upfront. The nanotherapy, nanodiagnosis, nanotechnology, that slide tells you all what is going to happen in future. And this is the classical patient of immunotherapy, immunoglobulins, metabolic resuscitation, vasopressors, low perfusion phenotype, the hemoabsorption, high endotoxemia, hypercytotoxemia. So there are so many gadgets around him, but no doctor. So that is the future of sepsis and its management. Thank you. Thank you all for the patient hearing. Thank you very much. Just want to thank my son. He helped me prepare this, and really, because this is 1 month preparation for me, because I started as an undergraduate student to study sepsis in the current, because so much has evolved after COVID. I tried my best to put it across to you. I hope I could convince you that there is hope for sepsis in future. Thank you.
Thank you, Dr. Sudhakar. It's a oration, we will not be talking much, but only thing is, as a close associate of Dr. K.B. Krishnamohan, on this auspicious and special occasion of lecture on Krishnamohan's oration, I'd like to share a few things with him. First, I dare not sit to talk about him. See, Dr. Krishnamohan, it's only, there are so many things to recapitulate about, but I tell only a few issues which touched me and which are relevant to the situation. Already covered in biodata, such a brilliant student. One thing was a Phillips blue ribbon holder in Madras province from Madras Medical College. That is, it's a regular one, that's okay. It is pertained only Madras Medical College. But one day, when he was upset with a little in his service promotions, I just went to his house to share the moments. Then he was talking, then he told Dr. Bhaskar, just I will show you. He went to the car shed and brought one old book. It was a Madras Gazette. In that, the service commission list was there. And in the selection list, that K.B. Krishnamohan's name was number 1. That means, at that time Madras province means it covered Andhra, at that time Andhra, Karnataka, Tamil Nadu and also Kerala, I think. For all these things, his selection was first. And he has showed me a few members where his promotional avenues have been surpassed. They were all behind him. You know the second person in that list was Dr. Thiruvengadam. I don't know whether anyone of you heard his name. He is a giant in Tamil Nadu. Such a brilliant man was only second to Krishnamohan. I happened to see him in one of the conferences. He was invited to Thiruvengadam only to speak to the audience for the glorious days he had. They have called him to see this. This is about it. I need not speak about his, so many things, but only one thing I tell you, how intimately, to the fathoms, he goes about an issue. You were conducting internal assessment in those days. You were 3 assistants. You were given that internal assessment, he was allotting us to correct. 3 assistants, myself, Dr. Ramchandrudu and Dr. Habibullah. He gave bundles. We have corrected and he will not accept our marking. He will ask us to bring all things to him. So we carried them to his house. After sitting for 2 hours, he called us. Then he started looking at the random. Each paper will say for 1 minute, keep. One paper he picked up. That was corrected by Ramchandrudu. In that, one of the questions was B12 disorders. Dr. Ramchandrudu gave 8 marks out of 10. You know what he has said? Dr. Ramchandrudu, what more you expect this student to write if you want to give 10 to 10? That means he wanted to know whether the gentleman has assessed properly or not. Then Ramchandrudu said, 10 it is also. What the thing you have to appreciate is, then he told, I too feel, Dr. Ramchandrudu, this candidate has written all about, for an undergraduate, all about B12 deficiencies. I don't think there is anything to be added to give to 10. I think morally he deserves 10. That's only I wanted to make. This is how he was trying to go into the fathom of the subject, fathom of the assistants, how they are correcting or not. You have to read and then consider. This is all about Dr. Krishnamohan. It was a very lively time. Now all are exhausted. Now this giving a memorial lecture in the name of Krishnamohan, I really appreciate the organizers. That is, Dr. Sattar has taken the lead to introduce this lecture. Just I am recollecting the good deeds of Dr. Satar. And I also appreciate our Department of Medicine for putting this lecture as a priority here in this thing. And Dr. Sudhakar really delivered a scholarly lecture fitting into the Dr. Krishna Mohan's credentials. It's a scholarly lecture. But yeah, scholarly lecture I said, because for okay. So this is I've been observing all our audience. There was no sign of any getting overloaded with the subject. Everybody is curious. He made such a analytic use of the sepsis. I think it is a fitting person chosen to deliver the lecture of such a great man, Dr. Krishna Mohan. So Dr. Balkonde also joins me to give standing ovation to Dr. Sudhakar on this occasion, and also to Dr. K.V. Krishna Mohan. Finally, I thank this Department of Medicine for inviting us to this very auspicious sessions. I wish such things to go. The University of Science, also Dr. Chanskara also has been telling, it's very nice that he has come and graced this occasion, and hopefully the other people who are involved in this infectious disorders will definitely continue this medical education program in this. Thank you.
Thank you, sir. Now I request the three chairpersons to please facilitate Dr. Sudhakar sir garu. Sir, please. And I request Dr. P. Srinivas sir and C. Srinivas sir to come and join during the felicitation.
Now, I feel we are justified in selecting Dr. Sudhakar for this oration. Thank you very much, sir, for your exhaustive lecture.
From matching lehenga tops to Sangeet ready fits, wedding wardrobe essentials.
Speak something.
I introduce myself as Dr. S. Nagaraj, MD, retired professor of medicine, Kurnool Medical College, Kurnool. After listening to the exhaustive lecture of Dr. Sudhakar, I think is there anything left over? Must be. sepsis 1, sepsis 2, like Bahubali 1, Bahubali 2.
Thank you, sir.
So the chairpersons stay on the stage, sir. We'll have small mementos. Chairpersons. Yeah, yeah.
Thank you. I just take a minute of yours. We are what we are because of the training we have received. I cannot forget the teachers I have been trained with. Really indebted because some of my immediate juniors or contemporaries are here. Dr. Bhaskar sir, Dr. Bhavani Prasad sir, Dr. Malkonde sir, Dr. Devanand sir, Sivaraj Abba sir, and above all, our relative Dr. Nagaraj sir. They are all monumental in bringing this department to this stage. I am just a speck in front of these people. Sri Ramalu made that speck into a vision today. I cannot forget that, this privilege I have been given. I am really indebted to my teachers, the department. Thank you very much. And this is the best time I have been in my life to be felicitated by my teachers. Is one thing my life is made. Thank you.
I request Dr. Nagaraj sir to present a memento to Chairperson Dr. Bhaskar sir. I request Dr. Bhavani Prasad sir to present the memento to Dr. Malakonda sir. I request Dr. Srinivaslu sir to present the memento to Sri Ramalu sir. Both Srinivaslu sir. Both Endo and Nero. Thank you, sir. Thank you, everyone. Now we move on to next session.
Sir, please stay on the stage, sir. Today, a small surprise program for us. We are going to give a small felicitation for our new registrar, Dr. Sai Sudhir, sir. It's a great privilege and great honor for the institute that he is being selected to be the registrar of NTR UHS. A surprise felicitation for him, sir. I think he also doesn't know about this. Please, Sai Sudhir, yeah, come on to the stage. Sir, please, sir. The senior persons, please be here to felicitate him. I request the professors of the Department of Medicine also to come on, sir. Join. Come, sir.
Very happy, sir.
Sir, HOD, sir. Sai Sudhir.
I congratulate Dr. Sai Sudhakar. Only thing I want to tell her, he is the son of my classmate, Dr. Rangson. Very, very happy about it.
Good afternoon to all the dignitaries, my teachers, my friends, my colleagues, and my students. There are no words for me to say anything. I do my best for the college and for the university. Thank you all. Thank you.
Yeah, please, all of you, go, join the lunch, and we'll be here within 15 minutes, as we are running short of time. I request all the delegates to be here within 15 minutes. Thank you.
After lunch, we will proceed with panel discussion at 2:15 p.m.
Enterococcus faecalis, Proteus, Pseudomonas, Citrobacter, those are the commonest organisms.
And to the clinician colleagues, would you always order, so the general teaching is that uncomplicated cystitis, they may not always require a culture, but would you, this is something that you routinely do in your practice?
Yeah, routinely not required, but as we are seeing multi-drug resistant UTS nowadays, so it is, I feel personally that it is mandatory to order the culture sensitivity, so that you can titrate the antibiotics. So
And sir, what would you, at this point, having sent a culture, would, in fact, let me ask the audience, since they're all quite full. How many of you would start something like trimethoprim sulfamethoxazole for this patient? Your CME points are subject to voting. I'll speak to Dr. Rajesh outside. Nobody wants to start cortisone. How many want to start nitrofurantoin? Quite a few. How many would start, there's a lot of resistance, right? How many would start pharopenem? Nobody wants to start pharopenem. There's such a lot of resistance.
No urologist here.
Okay. Sir, what would be your choices up front?
To be frank, I think your next slide also came up, but that's a good thing that it's you have also put up them. As of now, yeah, nitrofurantoin definitely is a good choice, but considering what's happening now, I think not more than what we are about to start, we need to understand what's there with us right now. I think every at least the hospitals like Kurnool Medical College or the institutions should have their own antibiograms. That's the most important. Before saying I would like to start that, why is the question? So I maybe the short of time, but I would like to quote this very particularly in front of everyone who is sitting here. So before I started my certificate course in UK, there was Sarah Atkinson was my course director. She came to Rome. We were there in Rome. We were a couple of South Indian physicians having a tea, and she was passing by. So congratulations, madam. The lecture was good. Then she asked, "Who are you all?" I said, "We are all physicians." She asked, "Are you all ID physicians?" No. Okay. Then the chat was going on, and then she asked, "What is the commonest antibiotic you use for an upper respiratory infection?" Everyone was selling their own thing. One was saying cefixime, one was saying azithromycin, one was saying doxycycline. Then she said, "You don't have any antibiograms or anything like that." Sorry to say this happened in 2014 or 15 when I started my program. But still, we are yet to have our own model, because we can start whatever you want, but we should know what to start based on our antibiotics. That's my answer, rather than to say, I will start nitrofurantoin. Maybe sometime down the lane, maybe I may not, because I might see it a resistance. Of course, as of now, empirically, a good choice, but we should have an antibiogram before saying that.
Right, right. So I'll just show the slides that you were talking about. So across India, if we look at the regional network, what madam said is absolutely what is seen across the nation also. E. coli and Klebsiella in this country are more common than gram positives. Enterococcus comes a little far below, but it's also important to know what is local to your place. So for example, this is the data from my center from 2024. Looks quite similar as far as distribution goes, but the choice of antibiotic is guided by guidelines one, but also by your local antibiograms. So anyway, in this patient, this was the report that came out. So this is a ceftriaxone resistant Klebsiella pneumoniae, which is resistant to the common BLBLIs like piptazo and cefoperazone sulbactam. It is also intermediate susceptible to ertapenem. Imipenem looks sensitive, and some of the higher drugs are reported. Nitrofurantoin is resistant. Cotrimoxazole is sensitive. Yeah, and it's an ESBL organism. So this is the report. So would you like to, or now that nitrofurantoin is resistant, sir, would you like to change?
Yeah. Now the question, actually when we went back, that patient walked into the outpatient department. We were suspecting just cystitis at that point of time, but I think it is preferable to conclude the clinical scenario with the help of other investigations, because that is going to actually
no, assuming that it is still a cystitis, but it's an ESBL producer.
So you, ESBL producer as of now, because AMP-C, we do not have much probability of saying we can detect an AMP-C directly without any molecular testing available. So in that case, considering it might produce an AMP-C, or down the lane, the doubt if it is still existing, then probably not many molecules are there, to be frank. In a situation like that, if the patient is sick enough, you have to, earlier we were using carbapenims, or probably a cephalosporin within this, previously there was tazobactam, now the newer molecule like enmetazobactam. But if you say the patient is completely stable based on the report, I think we can still try with oral drugs.
With cotrimoxazole? Yes. So
regarding quinoline susceptibility, being a critical care specialist, most of 50% nosocomial infections because of gram-negative organisms, it is Pseudomonas, E. coli and Klebsiella. So among all quinolines, ciprofloxacin, moxicillin, levofloxacin, ciprofloxacin is more potent, effective against the gram-negative organisms. So in empirical therapy, we will start with third generation cephalosporins, because third generation cephalosporins are acts against the gram-negative, whereas first generation gram-positive. So, and among with third generation cephalosporins, that is ceftriaxone, will start with amikacin, in combination of amikacin. If at all patient is
having renal impairment, in that scenario, we'll stop the amikacin, we'll use the ciprofloxacin. So
You're talking about the ICU UTI.
ICU, yeah, ICU. I'm talking of being a critical care specialist. I'm talking about most of our nosocomial infections are gram negative, 50%. Only 10 to 20% are gram positive. So here gram negative are E. coli, Klebsiella and Pseudomonas.
But are you comfortable starting ceftriaxone, sir? Because
Yeah,
knowing that
actually, if in early stage we'll start ceftriaxone third generation. If at all in late stages or in fulminant infections, if at all patient is suffering fulminant infections, that is Klebsiella with E. coli, we'll directly start piperacillin and tazobactam or meropenem.
does the antibiogram, does it support that, ma'am? In your center, is there a lot of ceftriaxone susceptibility to gram negatives?
So,
More resistance is seen for ceftriaxone and also for quinolones. 20 to 30% susceptibility is observed.
Yes. So usually I think knowing your antibiogram, Dr. Kalyan also
As
wants
such, the
to say
report
something.
shows that cotrimoxazole
And it is, in this case,
sensitive
it
to
is,
cotrimoxazole, and we can additionally give oral phosphomycin single dose. So that will suffice. Or if it is, we are suspecting AMC and everything, then we can shift to meropenem.
So I just want to show this IDSA guidance for ESBL infection. As long as it's an uncomplicated cystitis, you are okay using these drugs if they are sensitive. That is nitrofurantoin, cotrimoxazole. Alternative agents, of course, may not work in case of the Indian setting because quinolones have only about 20-30%, like Madam said. Other options are okay. But if this case was a pyelonephritis, for example, again, quinolones and cotrimoxazole in our setting, especially quinolones, may not be a good choice. Cotrimoxazole still may work in 50% of the cases. And our alternative agents are, of course, carbapenems. Outside the urinary tract or critically ill patients, once you know that it's an ESBL infection, meropenem or imipenem are okay. Ertapenem is generally avoided in this population because it is very highly protein bound, and it's always okay to step down if your cotrimoxazole susceptibility is there. But again, quinolones are a big red in the Indian setting. So if you look at the national level data, the ESBL rate for E. coli is something like 75%. It's only 26% susceptible. And therefore, even in the community, there is a pretty high level of ESBL circulating. So starting ceftriaxone would always have to invite a lot of caution. And quinolone, if you see here, it's only 22%. But then again, quoting national data for your use in your hospital is not correct. What you need is the local antibiogram. If you don't know yet, you can reach out to the microbiologist. They will provide you with the antibiogram at least for the last year or so, and you know what are your trends in your hospital. So your empiric choice will be based on that antibiogram. Once you have a report, of course, you can titrate to the narrowest spectrum. Right? So this is from my hospital, for example. It's definitely better than the national level data, but again, Apollo is a tertiary case, and we get patients who have already been to several other hospitals and then come here. But that may not be the case in Kurnool Medical College, for example, where you get patients from the community. They may not have such high levels of resistance, but you need to know that, okay? So this is some of the agents that we tested in the last 3 months specifically against ESBLs, and this is how it looks like. Cefepime almost never works for ESBL infections. Amoxiclav is, again, there is also a very high rate of recurrence in the clinical scenario, so generally it's avoided. Some of the other BLBLIs, piperacillin tazobactam, for example, by IDSA itself has sort of put it in the dustbin. But other BLBLIs seem to show some promise. Cefepime and enmetazobactam. Ertapenem, of course, works for ESBL most of the time. And this was a trial which compared cefepime and enmetazobactam with piptazo and found that it was not only non-inferior, it was also superior for treating complicated UTIs. But of course, the baseline ESBL rate in that population, which was mostly Europe and America, was 21%. I hope this is coming through. Sir, you have any experience using some of these options?
Newer ESBLs in the sense cefepime and
Newer
enmetazobactam.
BLBLIs.
So I thought, I was telling you, we need to actually tell them exactly what we are actually speaking. Because beta-lactamases, how many of you are, other than studying for the exam, how many of you have actually used it for your regular practice? So the time has come for the, at least for our country, 100% we need to know what we are doing when we are selecting an antibiotic. Because I remember when cefepime enmetazobactam was launched, we had some meeting like this in Guntur, and then following days I was seeing some prescriptions having both meropenem and cefepime enmetazobactam in the same patient. So the reason is probably understanding of those 4 classes. Can you please quickly, if possible?
Sure. So let me break it down like this. Let's not even go into classification. So can you name some beta-lactams? Can you name the first, who will do this? I'll maybe pull somebody out. Second year PG, can anyone raise your hand, volunteer? So you know the beta-lactam classification, you would have read in Tripathi at some point of time, right? So there are penicillins, then there are penicillinase stable penicillins, then you have cephalosporins, which are first generation, second generation, third, fourth generation, and then you have BL, BLI combinations, okay? The reason we need BLI, BL combinations is because these beta-lactams can get broken down by enzymes which are produced by bacteria, mostly gram-negatives, that will break down that beta-lactam ring. You understand, the penicillins, all of them have a ring, a beta-lactam ring, which is hydrolyzed by these enzymes. So the enzymes vary in severity from very narrow spectrum to very extended spectrum. So typically we call third generation cephalosporins as extended spectrum beta-lactams. And the beta-lactamases that break down third generation cephalosporins and above are called, correct? So things that break down extended spectrum beta-lactams are ESBLs. But even beyond that, you have another class of drugs called carbapenems. Every one of you is familiar with that. There are enzymes that can break down those drugs also. They are called carbapenemases. So that is even a higher spectrum of hydrolysis, right? So here in the first case, we were talking about an ESBL producing bacteria. Did we actually look for production of ESBL either by a molecular technique or by some phenotypic? Not exactly. Generally, if it is a ceftriaxone resistant E. coli or Klebsiella, resistant to aztreonam also, we consider it to be an ESBL. There are various kinds of ESBL. There are TEM types, SHIF types, CTXM types. But for all practical purposes, remember that if it is a ceftriaxone resistant, aztreonam resistant isolate, it is likely to be an ESBL, if it is an E. coli Klebsiella. I don't want to go into AMC and confuse them further.
Yes, that should be enough, I suppose, for them.
Right?
So now, yes, ma'am.
No, so please.
Yeah. So now, having got what ESBL means, probably from what madam has told, now, we have been seeing people using, I mean, we can ask this question like this, probably they will answer. Whenever you see a case, I mean, many of you are general medicine pages, right? Most of you. So you are the ones who are going to see the patients in the emergency room first. So you have a typical model of treating the patient. So what are you doing? At least one of you can tell. What are you actually giving when you're starting an antibiotic?
You get a prize, whoever volunteers.
Either I'll also give the answers by myself. Piperacillin, tazobactam, and then third generation cephalosporin of your choice, like ceftriaxone, sulbactam. Are these the ones you are starting or not? At least tell me this is enough. Or you're not starting anything at all. Yeah? Piperacillin, tazobactam.
Piperacillin, tazobactam is what
at least to certain extent now that is what madam is trying to confer upon. Okay, now you're targeting an ESBL. Now madam is asking, are there any newer ESBLs where the situation is where probably your piperacillin, tazobactam doesn't work? If you would have seen, I think you can show that slide, madam, previous slide, where you showed piperacillin, tazobactam was having some 60% resistance as per that national data which we had. That, if you can see over there, has got a that
also
one.
this is easier to read.
Yeah. So you have a significant resistance there, piperacillin, tazobactam. So madam is asking, instead of piperacillin, tazobactam, would you like to use anything else, newer drug options? Okay. Fine.
So anyway, so there are more potent spectrum BL, BLIs, and then there are, but of course, what is most important to know is what you're dealing with first. If you're not dealing with an ESBL, you're dealing with a pan-sensitive organism, there's no need to use piptas. You can even de-escalate to ceftriaxone. Okay. So we'll just move on to the second scenario, or shall we just?
Yeah, we'll do that.
We'll do this? Okay. So this is a 70-year-old male patient with diabetes, admitted with fever, chills and rigors and flank pain. Patient is in septic shock. And there is imaging evidence to show that there is pyelonephritis. So we discussed the cystitis and now this is a pyelonephritis and in a critically ill patient. So intubated, DJ stenting done, and initially he was managed with some antibiotics. I think sir has answered generally what you see in the ICU as far as bugs are concerned, like enterobacterials and pseudomonas. And so what would be your empiric choice in this case, like a pyelonephritis in a critically ill patient, going by your local data?
So, in critical care units, commonly gram-negative organisms. Among gram-negative organisms, E. coli and Klebsiella is main, and Pseudomonas also. So, most of all Pseudomonas, this Pseudomonas releases the beta-lactamase. So, we're supposed to give the antibiotic that supposed to having the property of anti-Pseudomonas beta-lactamate property, because ICU patients are critical ill patients. So, we straight away start with this carbapenem drugs, that is imipenem and celastine like drugs. If at all, some gram-positive organisms also causes this UTI in critical care units. That is Staphylococcus. So there is a methicillin-resistant Staphylococcus aureus. In that fulminating infection of Staphylococcus aureus, if at all this response is not with carbapenems that are acting against the gram-negative organisms, if at all this sepsis is persisting, we'll supposed to go for vancomycin. Vancomycin is having potent gram-positive activity. So these commonest organisms are this, and coming to gram-positive, Staph aureus, Enterococci, cocci are main organisms that causes infections, urinary tract infections. Apart from that, in most of all ICUs, that is CATI, that is called catheter-associated urinary tract infections. So whenever, because of this presence of Foley's catheter in urinary tract, it may causes again in further investigation infection. So changing of the Foley's catheter is important, and coming to conventional Foley's catheter, we are using latex Foley's catheter. So latex Foley's catheter, there is colonization of these gram-negative organisms, or chances are more. So you're supposed to shift it, remove that catheter and secure the silicone catheter. Silicone catheter is a smooth catheter, and its biocompatibility is more. So colony formation is very less. So this is my opinion.
Right. So these are escape pathogens, and it's a useful mnemonic to know. But again, this is a global mnemonic. We might have to adapt that to the Indian situation. In the Indian ICUs, it is the gram-negatives that really predominate in the ICU environment, especially the enterobacterials, Staph aureus to some extent. This K is now changed to C. difficile and Candida auris, which also you should be a little aware of, Acinetobacter, Pseudomonas and Enterococcus faecium. So all of these together contribute to about 80% of the infections in the ICU. Again, important to know what is local to you. For example, in my center, we actually see quite a bit of Candida. The third most common bacteremia isolate that we see is yeast. First is Klebsiella, followed by E. coli, and then yeast. So anyway, in this patient, this was a bilateral pyelonephritis in a patient with septic shock. Turns out it was a pretty resistant bug. It's resistant to your third generation cephalosporins, indicating that there is likely to be an ESBL. Then there is resistance to BLBLIs, and there is resistance to carbapenems, which indicates that it is likely to be a carbapenemase producer as well. So what options are we now left with? We have, this is a pyelonephritis, so you cannot use nitrofurantoin even though it shows sensitive on the report. Okay, it does not have any penetration into the kidney. There are aminoglycosides that look sensitive, amikacin, plazomycin looks sensitive, and then there is fosfomycin, which is sensitive. But again, we'll discuss that. And then there is colistin, which has an MIC of 0.5, which is by definition intermediate. And then there are cyclines, which are again not useful for urinary tract. So in this case, sir, would you like to change your therapy from meropenem now, knowing that it is carbapenem resistant?
So to be frank, in a situation like this, now we have the organism here? Okay.
E. coli.
E. coli is there. Yeah, considering what we are hearing now with this PBP3, generally speaking, if the creatinine is stable enough and things are in India, I would say that colistin is the choice initially. I mean, though people might say the new avibactam or whatever it is, we have felt, at least we are comfortable in starting with colistin, because, or if the patient is significantly sick enough, probably where we don't have much time.
Any role for these newer?
Yeah, the other one that's recently come up is the plasmomycin, which we could, yeah.
Sir, I have one doubt. Shall we start colistin empirically?
Not necessarily. Again, it depends on your local antibiogram, sir. If you don't see a lot of carbapenem resistance, especially in E. coli, nationally it is around 20, but even in Apollo it is only around 10. And I'm sure here, if you look at the data, madam can probably add, it may not be so much in E. coli. So you are okay to start meropenem, but what happens when you get a report like this, then you will have to escalate.
When you have an MDR especially. And the other school of thought, especially in a situation, because sir has asked, probably putting it in his perspective, what we have been doing it, because we get patients even in the middle of the night. So based on the antibiogram, they are starting on meropenem at around say 11 p.m. or 12 a.m. in the morning. You have a very bad ABG with severe acidosis, and then you have done what all best that can be done. Supports are initiated, but still there is no improvement. The hypotension doesn't improve in the next 4 to 6 hours. We're asking if they speak to the consultant, and occasionally, as you have asked, those are the situations where we have tried colistin even before the reports were available, and have seen some moderate success based on if the creatinine was good enough, but not every time. Yeah.
Any role for combination antibiotics, sir? Now that many of the single drugs are sensitive, generally we try to avoid combinations.
In a sense, now because we have the report, we have a very clear cut. Yeah.
Madam, any other drugs that you test for carbapenem resistant organisms? Routinely in the lab.
Ceftazidime avibactam we don't have in our institute right now. Ceftazidime clavulanic acid we have, but that clavulanic acid does not inhibit carbapenems. Like fluoroquinolones and colistin and aminoglycosides only.
Aminoglycosides. And any detection of carbapenemases that is done?
Routine detection, modified HOTS test we have. Okay. But NP test and carba NP or the rapid methods and that we are not doing right now.
Okay, so just quickly running through the IDSA guideline. Again, we have to titrate this to the Indian context. I think as sir said in the oration also, we probably have to work on Indian guidelines. So uncomplicated cystitis, even with CRE, if it is sensitive to nitrofurantoin, you can still use. But here we are dealing with a pyelonephritis. So most of these combinations will not work. Ceftazidime avibactam in our country, as sir earlier said, E. coli especially will have a high rate of NDM. And when there is NDM, Cefta-IV is not going to work in most cases. Aminoglycosides may be okay as a second option. The thing with IDSA is they downgrade colistin quite a bit because they have better drugs like Mirovebor, Emirelli and Cefiderocol available, and their epidemiology is different. Okay, so even if you look at these very attractive BLBLIs like Meropenem, Veborbactam, they are not available in India, and for good reason, because the carbapenemases that we see here are different from the ones that are seen in the US. Anybody knows what is a common carbapenemases seen in the US and what is seen in India? What is the capital of India? Oh my goodness. I think you're all in that post-Gutivankaya Kura slumber. Right? So in India we see quite a bit of NDM, which is a New Delhi metallobeta-lactamase, which is not, against which ceftazidime avibactam generally doesn't work. So if you have a CRE, you cannot just use this. You can either use aztreonam in combination because aztreonam is not broken down by NDM. But in E. coli, there is an issue of PBP3 also. Way too much for you people. So, but infections outside the urinary tract, again, there is a recommendation for extended infusion meropenem, but I would tread carefully there because we don't see this non-CPCRE much here in this country. Most of the times you see some carbapenemase which is associated with it. Even if there is a ERTA-resistant, mero-sensitive isolate, tends to be OXA48 most of the time. So we generally tend to avoid these kind of therapies. KPC producers, again, we don't see in India, so these things don't matter to us. Tigecycline, if it is a non-urinary tract, non-bacteremia isolate, you can probably use. OXA48 is where Cefta-AV is still useful. So these are all types of carbapenemases against which you have these options available. So this is again data from my center which compared options for CR E. coli and CR Klebsiella. Colistin remains quite useful, at least for E. coli, 100%. I mean, if you consider the intermediate breakpoint. For Klebsiella, it's slightly lower, it's around 95%. Aminoglycosides between amikacin and plasmamycin, there is slightly better. This is what the US data also suggests, that susceptibility of plasmamycin is better than that of amikacin. Cefta-AV, if you see, see alone, within the CR, it's very low. It's only about 20 to 30% across E. coli and Klebsiella. So most of the time for Klebsiella, you can add aztreonam and 100% of the time it should work. But for E. coli, preferable are the other options. So this is a summary slide for the newer antimicrobial agents, because this is a topic for today's discussion. Of these, we have the available options that we have is Cefta-AV. So what is to remember is it works for KPC, works for OXA48, which we also have. About 30-40% of our isolates which are carbapenem resistant have OXA48. You can get away using Cefta-AV. Works against Pseudomonas. Again in India, that is probably a bit questionable, because many of our Pseudomonas also carry NDM. And then the other efflux pumps, etc. Cefiderocol is not available in India, but it is supposed to have a very wide spectrum of activity. But there are reports that show that cefiderocol is also affected by the modified PBP3, which makes susceptibility less to E. coli. The other BLBLI is not available here. Aztreonam avibactam is now available. Doesn't work well for Pseudomonas, especially in the Indian context, doesn't work at all for Acinetobacter. Cefi-ZD is a drug that kind of works across all these. Fingers crossed, maybe at least for some time to come it will still be working. It is yet to be fully available though in India. So any of these options you have used, sir?
That cefiderocol thing actually we used for a couple of patients and found it to be not great. Then I remember this 2024, 2024 Balaji sir was not there. He was in Korea for a conference, and he was presenting the slides. I just bumped into the room. He was presenting cefiderocol. He said may not be for India. Now it looks like it may not be for India and may not come to India also, considering the studies that have been shown. Now, as you rightly said, it's a total different resistance mechanisms that are there. Zidibactam, very few have used. I think it's available. I think Niren, you had one experience. Okay. I think you might have seen, madam. You would have seen.
We have used for a few patients.
Few patients, yeah. Other than these two molecules, I think plasmamycin, yes, of course, but not, though it was a better option than amikacin, but I am not sure where to place it exactly without a proper culture report.
Yes, if the culture report says sensitive, that's
yeah, then only, otherwise it's going to be, and also the cost factor.
Yes, compared to amikacin especially.
Yeah.
So that's all I have. Thank you. So thank you to the panelists and thanks to the audience for laughing at my jokes.
Yeah, you want to ask?
Thank you very much for our esteemed panelists for this engaging and insightful discussion. And thank you, ma'am, for your comprehensive presentation. I would request our panelists to present a token of memento for our speaker, ma'am. Chandrasekhar sir, Bhimasena Chari sir, Chandrasekhar sir. I would further request Dr. Bhima Sachanar sir, Professor and HOD, Government Medical College, Anantapur, and Dr. S. Chandrasekhar sir, former professor and senior consultant, to present a token of appreciation to our panelists.
Bhima Sachanar sir. Yes, Chandrasekhar sir. I thank all the panelists for their active discussion. Now we are moving to next session.
The next session will be on adult vaccination importance. To chair this session, I would like to request Dr. P. Rajshekhar sir, Professor, Department of General Medicine, Kurnool Medical College, Kurnool, and Dr. K.V. Somashekar Reddy sir, Senior Consultant Physician, Nandyal, to chair the session, sir. I would like to request Dr. Surendra R. sir, Consultant Infectious Diseases, SIMS Hospital, Chennai, to present this topic, sir. Over to you, sir.
Good afternoon. So, now the topic is about adult vaccination. So that is very important. So that is by Dr. Surendran, got at Coimbatore Medical College, Coimbatore. His present designation is a consultant of infectious disease and hospital infection control at well-known leading one of the best hospital, that is SIMS Hospital, Chennai. He got some awards, the winner in Transplant ID Quiz 2019 and the winner of Neuro ID Quiz 2019, that is Neurological Infectious Disease course, CMC Velur. He is the one member of prestigious societies, that is including IDSA, that is Infectious Disease Society America, and SIDS India. Thank you.
Thank you, sir, for the introduction. So thank the organizers for giving me the opportunity. It's an honor and pleasure to be with you all today in this afternoon. So the session is about adult vaccination. So just a question, how many of you in this hall have received a vaccination in the past 5 years except COVID vaccines? Except COVID vaccines, can you give me a show of hands, how many of you have received any vaccination? Yes, I can see a few hands. Okay, that's good. So can anybody tell what this picture is about? It's about? Sorry? Yes, it's variolation. So it's variolation, it began in 18th century. So 18th century, what they did, there is a procedure they did. They used to take materials or particles from people with smallpox and they injected that into healthy people so that they do not get smallpox. So that is when vaccination began. The famous American physicist, virologist has told this, the impact of vaccination on the health of world's people is hard to exaggerate. You don't need to exaggerate, it is very obvious. With the exception of safe water, no other modality has had such major impact on mortality reduction and the population growth. And it is one of the foremost scientific advances of the 21st century. So this is my outline. I'm going to talk about a little bit of history, different types of vaccines, the impact of vaccines, the benefit of vaccination, the burden of vaccine preventable diseases, and why do we need to talk about adult vaccination, a little bit in detail about influenza and pneumococcal vaccines, and I'll touch on other vaccines and an introduction about recommendations and challenges. So this is a history of vaccines which began in 200 BC. The Chinese doctors used dried cowpox caps to provide immunity to smallpox. And 1796, the smallpox vaccination was discovered by Edward Jenner, and then 1884, rabies vaccine, 1914, diphtheria, 1921, BCG, and so on. So to broadly classify vaccines, the broad classification is live attenuated and inactivated vaccines. So in live attenuated, you can have viral and bacterial vaccines. In inactivated vaccines, you can have whole cell vaccines and fractional vaccines. So what does live attenuated vaccines do? Live attenuated vaccines are basically weakened form of the wild virus or the bacterium which is sent into the body. It exactly replicates a natural infection. Mostly live attenuated vaccines, a single dose would be enough. So it usually mimics natural immunity, and severe reactions are possible. And there can be interference from circulating antibodies to that particular pathogen. So what about inactivated vaccines? Inactivated vaccines cannot replicate. They are less affected by the antibodies in the circulation, and the immune response is mostly humoral. And because of these factors, the immunity developed is not last-longing in case of inactivated vaccines. You will have to give boosters in case of inactivated vaccines. In inactivated vaccines, you have polysaccharide. In polysaccharide, you have pure polysaccharide and then conjugated. And then what is the difference between pure polysaccharide and conjugated? In pure polysaccharide, the immunogenicity is less. When you conjugate a particular vaccine, the immunity and the immunogenicity is going to increase. If you remember these points, that's enough. And then we have recombinant vaccines, which are made of recombinant technologies which can create virus subunit particles or the bacterial subunit particles. So this is an example of types of vaccines, different vaccines. I think everybody knows examples of live attenuated vaccines, which are chickenpox, MMR, smallpox, Japanese encephalitis, etc. Whereas toxoid vaccines are diphtheria and tetanus. What about the impact of vaccines? I don't have to show you data to make you believe that vaccines work. We all know that vaccines work, but let us look at some figures. So this picture shows that this much total number of deaths averted globally because of vaccines between 1974 and 2024 for selected diseases. So this much amount of death is prevented from measles, from tetanus, pertussis, tuberculosis. Every disease rate is coming down after the introduction of vaccines. And other big achievement in the humankind is eradication of diseases. We have eradicated smallpox in 1980. So this picture shows the year in which last case of smallpox was diagnosed in each of the shown countries. The other one is the polio endgame. So the above picture shows 1988 before the polio vaccination and after polio vaccination. Only one or two countries are endemic for polio now. So what are the benefits of vaccination? So when a patient asks you, and when you recommend a vaccine to a patient, for pediatrics it's not a problem, it is there in the program. When the pediatric says the parents take the vaccine for their children without any questions asked. When you recommend it to an adult or a patient, they ask, why should I get vaccine? What is the benefit? I'm going to pay so much. So what are the benefits I'm going to get out of this vaccine? It is very difficult to counsel on an individual patient basis, but let us try and understand what a vaccination does to an adult. So there is direct benefit to the vaccinee in terms of prevention from that particular disease. There is also benefit for the community in terms of herd immunity. And there is reduction in secondary infections caused by the vaccine targeted disease. Say you vaccinate somebody for influenza. So what are the complications of influenza? When somebody gets influenza, a significant proportion may get a superadded bacterial infection caused by pneumococcal pneumonia, pneumococcus or staphylococcus in terms of pneumonia and the mortality and morbidity associated with that. So influenza vaccine is going to prevent pneumococcal disease and staphylococcal pneumonia also. And there is also indirect benefit of vaccine to the neonates when the vaccine is given to the pregnant mothers. And indirect benefit towards morbidity of the targeted pathogen. It doesn't only prevent infection. When the infection is prevented, it is going to prevent hospitalization, it is going to prevent cost for the patient, etc. And not only that, indirect associations, because influenza can cause is associated with cardiovascular events and thrombotic events. So when somebody doesn't get influenza, they are prevented from these events as well. And cancer prevention. There are vaccines which prevent cancer. Say for example, hepatitis B vaccine prevents hepatocellular carcinoma. HPV vaccine prevents cervical cancer and other cancers associated with HPV. And vaccines are an important tool for the prevention of antimicrobial resistance as well. Example, we have multi-drug resistant salmonella, multi-drug resistant gonococcal infections. So if we have good vaccines for them and many people do not get these diseases, we are going to prevent multi-drug resistance in these infections as well. So this is just infographic which the ChatGPT created for me based on an article. This is just the impact it shows. It's not only the health impact, there is also a lot of economic impact. For every 1 rupee spent on vaccine, you are going to get a benefit of 27 rupees. And there is boosted productivity, fewer sick days for children and adults. So we see so many people getting sick leaves because of flu and associated illnesses. And there is social impact, health equity for health equity and in rural areas, stronger health systems because the infrastructure is going to develop, and empowering women and families. There was a study done in northern eastern part of India where they educate women about vaccines and then they give the choice of taking vaccines for their children, and they had a control group where they do not educate women and they recommend vaccines. So when they empower women to take decisions, there was more vaccinees in that group. So that was documented. Now what is the burden of vaccine preventable diseases? So just concentrate on the red. Basically it says all these infections are in increasing trend or re-emerging. For example, varicella, measles, zoster, hepatitis E, A, B, etc. So just concentrate on this. There's something called as downstream effects. When there is a disease, the downstream effects are loss of independence, loss of quality of life. These are mainly important for somebody above 65 years. In the older age, when they get an attack of influenza or a pneumococcal pneumonia, their life changes after that. Once they get out of the ICU, it is not the same as before. So the studies which are doing now are not accounting for the disability adjusted life years, the quality of life and all those things. So here 25% of the vaccine preventable disease patients require increased need for home assistance, whereas only 9% of non-vaccine preventable disease requires. So there's a clear association of these downstream effects also. So what is the need for adult immunization in India? There is high burden of mortality and morbidity due to vaccine preventable disease like flu, pneumonia, typhoid, cervical cancer, etc. in adults. There is an epidemiological shift in the occurrence of vaccine preventable diseases like diphtheria, pertussis among adults in India. Immunosenescence is very important. So people used to say, I got these vaccines in childhood. Should I take the vaccine when I am an adult also? Yes, what happens? As people age, and we have the proportion of people who are in the adult age are also increasing in our country because of better healthcare and things like that. So what happens? They have immunosenescence. Their immunity is also aging. So it forgets. So the immunity is not enough to prevent them from these diseases. So we need to give a booster, or we need to give them vaccines for the diseases. Waning immunity among adults, increased cost of hospitalization, increased vulnerability of elderly to acquire VPDs due to existing chronic diseases and exposure to infectious diseases from children in their homes, and increase in antimicrobial resistant bacterial strains leading to increased burden of infectious diseases. So this is a study which shows, if you see in other countries, in the UK, the take of influenza vaccine is more than 75%. In the USA, this is in adults. In the USA, it is above 65%. 70% in Canada, 7.4% in China. In India, they collected data from 64,714 adults aged 45 years or older. The take of influenza vaccine is only 1.5%. Pneumococcal vaccine is 0.6%, typhoid is 1.9%, and hepatitis B is 1.9%, which is very, very low. So a few words about influenza. It has a high mortality. It has been reported in India. These are the different types of, severe influenza getting admitted to the hospital has high mortality. The summary of advantages and types of influenza vaccines, there are different types. You have inactivated egg-based, inactivated cell-based, live attenuated, and recombinant. What is commonly available in our country is the inactivated egg-based vaccines. So the vaccine efficacy, if somebody asks, doctor, you are prescribing me this vaccine, I'm going to spend like 2,400 bucks or 3,000 bucks. Does it mean that and the next month they will come back with the flu and they'll say, you gave me the vaccine but it did work. It doesn't work like that. Because we have to make them explain or counsel them, understand that the efficacy or effectiveness is between 40 to 60% when the vaccine strains are antigenically well matched with the circulating viruses. And the immunity depends on several factors like age, match of the strain, egg adaptation occurring during the production process, and the history of previous vaccination. They have to take the vaccination every year, what strain they took, it depends on all these factors. It may not prevent them from getting the infection, but it will definitely prevent them from getting hospitalized in an ICU. So what are the vaccine formulations we have in India? Inactivated influenza vaccine, we have trivalent and quadrivalent. So basically, how to choose a flu vaccine? For this, you have to understand how the vaccine recommendations are made. Usually in the northern hemisphere, the flu activity happens during November to April. In the southern hemisphere, it happens between April to September. So the composition of flu vaccine undergoes adjustments annually. Every year it is updated like the software update to account for the prevalent strains expected for the upcoming season. So what happens, the selection of these strains for the particular year is made during 2 months, one during February and September. February they'll sit and discuss about the northern hemisphere strains, and once the strains are released by the WHO, for the production to happen it will take another 6 months. Only after that you will get the vaccines in your hand. So this is an example of, you can go and see the WHO website or Google what are the recent WHO recommendations for the upcoming year and the current year for the flu vaccination. So this is a paper which showed the demographics and the epidemiology of flu in India, because India is different. India doesn't follow this temperate and temperate weather and the other one. So here, India is a tropical country. So we don't know when it is going to rain and when the flu activity is. Basically what we say in India is the flu activity is all around the year with peaks during the years. So the variations in peak flu season across various parts of the country, it is mostly September to October for cities with temperate seasonality, April, May for cities with peak monsoon season, in July, September. So from this paper they suggest suggest vaccine during April, May for the part shown here, and September, October basically Srinagar, Chennai and Vellore. In Chennai we usually advise vaccination during the August month or September month. So which formulation to use? It's simple. You use the formulation whichever is the latest which you have available by the WHO. Coming to pneumococcal disease. Invasive pneumococcal disease has a 19% mortality rate with a case fatality rate of up to 30%. So I think everybody knows about pneumococcal vaccine 13, that is PCV 13. It has a good efficacy of 46% in preventing CAP and 75% in preventing IPD, that is invasive pneumococcal disease, among adults above 65 years. The available vaccines, just listen to the name of the vaccines. You have PPSV23. Initially we read the polysaccharides and conjugate. So PPSV23 is a pure polysaccharide vaccine, whereas the others are all conjugate, PCV13, 15, 20, 21. We have PCV20 in India recently in the last year, and we also have PCV13. So we have 2 conjugate vaccines in our country. So we have to juggle only with these 2. The sequence of pneumococcal vaccines is very important. A lot of times we are being asked by cardiologists or pulmonologists which vaccine to give first and which one next. So this based on this fact that if you give PCV13 and if you give PPSV23, the polysaccharide vaccine after that, the PCV13 augments the response of PPSV, that is the polysaccharide vaccine. It is due to recalled or augmented immune response. But if you give a polysaccharide vaccine first, and if you give a conjugate vaccine later, it is going to diminish the response. So it is not supposed to be given like that. There should be a gap of 1 year between a polysaccharide vaccine and a conjugate vaccine. So this is the rationale for the recommendation on first administering a conjugate vaccine, then giving a polysaccharide vaccine with regards to pneumococcus. So this is the impact of reduction of incidence of pneumococcal disease spectrum in relation to pneumococcal vaccines. So timing for, I'm not going into the detail of it, but I'll give you only one thing. You can go into CDC and read all this. It is a huge chart for different categories. Just I will say a simple thing, above 50 years, the cutoff is above 50 years, you can recommend pneumococcal vaccine as the age criteria. If they have not received any vaccines before, you just give very simple, PCV20. We have PCV20 in India. Just give 1 dose of PCV20, that's enough. But if they have received, say for example, PPSV23 before, after 1 year, because the gap required is 1 year, and then you give a conjugate vaccine, which is PCV20. If they have received PCV13 early, after 1 year, you give PCV20. So that simplifies it. And you should also suggest or recommend influenza vaccine for this group, immunocompromising conditions like chronic renal failure, asplenia, acquired immunodeficiency, malignancy, HIV, Hodgkin's, leukemia, lymphoma, multiple myeloma, nephrotic syndrome, etc., regardless of their age. And you should also vaccinate people with chronic health conditions like chronic heart disease, congestive heart failure, liver disease, lung disease, etc., who will also benefit from pneumococcal vaccines. So this I have already told PCV, but if you do not have PCV20, what to do? So in that case, if you have only PCV13 and PPSV23, if somebody who is above 50 years of age, you give PCV13 followed by the polysaccharide vaccine after 1 year. And if somebody who has received polysaccharide vaccine before, after 1 year, you give a conjugate vaccine. If you do not have 20, you give 13, that's okay. But if somebody who has received PPSV23 and PCV13, after 1 year, you give PPSV23. But now you have conjugate vaccines. It's better to give PCV20 itself. The only difference I want to say is in the high-risk group, say for example, this high-risk group, you can decrease the duration of 1 year to 8 weeks. So here, after PCV15, you can, after the gap between a pneumococcal conjugate and a polysaccharide vaccine is 8 weeks in the high-risk groups. Other groups, it has to be 1 year. Okay, coming to shingles, the herpes zoster, it's a recombinant vaccine. You give 2 doses, 2 to 6 months apart, above 50 years is the recommended indication, and no need to check for varicella serology. HPV, the recombinant protein capsid liquid vaccine, recommended for less than 26 years, 2 or 3 doses based on the age. If it is below 15 years, it is 2 doses, above 15 years, 3 doses. There is no recommendation for pregnancy. Between the age of 26 and 45 years, it's a shared clinical decision for high-risk individuals. So we have 3 different types of vaccines, the bivalent, quadrivalent, and the nonavalent, which covers these strains. If less than 14 years, 0 and 6 months, above 15 years, 0, 2 and 6 months. So these are the strains covered. Most of the oncogenic strains are covered in these vaccines. Typhoid, you have an inactivated vaccine, VI polysaccharide vaccine, and a conjugate vaccine. The conjugate vaccine is most commonly used. It can be used in people about 2 years. It's a single dose. Booster may be given after 3 years in a high-risk individuals. The indications are mainly professional food handlers, unvaccinated adults 18 to 45 years may be given TCV in endemic areas, travelers, and during outbreaks. Meningococcal vaccine, you have a purified capsular polysaccharide and a conjugate vaccine. Conjugate vaccine is IM. The indication is adolescents or travelers to high-risk countries, 1 dose. High-risk, 2 doses, 8 weeks apart. Anatomical and functional asplenia is also an indication. Hepatitis B, you have a recombinant DNA vaccine. IM, 3 doses, 0, 1, and 6 is the common schedule. It has to be given in CLD, alcoholic liver, basically CLD, HIV, MSM population, injection and non-injection drug use group. So based on the strength and the brand you use, the schedule may vary. If you are using a monovalent vaccine which contains 20 microgram per dose, you use it at the regular doses 0, 1 and 6 months. In dialysis patient, the dose has to be doubled. It is 40 microgram, 0, 1, 2 and 6 months. There is something called as an accelerated schedule. If you want to achieve immunity very quickly in some people because of high risk or something, you use 20 micrograms, 0, 1, 2 and 12 months, or 0, 7th day, 21 days and 12 months. So this is an accelerated schedule. So what to do if there is a missed dose? Some people say, particularly doctors, medical students, they used to take the first dose in the first year and they forget. And when they come back to PG, they will take the second dose again. Again, they will repeat the dose. So how to go about it? There is no need to restart the series. If the series is interrupted after the first dose, the second dose should be given as soon as possible, and the third dose 2 months after the second. If the third dose is delayed, it should be given as soon as possible. And then after 1 month, we have to check for the titers. Coming to Tdap, I would just say there is a recommendation to give Tdap vaccine at the age of 21 years, and it has to be repeated every 10 years because the immunity is waning, and that is why we are seeing a lot of pertussis and diphtheria cases. The reason is what we discussed, because we are using acellular pertussis vaccine and the immunity is not that strong. And what about wound management? That is, in wound management, if the wound is clean or minor wound, if somebody has received tetanus in the past 10 years, no need to receive. If the wound is bad, if it is more than 5 years, we have to repeat a tetanus vaccine. Anti-rabies vaccine, I think everybody will know. Just to simplify, category 2 exposure, IM injection 0, 3, 7 and 1 between 14 and 28. If it is category 3, along with immunoglobulin or monoclonal antibody. The common scenarios that we see in practice is pregnancy vaccination, travel vaccination, patients with comorbidities like diabetes, CLD, CKD, heart failure and lung disease, and occupational vaccines for healthcare workers like doctors, nurses, etc., veterinarians, laboratory personnel, and post-exposure vaccination like hepatitis B, rabies and tetanus. Newer vaccine could efficacy which is over 90% for 90% against HIV infection via 3-dose schedule, that is 0, 1 and 6 months, which is available in India. And what about pilgrimage? So we used to vaccinate people who are going for Hajj travel or Kumbh Mela, etc. So for everyone, typhoid is required because of the food and water hygiene problem, hepatitis A and influenza. If somebody is going to have a prolonged stay, they need to have hepatitis B, Japanese encephalitis and pneumococcal vaccine. And the second one, for mass gatherings outside India like Hajj travel, for everyone, meningococcal vaccine, flu and polio vaccine. For prolonged stay, pneumococcal vaccine as well. Pregnancy, influenza, Tdap, hepatitis B and COVID. COVID mainly during pandemics and local epidemics. Splenectomy, this is a very common scenario which we see in practice. Splenectomy, the surgeons call us to give vaccination. So you give a flu dose and every year it has to be followed. And pneumococcal, like I said, PCV 13 followed by PPSV 23, 8 weeks, because this is a high risk group. Or if you have PCV 20, 1 dose of PCV 20, that's it. Then Haemophilus influenza is optional because the Haemophilus influenza rates in adulthood is very low if they have been vaccinated in childhood. If they are affordable, you can prescribe Hib vaccine, meningococcal vaccine and other routine vaccines like Tdap. So this is the list of common vaccines that can be given in comorbid conditions like CKD, CLD, lung disease and heart failure. I'll just show you what are the recommendations available. You can Google it. There is ACIP recommendations. Yearly it is revised. You can go and check and read about these recommendations. Age group and risk factor wise it is there. And we also have an Indian consensus guideline on adult immunization which is tailored to the Indian setting, which is there in the internet. You can go and read it. It is a very huge document on all of these vaccines. They have given recommendations for all of these vaccines in this document. So they have a recommendation based on age, they have a recommendation based on high risk condition, comorbidities and risk conditions as well. So few general principles. When you want to give 2 or more non-live vaccines, it can be administered simultaneously without any interval on the same day or at any gap. If you want to give a live and a non-live vaccine, you can give it together on the same day or even without or at any interval, no problem. But if you want to give 2 live vaccines, it has to be spaced by 28 days. You can give it either at the same sitting, or if you want to space it, it has to be 28 days. Most of the vaccine should be given intramuscular. The intramuscular injection should be given in the deltoid at 90-degree angle, not in the gluteal region. That is very important. And subcutaneous injections should be administered at 45-degree angle in the upper outer triceps area. Egg allergy, there's a lot of questions about egg allergy, basically for flu vaccine. The trace amount of egg protein in MMR and MMRV is insufficient to cause allergic reactions, so no need to worry. Even for influenza vaccine, there is no contraindication for egg allergy. And like I already told, PCV 13 and PPSV 23 should not be administered together because one is conjugate, one is polysaccharide. There should be a gap of 1 year or 8 weeks. So what is the current state of adult immunization in India? The challenges is lack of awareness, inadequate access, fragmented healthcare system, limited vaccine coverage with operational challenges, vaccine hesitancy because of misinformation and vaccine apathy and expense. What are the opportunities? We should establish national adult immunization program. We should strengthen the awareness campaigns. We should integrate the immunization services. We should strengthen the training for healthcare workers, promote public-private partnerships. We should implement comprehensive immunization information system, tailor recommendations to high-risk groups, adapt global best practices and adult immunization. We should establish adult immunization clinics which are specialized for adult immunizations per se. Thank you.
Thank you, Dr. Surendra sir, for this excellent informative talk on adult vaccination and updates and recommendations. I would request Dr. Rajshekar sir and Dr. Somashekar Reddy sir to present a memento to our speaker, Dr. Surendra sir. I would request Dr. Sivarajappa sir, retired professor, and Dr. Srinivas sir, consultant Aditya Nursing Home Adhuni, to present a memento to our esteemed chairpersons. next topic of today's session will be on rheumatology and infection. And I would request chairpersons for this session, Dr. Sujana ma'am, rheumatologist, Medicare Hospital, Kurnool, and Dr. G. Srihareddy sir, consultant rheumatologist, Kurnool Rheumatology Center, Kurnool sir, to chair this session. I would like to invite speaker Dr. Haripriya Reddy ma'am, consultant infectious diseases, AAG Hospital, Hyderabad, for this talk. Over to you, ma'am.
Dr. Haripriya Reddy Challa has done her MBBS and MD General and FNB in infectious diseases. Her present designation is Consultant Infectious Diseases, AIG Hospital, Hyderabad, and her areas of interest are tuberculosis, particularly the MDR variant, the PUOs and IPC. Award she has received certification in infection control, CIC, and one book chapter and 12 publications. I request Dr. Haripriya to take over.
Thank you, sir. Good evening, everyone. I think we are running late, short of time. I would like to keep it crisp. At the outset, I would like to thank the organizers for such an event and giving me this opportunity. So before I actually go into the topic, these are few scenarios as ID physicians we will face. A 33-year-old female with ankylosing spondylitis referred to us before starting infliximab, and then a young female referred to us from dermatologist before starting dupilumab, and then from a neurologist before giving a pulse therapy for his multiple sclerosis patient and starting rituximab. I work at AIG. These are the cases we see regularly. Crohn's patients who are refractory to local steroids, giving infliximab and vedolizumab, and other cancer patients receiving rituximab and chemotherapy. So these are all the kinds of patients that we receive, and how do we optimize. I am not really sure how many of you encounter such consultations, but this particular talk, I would keep it as an interaction between the rheumatologist and infection disease specialist. So how do we deal with these patients, what tests to be done, how do we advise on some of the prophylaxis and vaccination. This would be, so the outline would be immunosuppressive drugs and mechanism of their actions, different drug classes and what are specific risks of those drug classes, and then biological therapy, how do we screen these patients and optimize them. A few words on LTBI and a few conditions in which we work closely with rheumatologists, because patients and diseases won't come reading textbooks. We always have a dilemma: is it an infection or is it a flare of a disease or a rheumatoid condition presenting with inflammatory state and fever that is non-infectious. So this is the outline of the talk. So this is majorly what Dr. Sudhakar sir was covering, the sepsis, the inflammatory events. I'll just skip this. So these are the drugs that rheumatologists use. So they broadly classified as conventional DMARDs and synthetic DMARDs and biologicals. So in conventional, we have methotrexate, HCQs, sulfosamides, sulfosalazine, and MMF, cyclophosphamide. Then we have tofacitinib in targeted DMARDs. We have tofacitinib, baricitinib. These are targeted small molecules, and biologicals we have TNF-alpha inhibitors, rituximab, and other biologicals which has monoclonal antibodies. So these are all, So basically these show the targets where they act. So TNF alpha inhibitors, they inhibit the TNF alpha and action of neutrophils in the innate immunity arm, and these MAPs are B cell therapy inhibitors, that is specifically CD4. I will talk specifically about 2 or 3 things today. One is corticosteroids, another one is rituximab. This would be the major crux of the talk. So rituximab, it is an anti-CD24 agent that acts on B cells, and what are the infection risks of this agent? So basically, the infections include, when we are going to give this, the patients are at risk of both bacterial and viral infections, PCP, and overall infection risks, sepsis, but fungal infections are rare. So when you are seeing any biologic, you have to see what kind of biologic it is, what are the risks, and what are the type of prophylaxis or vaccines that you have to give. So this actually causes B cell depletion. So 6 to 9 months it will take for the recovery. So there's a problem with this, because when we used in rheumatology setting, we still use for limited number of doses, but with R-CHOP regimen, which are being used in cancer therapies, there's continue to go on. There is no point where the B cells depletion, B cells recovery is there. So before starting rituximab, patient needs evaluation, majorly for hepatitis B, PCP. There's TB risk. TB risk with rituximab is negligible, and there can be late onset neutropenia with rituximab. So the approach should be antiviral prophylaxis for hepatitis B, or if the already known patient, already HBsAg positive or previously positive and cured, that is HBsAg negative but anti-HCB antibody positive, those who naturally cleared the infection. These 2 patients might have a reactivation even though there is no viral active replication now. So these patients should be put on prophylaxis. For those patients who don't have immunity, that is HBsAg negative and also anti-HBs antibody negative, those patients need to be immunized, that is vaccinated. For hepatitis B, in before session, Dr. Surendran spoke about for duration that we can come down on for hepatitis B. This is one category patients where you can use that short duration hepatitis B vaccination, and you also have to give cotrimoxazole prophylaxis. No LTBI treatment is needed. Other age appropriate vaccination, as we heard, and this vaccination, let's say if patient already received rituximab, you can vaccinate him only after 6 months. So because it takes 6 months for the B cells to be again functional after rituximab once given. So this is what I've told. So anti-HBs positive or when the patient is not having immunity, you have to vaccinate him. If the patient is anti-HBsAg positive, he is all protective. When he's is this clear? Sorry, I think it is not clear. So that is the same thing. So HBsAg positive status, he should be given antivirals as prophylaxis. If HBsAg negative and anti-HBc positive, that is already cleared the infection, also should be given virals, because there is a high chance of reactivation with rituximab. So that is with the rituximab. I would skip this TNS alpha inhibitors for the want of time. One thing you have to remember, all the TNF alpha inhibitors are main risk factor is tuberculosis. So you have to screen for latent TB and give prophylaxis. Also tofacitinib and baricitinib, these are also high risk for reactivation of herpes zoster. So we heard the Shingrix vaccination in previous session. So these are the patients who should receive herpes zoster vaccination. A few words about approach to latent TB, which is very important in a country like India. To rule out active TB per se is very difficult. So by history, you have to consider previous exposure or previous treatment, clinical examination for any overt signs of TB, chest X-ray, tuberculin skin test or IGRA, more than tuberculin skin test will not be useful in immunocompromised hosts. So because the inflammation on the after the MON2 will not be shown because of they're already immune paralysis. So IGRA is to be used more than TST. And also if patient is found to have active TB or any suspicion of active TB to further evaluate. If you are sure of no clinical TB, then we go ahead and give LTBI therapy. At least ideally you have to complete LTBI therapy before starting TNF alpha inhibitors, or but within sometimes because of emergency or the patient is very severely symptomatic, we might have to start the therapies early. Then at least the recommendation is to complete 1 month of LTBI therapy or start and both the therapies simultaneously. That is the immunosuppressive therapy and the LTBI therapy. So what are the recommended or approved therapies? 6 or 9 months of INH alone, 3 months of weekly INH and rifampicin, 3 months of daily INH and rifampicin, 1 month of daily INH and rifampicin, 4 months of daily rifampicin. These are the 5 WHO approved LTBI treatment regimes. So I just want you to take one message from this slide. The risk of TB reactivation is highest with infliximab, than adalimumab, than etanercept. So infliximab is as much as 17 times, adalimumab 10 times, and etanercept approximately 6 times. More likely the patients on these drugs are so and so number more likely to have TB than the patients who are not receiving any of these drugs. So infliximab has highest chance of TB reactivation. So this is a quick checklist of investigations before before starting biologicals: viral screening, routine biochemistry test, chest X-ray, MON2 or quantiferon, as I already discussed. If you are going to start rituximab, serum immunoglobulins, and then any by symptom wise any history of active infections. How do we optimize a patient before biologics? If you suspicion of any serious active infections, do not initiate immediately. Do a workup and to at least diagnose the underlying active infection and start treatment to both the conditions simultaneously. And whenever use of biological is a must, try to use the biological with the lesser infection risk. If there is a discontinuation in the to discontinue in the presence of serious infection, but this is many times rheumatologist or the other physician who is sending you the patient would not agree with it. Try to come on board with them and have a multidisciplinary meet and try to optimize the patient accordingly. And there can be non-infective adverse effects which mimic infections, so we have to be thorough of them. So you have to know, every day there is new and new biologics coming up. You have to know the drug and its target, what is the underlying condition that we are treating it for, assess the risk and need for prophylaxis accordingly, and then appropriate vaccination. So two more slides. PCP, when and with which all drugs you need to prophylax for PCP. Basically glucocorticoids at what dose? Any dose more than or equivalent to 20 mg of prednisolone, which is planned for about 4 weeks. So this is the one important thing I would want you to know. More than 20 mg of prednisolone planned for 4 weeks or more. All such patients should be kept on PCP prophylaxis. Calcineurin inhibitors, TNF alpha inhibitors. Azathioprine or MMF alone doesn't warrant the therapy, but when these are given along with calcineurin inhibitors or prednisolone, you need to prophylax for PCP. Rituximab monotherapy also doesn't warrant PCP prophylaxis, but rituximab with any one of the other immunosuppressives, so it would want a PCP prophylaxis to be given. I'm sorry if the other, I would read it out for you. So what are all, we all know usually PCP prophylaxis, we give trimethoprim sulfamethoxazole. Yesterday my nephrologist calls me asking her lupus nephritis patient is developing rash with trimethoprim sulfamethoxazole prophylaxis. So what are the other alternatives? It is always important to know other alternatives for PCP prophylaxis. So we have dapsone, but before giving dapsone, you have to check for G6PD deficiency, and we don't have other options easily available in India. For Indian patients, what we have is dapsone other than this, and also other options are in nebulized pentamidine, atovaquone. So these are the other options that we have. So at another thing with steroids is in India and other endemic areas, you have to see, and if it's not possible to screen, just give 12 micrograms ivermectin when you are just starting off as a single dose for strongyloids treatment. That would prevent hyperinfection and secondary bacterial sepsis in patients whom you are planning to start glucosteroids. I think this was already covered by Dr. Suren. So few conditions which we work along with rheumatologists which mimic fevers and adult onset still disease, sarcoidosis. I just want you at least to know the names. A flare of SLE, so how sepsis overlap with SLE flare. So this is a very common scenario that we encounter. We have to be sure that there's a fine balance. We shouldn't be overthrowing that balance. And another thing is giant cell arthritis. These are all the adult onset still disease, sarcoid, giant cell arthritis. These are the few conditions which come in with PUOs and need a close association with the rheumatologist while we are working. So that I thought I would have a mention on this. Thank you. I would like to take any questions if you have any. Any comments from you, sir, ma'am?
Nothing, ma'am. Nothing. I just want to add that cotrimoxazole prophylaxis is also advised whenever patients were put on cyclophosphamide.
Yes, sir.
Yeah,
yes,
that.
Hello, ma'am. That was an elaborative presentation, very nice presentation. So, I too want to add one thing. Before starting any immunosuppressant, we have to rule out infection. Whether that could be steroid, whether that could be methotrexate, whether that could be azathioprine. Any immunosuppressant, we have to rule out steroid because there is most of the rheumatological diseases mimic the infections. First of all, if the patient comes with joint pains, rash, fever, we have in mind that both the infection and rheumatological diseases, but we have very intention, especially we rheumatologists have an intention to start steroid at the outside, first time. So for us and for all the postgraduates, whether if you come across any patient with fever, PUO, with arthritis, don't hastily start steroid. First rule out infection. And one more thing I want to add is, if you are giving immunosuppressants like methotrexate, cyclophosphamide, azathioprine, you can give vaccination, non-live vaccines, not live vaccines, along with the immunosuppressant. But if you are giving methotrexate, you can wait up to, you can give the vaccine, but you can postpone the methotrexate dose up to 1 to 2 weeks. Those two things I want to add.
Thanks for bringing it up, ma'am. Actually, I think I just missed it. Don't hesitate to put a needle in joints whenever there is a warm joint, just to diagnose, is it a flare. Your disease flares are also warm. It is not, we never know until we see what is inside. Don't hesitate to do diagnostic taps. Just keep them sterile diagnostic taps, that's it. And you better rule out infection before you, never cause harm giving more immunosuppression on a joint which is already infected, because rheumatoid arthritis per se is a risk factor even without any immunosuppression for staphylococcal and other bacterial joint infections because of the wear and tear already present in the joints. Thank you.
Thank you very much, Dr. Haripriya ma'am, for your elaborative and detailed presentation on the intercomplex interface between the rheumatology and infection. I would request our chairpersons, Dr. Sujana ma'am and Dr. Sri Reddy sir, to present a memento to Dr. Haripriya Reddy ma'am. I would request Dr. Devanand sir, retired Professor of General Medicine, and Dr. Abdul Rahim sir, Professor of General Medicine, Karnool Medical College, Karnool, to present a memento to our esteemed chairpersons. I would request Dr. Rashekar sir to join Dr. Devanand sir to present a memento to our chairperson sir. Next topic of today's will be syndromic testing panels for early optimization of antimicrobials. To chair this session, I would request Dr. Bhimasenachari sir, Professor and HOD, Department of General Medicine, Government Medical College, Anantapur, and Dr. S. Chandrasekhar sir, Professor and Kurnool Medical College, Kurnool, to chair this session, sir. I would request Dr. Arun Kaushik R sir to kindly deliver his talk.
Hello. The Dr. Arun Kumar Kaushik, his education qualification, he has done his MBBS, MD in microbiology, a DNB in microbiology and PG diploma in ID. And his present designation is currently working as manager, Biomedics Medical Affairs, South Asia. And the areas of interest is hospital infection control, mechanism of antimicrobial resistance, and management of infectious diseases and quality control. And his awards and achievements are, has many publications in national journals in various topics and has been a part of many research projects during his tenure in medical college, and is trained on ISO 15189-2012 and has served as a quality manager, has faced audits from NABH, NABL, JCI. Sir, please.
So good evening everyone. Thank you sir, thank you for your warm welcome. I'd like to thank the organizers of this CME for having me here. So let's make it a little bit more interesting. Can we have it more interactive than being a didactic lecture? Because I think it's a whole full day of it's almost 4 o'clock now. So I think we'll have a little bit of discussion. So postgraduate students, can you make it more interesting? More discussing? Yeah, so I think my topic today is syndromic testing panels for early optimization of antimicrobials. So what is syndromic testing? Anyone of you have heard of? I think clinicians also, anyone can tell. I think all of you would have heard of syndromic testing. So any idea what is syndromic testing? Okay, what is a syndrome? Yes, sir. Okay, sir. So, sure, sir. So anyone, what is a syndrome? Okay, what is a syndrome? Why? Yes, sir. Thank you, sir. So we identify the signs and symptoms, which is called as a syndrome. So any panel which identifies a syndrome which supports a clinician to start the right antimicrobial at the earliest is the syndromic testing. So that's what we tell as syndromic testing. We utilize it to optimize the antimicrobials at the earliest, not only antibiotics, the antimicrobial. It can be antifungal or an antiviral or an antibiotic or antiparasitic at the earliest, so that we don't want the misuse or unnecessary irrational use of the antimicrobials. So the technology is film array technology and the instrument is called as BioFire. So how many of you have heard of this instrument called BioFire? This is not a product, this is a microbiologist talk. So I'd like to just brief you on this panels which is available. How do you utilize it? How does it support a clinician to start the antimicrobial at the earliest? That is my main goal of today's talk. I think I saw one hand. Anyone else of you have heard of BioFire? 2? So I think with very less hands, I think I'll just highlight the importance, what are the panels, how does this work, what is the importance, how do we utilize it, and how do we utilize it to give the right antibiotic at the earliest or the right antimicrobial at the earliest. Because I think with today's talk on sepsis, I think we all understood we have only the 1 hour or 3 hour, golden hour when we can give antibiotics. After that, antibiotic may not be useful for the patient at all. So it's very important for us to understand the organism early, treat them early. This is where the turnaround time of the test plays a very, very important role. So if you're able to give the result of clinician that this is the organism you're treating with, and this is the resistant gene pattern which is there. So you know if it is an ESBL producer or the carbapenemase producer, which carbapenem, it is an NDM or KPC which is there, or if it is a vancomycin resistant one, or if it is an MRSA, within an hour's time. I think that gives you a lot of information, and you can give the right antibiotic or right empirical therapy for the patient at the earliest. So we call it the syndromic approach because we are dealing with syndromes. So we will tell you what could be the causative organism in that patient based on his signs and symptoms. So you pick and choose the right panel based on the signs and symptoms of the patient, based on the site where you expect the infection to be, and then you get the organism which is causing that syndrome in a patient, and you are able to target the right therapy for the patient based on the organism which is there. All of us know cultures, we send cultures, but what are the difficulties? Sometimes it takes long time for it to come. Poor sensitivity, and sometimes poor diagnostic kit because we only do cultures. We don't do viral cultures, we don't do parasitic cultures, and very rarely we have fungal cultures which is ordered, and even if we do, it's very difficult for it to grow. So we sometimes miss out fungus. So this is all the difficulties which we see with bacteria, and certain fastidious bacteria do not grow for us, or they can be missed out. So it's very important for us to send cultures. They are the gold standard still, but it's very important for us to do these molecular tests because we're able to reduce the turnaround time to, which was 2 to 4 days to almost 2 to 4 hours. That's a huge difference which is there, and we're able to optimize the antimicrobial therapy for a patient at the earliest. So these are some of the difficulties which we see with the paucity of time. I just go a little quick. So there are many studies, it supports the clinician to us know the organism early, know the identification of the organism early, and then treat appropriately. There is a talk on intrinsic resistance, which all antibiotics can be used for which all organisms. So it's very important for us to know the organism early, know the resistant gene pattern early so that we're able to optimize the therapy for a patient. So in this test, one sample in one comprehensive test, in an hour's time, we are able to give you multiple results. It can be bacteria or a bacteria plus bacteria. Bacteria plus bacteria can be a 2 gram negatives or 1 gram negative, 1 gram positive, which causes infection in a patient. Or it can be plus a virus, plus a fungi, or plus a parasite which can be identified, and we are able to give appropriate management for a patient. So this is the huge difference which is there. If you are able to give reports within a very short span of time, you are able to give the right empirical therapy for patient on day 1 itself. You don't need to wait for day 3, day 4. Now microbiologists can safely tell we can give reports in 48 hours. What was 3 days, 4 days prior because of manual testing, with automation we are able to give reports within 48 hours, almost 95% of the cultures. That further is reduced. So the empirical therapy is up to day 1. It is less than 24 hours. So within 1 hour is the runtime for these panels. So within 1 hour you know the organism, you are able to optimize your empirical therapy on the day the patient is there in the ICU. So it reduces the number of days in the ICU, reduces the ALOS of the patient. The patient gets out of the ICU faster, and patient gets discharged faster, and the patient improves better. Because if you treat the patient, or all your parasites can easily be identified by using these molecular tests. It's supposed to identify the undiagnosed or underdiagnosed pneumonia, whatever it is. So very important for us to identify co-infections, helps clinicians to do appropriate clinical decisions so that they're able to counsel the patient attenders on day 0 itself. You can tell your patient attenders, this is a patient who is suffering from this organism, I am treating with this, and we have seen good outcomes of the patient. And finally, generate savings for a patient. So main important thing is generate savings. Reduce stay in the ICUs, reduce number of irrational or unnecessary antibiotics, reduce or appropriate use of the empirical antibiotics, and better outcome for the patient. So overall, if you see the total cost saving for a patient, it is huge. Studies have shown almost 50 to 60% reduction in the overall cost package of a patient. If it was 1 lakh, it has gone up to less than around 50,000 for a patient. So this is again the important role. It also plays a very important role for antimicrobial stewardship. So one of the part of the diagnostic stewardship which we have been talking since morning. So all the things is done by the instrument, the sample preparation, amplification, and detection. So for microbiologists here, it supports a micro, because all you need to do is just put the sample into the instrument does the whole thing. Otherwise it is individually, it has to be done by the technician. They need to do a sample preparation, amplification, detection, and finally reporting. So everything is done by the instrument, and the total runtime is around 1 hour. So it mainly works on the melting peak technology. So the confidence limit is high, the sensitivity is better, the specificity is also higher. So we don't pick up the unnecessary contaminants from the environment. It's a closed system, so the chances of missing out pathogens is reduced. The chances of contaminants being picked up by the instrument also is reduced. That's a huge advantage for a clinician because we are sure of the organism which we are going to treat with, and we can treat the patient appropriately with the antimicrobial. So this also supports by the nested PCR. That's why we are able to give more number of pathogens within a shorter span of time. It's a huge advantage which is there. And again, each process has its own control. So if any of these controls fail, also the instrument will not give a result. So we are sure, or the positive predictive value is higher for the instrument. And it also supports as a negative predictive value. If the test is negative, it means that most of the time those pathogens the panel covers is not there in the patient. We are sure that we are not dealing with the list of pathogens which is there, which is covered by the panel. And one more advantage is 2/3 of the wells must be positive, or 2 out of 2, that is 2 out of 2 or 2 out of 3 should be positive for the instrument to give as positive. So it's again a confidence when it increases the sensitivity as well as specificity of the testing. So this is the basics on BioFire. So now I'll be going into different panels. So one we have almost 6 panels which is being utilized. So we use, this is for the upper respiratory where we call as the respiratory panel or the RP 2.1 panel. So we usually have 2 parts, the upper respiratory tract infection and the lower respiratory tract infection. So what is the difference? Postgraduates, any difference between upper respiratory and lower respiratory? Any one of you? Or is it the same? Is the pathogen flora the same in upper respiratory and lower respiratory? Actually, they are different. The upper respiratory, we have more number of viruses which we usually isolate. In the lower respiratory, we usually have more of the bacteria, the gram-negatives and the gram-positive which we see. Okay, where do you see upper respiratory infection? Is it common in the hospitals or in community? Where is upper respiratory common? Is it in the community or in the hospitals? Community, thank you. Where is lower respiratory infection commonly seen? Community, yes, but otherwise? Nosocomial is what we see commonly in the HAP patients, that is hospital-acquired pneumonia patients, or in the VAP patients, that is ventilator-associated pneumonia patients. So the plethora of the organism which is there is different, the MDR status is different. So it's very important for us to diagnose them early and then treat them appropriately. So these are all things which this again if you see here, it's more of viral in the community-acquired pathogens, though we have certain atypical organisms like mycoplasmas, chlamydias also coming in. Then we have the hospital-acquired pneumonia, and then, so this again, if you see, again it is the bacterial infection which you see. But more of the sensitive bugs of the gram-positives and the gram-negatives are more common here. If we go into the ventilator-associated pneumonias, then we go into more of the multi-drug resistant organisms. So each part of the thing, the organism, the type of organism also varies. So viruses, bacteria, among bacteria again the gram-negatives, the gram-positives, again among gram-negatives and gram-positives the MDRs and the non-MDRs also differ. That's why we need to pick and choose the right panel. That's why we have 2 panels which is there in the thing. And we have many studies which tell that doing the rapid diagnostics supports to give the right therapy for a patient. The unnecessary antibiotics are reduced because we know the organism, we know what we are dealing with, and we are able to optimize the therapy for a patient. So this is a panel which you hear. If you see here, this is a full plethora of the viruses. This is upper respiratory panel where we have more amount of the viruses which is there. All the influenzas, para-influenzas, RSVs, HMPVs, SARS-CoV-2 along with other coronavirus and adenovirus are covered in this, along with the bacteria like Bordetella, pertussis, parapertussis, chlamydia and the mycoplasma pneumonia are covered in this, and you can yourself see the sensitivity and specificities here. So ideally we require the nasopharyngeal swab which has to be sent for this patient. So anything what you understand, so what is the main importance of doing the upper respiratory panel or the RP 2.1 panel? Anything from the postgraduates? So where do you utilize this more? Which patients commonly we think this panel can be utilized? Is it hospitalized patients or community patients? Community patients. So among community patients, anything, it's more among the infants, pediatric patients, we see more amount of viruses. It plays a very, very important role. And also even other community acquired, especially flu patients, immunosuppressed patients, this plays a very, very important role. So there are many guidelines, and one of the most important IDC testing which tells that if you have multiplex RT-PCRs, kindly utilize this. There are n number of things. This is how the panel looks. Next, coming into the lower respiratory panel, which is the pneumonia panel. So again, if you see here, it is more about the bacteria which is there. It also gives you the atypical bacteria and the viruses, and also supports you with the carbapenems. I think we were discussing about NDM, OXA48 like VIM, IM, KPZ. So with this, we know which antibiotic we can give for a patient. If you are planning to give any of Ceftriaxone, we know we need to synergize if it is NDM. So we can pick and choose the antibiotic based on the antibiogram on day 0 or day 1 when the patient is there in front of you. That's a huge advantage. We don't need to wait for the culture reports to come till you are able to optimize the empirical therapy. You can optimize the empirical therapy when on the time of contact. Within 1 hour's time, which is the runtime here, you are able to optimize the therapy for a patient. You can even identify the methicillin resistant or the ESBLs for these patients. And most of the common gram negatives and the gram positive organisms which causes the lower respiratory infections or the pneumonias are covered in this panel. So ideally we have seen what was initially done when we don't have this molecular testing, it's either no pathogen detected or it is only the bacteria which can be detected. But after doing molecular testing, we have seen more number of viral only pathogens being isolated, or viral plus bacterial co-detection, or viral co-detection which has increased or which has improved. That's a huge advantage of doing these molecular testings. And this is IDSA 2024 which tells if you have molecular testing, if it is a severe cap, kindly utilize it. And if you are having this along with you, even for non-severe cap, especially for viruses, if available, kindly consider doing the molecular testing. This is from IDSA 2024 guidelines. And what they have seen is, if you are using a BAL specimen or a bronchial wash for a patient, the isolation is better compared to sputum, but again both can be utilized in the panel, so the isolation is far better than compared to just doing cultures for the patient. This also gives you something called as the bin copies. It gives you copies per ml, that is 10 power 4, 10 power 5, 10 power 6 or 10 power 7, similar to a culture report. How many of you have seen culture reports coming from the lab? BAL culture reports, endotracheal tube culture reports. Postgraduates, have all of you seen? Have you seen these values coming in your reports? Yes, so same way this also will give you the quantification or semi-quantification of the load of bacteria which is there. So it supports the clinician to pick and choose, because what we have seen is usually if it is a sputum, 10 power 6 and above is more likely to be a pathogen. Less than 10 power 6 could be a colonizer, so we will not treat. Suppose you have 4 to 5 organisms. If the colony, the copies per ml is less than 10 power 5, if it is sputum, then it could be more likely to be a colonizer than a pathogen. But if it is 10 power 6 or 10 power 7, then it could be more likely a pathogen. So we are able to appropriate and optimize the therapy for a patient better. That's a huge advantage, because usually sometimes when we see reports, we see 2-3 organisms, so we don't know which to treat or how to treat. So this plays a very, very important role. This semi-quantitation plays a very important role in treating the patient. So this is what I am telling you. You are able to see if it is 10 power 4, 5, 6 or 7, along with the organism which is there, along with the resistant gene pattern which comes. So it supports a clinician to pick and choose the right antibiotic for a patient. So it increases the isolation better. It supports for de-escalation. Almost 62% de-escalation is there. 42% of the time we are able to discontinue the antibiotics, and 23% of the time we are able to escalate. It's not only discontinuation or de-escalation positive organism which is there along with the yeast. So even you have Candida auris which is there. So it is the albicans, non-albicans Candida, the common gram positives and the common gram negatives which commonly we expect in blood along with your antimicrobial gene pattern. It also has MCR1 as of now. We are trying to increase MCR3 also, but as of now MCR1 is there for colistin resistance. And all you require is 0.2 ml or 200 microliters of the positive blood culture sample which has to be done. So this is how the report looks. This is what is the current status, what many laboratories in the country are doing. What they're doing is they're putting into the automated instruments. Once the blood culture indicates as positive, it goes into gram stain. Gram stain report is informed to the clinician. Then we put it across onto plates to get the growth. Once the growth comes, we put it across onto either multi-top or to Vitek instrument. I think what Nandini was showing was multi-top instrument for the ID, and AST was done by Vitek. But going further, what many laboratories are doing is once the bottle indicates positive, it becomes a reflex test. So they will put the bottle into the instrument. Bottle indicates positive. First arm goes into gram stain. Second arm goes into biofat. And the third arm goes into culture. So they have 3 arms which is there. So they optimize the cost for a patient, ideally for the ICU patient, so that they are able to get the faster report. So you get the gram stain report, you get the biofat report on the day the bottle indicates positive, something like this. So once you have the blood culture which is there, it indicates positive. So you see the timelines here. So usually within 8 to 10 hours, most of the blood cultures indicate positive. Max to max, you take 20 hours. So once the blood culture indicates positive, it goes into gram stain. Gram stain report is informed. Immediately in an hour's time, you are able to get the BCID report which comes to you. So you know the organism, you know the resistant gene pattern, you are able to optimize the therapy for a patient. Then you go ahead with subcultures. Then either if the institution has a multi-top is done. Otherwise you put it on white biofire report because it reduces the unnecessary antimicrobial resistance. It improves the outcome of the patient, reduces A loss of a patient, and the patient also improves faster. One more component is Procal. I think all of you have heard about this. So this supports, so this is the instrument which commonly many hospitals are utilizing, and they have a high confidence, and this is the instrument which does not only for Procal, all the other testing can be done. All your emergency markers, cardiac markers, biochemistry tests, everything can be done. Next, coming into the meningitis panel. So this panel, as all of you know, gram staining or identified cultures sometimes can miss out on the common organism, especially in CSF, or the pickup rate is very, very low. How many of you have seen positive cultures coming out from CSF? Have you seen any? You have seen it very frequently, or is it very rare? Okay, sir. Okay, you're doing meningitis, but on culture I'm asking, sir. Cultures positivity, how much it is? 2 to 3%. So it's very, very difficult as a microbiologist myself, very difficult for us to isolate organisms on culture because of the amount of bacteria which is there. So this is where this panel supports. So this panel reduces your turnaround time, and you are able to optimize the therapy on day 0. So it's a huge advantage of doing this panel. If you are not using the molecular panel, you will have to do individual tests. You will have to do gram staining, culture, India ink, latex occlusion, PCR, and for other individual molecular tests, which is again time consuming. This volume of CSF is also less, which cannot be utilized for so many number of tests. This is where this panel supports. It gives you all your bacteria, common bacteria which is seen in community acquired meningoencephalitis or meningitis, the common viruses which commonly we are seeing, especially CMVs, enteroviruses, HSV1 and 2, HHV6, human pericovirus, and the varicella zoster virus, along with cryptococcus which is there, which commonly are seen in community acquired meningitis or meningoencephalitis, and hardly require 200 microliters of the CSF sample. So the remaining amount of CSF sample can be used for culture, gram stain, or any other reflex testing which you want to do. And you have very high sensitivity and specificity for the test. So many of the patients, especially pediatric patients, neonates, patients coming from community where expect meningitis or meningoencephalitis, this panel is commonly utilized because it is FDA approved, it is in-house, and your turnaround time is only 1 hour. So within 1 hour, you know the common organism which is causing infection in a patient. So LP is itself a difficult process. So once you get the CSF, you hardly get around 8 ml or 10 ml of CSF. In that, if you have to do biochemistry plus hematology plus culture plus etc., very difficult. This is where this panel plays a very important. So this is how the report looks with all your organism which is there. The advantage is it is multiplex. So any of this which is detected, it will be easily shown in this report, and this can be taken and then appropriately you can manage your patient. This is from again ICMR. They say CSF PCR if available, it is always good to do for the patient. So it also reduces the aggregation use of antivirals. So if you want to treat a patient with antivirals, appropriately manage. If you don't want, you are able to manage symptomatically, you can still go ahead and manage the patient. So unnecessary antivirals like acyclovir have been reduced because of utilizing this panel, because we know the organism is causing the infection and we are able to optimize the therapy for a patient. Next, coming into the GI panel, commonly it is recommended for chronic infections, patients with immunosuppressed condition like retropositives or on steroids, post-transplant patients, because if you see here, this is a huge dilemma for a clinician. We don't know if the diarrhea is severe, if the patient is having dysentery, what is the cause, is the patient immunocompromised or comorbidities leading to this, is it a C. diff infection which is leading to this, is the diarrhea infectious or not, it can be non-infectious diarrhea also. So it's very important for us to answer these questions, which is where doing a molecular test plays a very, very important role. Commonly available tests are, what are tests commonly you do for stool? Patients come to you with a low stool. So what do you do for that patient? What testing is commonly ordered for a patient? Patient is coming with diarrhea or dysentery. So what are the common tests which we order? Or we don't order any test, we just treat symptomatically and leave the patient? Stool for microscopy. Anything else? Stool for culture. Anything else? Stool for hanging drop. Yes. So it's good that we are ordering at least tests for identifying the organism in the patient. But only difficulty is stool for culture, commonly what we see, normal flora. It's very difficult for us to isolate. Sometimes Salmonella or Shigella, if we are able to grow it, well and good. Because most of the times these E. coli usually overlap or overgrow the Salmonella or Shigella. That time it's very difficult for us to identify unless we put it on selective media. So again, it depends on the laboratory which is there. The next difficult thing is time consuming, or sometimes we might miss out the organism. Amoebas and all cannot be cultured. So it's very difficult. Clostridium difficile again very difficult to culture. Or you have to do multiple tests to identify each and every organism. This is where this panel supports. So it gives you all your common pathogenic bacteria, your diarrhegenic E. coli which commonly is missed out in culture. Culture we see E. coli, we give it as normal flora of the GIT. But if it is any of the diarrhegenic E. coli, it can easily be picked by these panels. Vibrios can be picked up, Clostridium difficile can be picked up, Campylobacter, Salmonella, Vibrio, and Shigella, and also common viruses we can pick up. So for pediatricians here, so it identifies commonly noroviruses, rotavirus, apovirus, which commonly are missed because we don't do anything for identification. What you have seen is many of these norovirus identification or astrovirus identification has improved after doing this test. Patients in whom we expect parasitic infections, doing a direct mode, again we tend to miss out the organisms, but doing this support. So we are able to identify especially Cryptosporidiums, Cyclospora, Centamoeba, and Giardia are easily identified by this, and we require 0.2 ml of the stool sample, ideally in a carry bladder transport medium. So for all the patients, as per IDSA, out of culture or other than culture methods, this is what they usually recommend. Molecular testing is usually recommended. And this is how the report looks for the clinician. So there are many algorithms which tell if you are having a chronic diarrhea, always consider microbiological lab investigation, and among them molecular testing is one of the most important things which can be done. So this is the algorithm which tells how to utilize the BioFire panel for identifying the GI infections.
So
it reduces...
Conclude, sir. Time is running out.
Just 2 more minutes. So we have the different organisms which can be easily identified and be able to optimize therapy for a patient. So this is one of the last panels which is there. This is called as a joint infection panel. Ideally for orthopedicians in whom they expect septic arthritis patients or in prosthetic joint infection patients. We all know it is again long run. I think morning sir was telling how difficult it is, how they put the cement balls with the antibiotic and then put the pellets into the joint. So this supports, if you know the organism, you are able to treat the patient appropriately, and you know you are treating the patient appropriately. That gives a lot of confidence for the doctor, and also it reduces the number of revision surgeries, especially in a joint, especially in a THR or a TKR. The number of revisions have reduced once you know the organism. So this plays a very, very important. So it informs the operative planning for the orthopedician. That's a huge advantage because you're able to tell your patient you are suffering from this organism. This is the antibiotic I'm going to put across in you, and we are able to optimize the therapy for patient. So in order to remove the joint, you can save the joint, reduce the revision surgeries, and have good outcome for the patient, especially from prosthetic joint infections and in septic arthritis. So this is a panel which is there. It contains commonly the gram positives, gram negatives, and the anaerobic organisms like Anaerococcus, which commonly we see, or Finigoldia, or Parvimonas, or Peptostreptococcus, which commonly you can see, or Bacteroides fragilis, which commonly are missed out in cultures. It can be easily identified along with the antimicrobial resistant genes, and we require only 0.2 ml of the synovial fluid. Even there are studies which show even bone crushings or tissues from the synovial or synovial tissue also can be put into this panel, and we have got good results from the patient. There are n number of studies which tell the importance of doing this panel. This is how the report looks. So I had just 2-3 cases. So done, sir. Done, sir. Done, sir. I just had 3 cases and close, finish it. So which panel do you suggest for this? Patient with cough, reduced feeding, irritable, breathing faster. Which panel, BioFire panel, do we suggest for this? Pneumonia panel. So the patient is having flaring of nostrils, straining of chest, 3 months old. We go more for the upper respiratory because pediatric patient we expect upper respiratory tract infection for a patient. Patient with watery diarrhea, stool sent for culture, hanging drop. Which BioFire panel do we do for this? We utilize a GI panel for this patient. Then we have 12-year-old child with fever with chills, burning extrusion 3 days back, was on antibiotics from a local medical store, feeling better on day 1, but again started feeling drowsy, was not good on day 3, came to ER, signs of septic shock. So which panel? sepsis panel. So the BCID panel is what we usually suggest. So this has direct benefits and indirect benefits if you are able to integrate the molecular rapid diagnostic test like BioFire in your workflow. It supports for faster identification. So thank you for the opportunity.
Thank you, Dr. Kaushik, for the highly informative lecture. Any questions? I think microbiologists could have undergone the topic thoroughly.
Thank you, Dr. Arun Kaushik, sir.
Thank
I
you,
would
sir.
request Dr. Bhimasenachari, sir, and Dr. Chandrasekhar, sir, to present a memento to our speaker, Dr. Arun Kaushik, sir. I would request Dr. Maheshwar Reddy, sir, and Dr. Vidyasagar, sir, to present a memento to our panelists, to our chairperson. Due to the shortage of time, I would request Dr. Kalyan Chakravarti, sir, to take over the next presentations. Over to you, sir.
Yes. So, until now, since today morning there has been ESBL torturing you, I think we'll come out of that ESBL completely, such that now at least you'll have something different which you regularly see, but we kept it for the last maybe in context of time. So we have some very important, it's not that all the time you deal a patient with piperacillin, tazobactam or cephalosporins. You have other organisms, you have tropical infections, and you have, they look like infections but they are not infections. So we are going to club everything into one thing rather than taking lot of your time, and followed by Dr. Maheshwar Reddy sir's final topic on HIV. So all different topics, interesting topics, quickly wrapped into a single thing. To start with, it will be Harsha.
For the next sessions, the chairpersons will be Dr. Sivarajappa, sir, retired professor and HOD and senior consultant physician, and Dr. Lakshmibai Madam, professor of general medicine, Karnool Medical College, Karnool, sir, to
Same chairpersons will be fine.
So, good evening everyone. So, I see all the medicine residents are already fatigued, but this is going to be very helpful topic. So, as a medicine resident, when I was doing my residency in Nizams, so much of the information which is there in this PPT, I really don't know. As a medicine resident, I really don't know. So it's a good opportunity for all of the medicine residents to learn much from this session. So I thank medicine department, Sri Ramulu sir and Somappa sir for inviting me along with SITS Andhra Pradesh. And sitting in front of me, Muva Gopal sir. Sir is my friend's father. So glad to present a session before him. Karthik is my batchmate, sir. So today's outline is what is invasive candidiasis, some few seconds on Candida diagnostics, what is the importance of knowing species level identification of Candida, antifungal drugs, some pharmacokinetic and pharmacodynamic literature, and antifungal therapy, how we are going to deal with the infection. So basically, my topic given was, when is it a fungus? So in fungus, we have lot to deal: Aspergillus, Candida, mucormycosis, lot of endemic mycosis. So I just, because of lack of time, I know that it is only half an hour, I only selected only invasive candidiasis we are going to discuss. So when we actually suspect invasive candidiasis is, patient is already in the ICU. We are giving treatment for his UTI. So patient is on ventilator, patient is on multiple inotropes, patient is on central lines and arterial lines for the monitoring of hemodynamics. So basically this patient is improving on treatment for the UTI, but suddenly a new fever spike starts and patient is dipping again hemodynamically. So these are the scenarios where patient comes with community acquired UTI infection, but he is succumbing to hospital acquired infections. So in hospital acquired infections, we know we are already dealing with multiple gram negatives which are drug resistant. So Pseudomonas, Acinetobacter, Klebsiella, all these things are the most common hospital acquired infections in our hospital. So basically we send a blood culture. If it is gram negative hospital acquired infection, we escalate antibiotics. If it is, though the Staph aureus infections are rare, in the Western literature it is always Staph aureus which causes hospital acquired infections. So we cover MRSA, patient still is not improving, deteriorating. So that is the time we should also think of some fungal with candidiasis is also one of the possibility. The third is deep-seated candidiasis not associated with candidemia. Something like prosthetic joint already there, inflamed joint, but it may not present in the blood, but it's still causing deep-seated candidiasis. So these are the three spectrums of invasive candidiasis. There are definitions for proven and probable candidiasis. So for proven, we need to prove the bug on the microscope or growing in the culture. So direct microscopy, only one caveat is these are yeast-like organisms, Candida, so which will proliferate forming pseudohyphae and hyphae. But only microscopic diagnosis, what is the problem is, there are other yeast-like organisms like Trichosporon and Geotrichum, which are also behaving the same on the microscopy. So and extended PCR-like testing will actually give us correct answer. So culture from sterile sites, pancreatic collection, put a pigtail, send it for culture, Candida can grow. So there we are proving our candidiasis. Next, positive blood culture, if there is any candidemia, the blood culture comes positive. So these are the three guidelines to say it is proven candidiasis. Either we have to prove it on microscopy, or some culture should grow, or blood culture should grow. So the other things are probable candidiasis. So where clinical criteria, patient is dipping on gram negative, gram positive coverage, patient high risk of Candida infections, thoracic surgery, neutropenia, particularly aplastic anemia and post-BMT, gut translocation and candidemia is very high likely. In pediatrics postings, we used to see whenever there is thrombocytopenia, neutropenia, along with gram negative infections, they used to cover candidemia with amphotericin because low birth weight neonates are very high risk for candidemia. Burns patients and intravenous heroin use, basically this, when there is intravenous injections, the Candida is a skin colonizer, we push it into our bloodstream. Okay. Next, coming to the Candida diagnostics, blood culture is the standard. The sensitivity is only 50 to 71%. When 6 bottles, 60 ml of blood is used, basically it is not a practical scenario where we send 6 bottles of blood culture. So it also takes 2 to 3 days to grow. And some species like Glabrata grows at 4th day, 5th day compared to other species. So these are some of the caveats with diagnosing candidemia with blood culture. And in neutropenic patients, the blood culture sensitivity is further low because low amount of infection only can cause a lot of trouble in them. And once the fungal load is less, it's hard to get on the cultures. So the now recent thing, I think beta-D-glucan, as a medicine resident, I don't know about this, but I think it's there from the last 5 to 6 years. So beta-D-glucan is actually a constituent of fungal cell wall. It's there in all fungus except Zygomyces, means except Mucormycosis family, it's there in all fungi. So soya beans, for example, if anyone is from the agriculture background, soya beans can detect fungus because there is an enzyme in the soya beans which detects the fungal cell wall constituent, and it releases some toxins against that fungus. Similarly, horseshoe crab has an enzyme. So basically that pathway is called factor G cascade reaction. So based on this enzyme availability, once exposed to the fungus, is actually the basis of this commercial test called beta-D-glucan. So we call it 1,3 beta-D-glucan. So the sensitivity of this test, we do it on the blood. The sensitivity is 81%, specificity is 60%. It's a very high negative predictive value. Basically, once the beta-D-glucan is negative, it's like we are almost ruling out invasive candidiasis 98% of the time. So cutoff value is 60. False positives can happen along, just like how you know while using galactomannan, IVIG, IV albumin, gauze packing materials, disruption of gut, some candida spill into the disruption of, in mucositis it spills into the blood and it can cause false positives. So I just want to show some real world experience of this beta-D-glucan assay. This was done in Apollo Chennai. Nandini Seturaman ma'am, who was also one of the author, who was the prior speaker. So before that, I want to tell you there is one score called Candida score. So based on the risk factors, we score this patient. The score is high, we assume this patient is at risk of candidiasis and we may think of giving empirical antifungals. If the score is on lesser side, we assume he is not at risk of candidemia and we don't give antifungals. So basically, this score I'm just presenting because based on this score only, the study was done. Okay, so the study was done in 3 groups. Group A is already proven blood culture positive candidemia. Group B is after surgery, patients are very sick, but they have already proven gram-negative sepsis or gram-positive sepsis. Group C is we didn't get any culture positive, but the patient is worsening. So basically in all these 3 groups, they did beta-D-glucan, and they found that beta-D-glucan levels as a mean, you can see the highlighted, the first row, the beta-D-glucan mean is high in the group A where there is proven candidemia. Group B where it was proven gram-negative infection or gram-positive infection, still the beta-D-glucan high is little higher side, whereas group C where they are suspecting candidemia based on the clinical scenario, but the cultures are negative, the beta-D-glucan is somewhere around 292. So basically, what they found is when the beta-D-glucan levels are high, maybe around some 500 or 600, the higher value is having a specificity, higher specificity of around 60%. We are able to identify the infection with more specificity, whereas the lower cutoff values, the specificity is less, but the sensitivity will be high. So the test comes as 80. 80 is equivocal, above 80 is positive, below 80 is negative. So values around 500, above 600 or whatever higher the value, there is a strong suspicion for candidemia. Okay, and I just want to show, so basically patient is having Klebsiella pneumonia, E. coli, Acinetobacter in the blood, but still the beta-D-glucan is high. So I just want to give a message that beta-D-glucan is not specific, but once the values are on the higher side in the 500, 600 range, it might be specific marker. So there are also molecular tests. We know the culture sensitivity is less, so we should do a PCR and find out. It shortens the time to diagnosis. So basically culture, the limit of detection in the PCR is 10 colony forming units per ml. Coming to the PCR based test, this is the BCID2 panel already spoken by the Biomerics company. Even the BCID panel has almost like 6 to 7 species of candida which it can detect. There is something called T2MR candida panel. How in Malditov we are using a laser desorption assay to identify the organism, to break the organism and identify the organism based on the cell constituents. Here we are using the MRI waves, the T2 sequence of MRI waves, that machine generates it. So blood sample, this T2 MRI detects the cell wall and it identifies the cell wall based on the cell wall constituents. it can detect Candida, like Candida albicans, Candida tropicalis, Candida parapsilosis, Candida krusei, Candida glabrata. The limit of detection is very low, one colony forming unit. So this is the advantage with T2 Candida. We may see this testing in India in coming 1 or 2 years. So the next question I want to answer is, so our treatment, now we know when to suspect Candidemia. The second point I want to tell is, the treatment depends on what Candida species it is, because many of the Candida species are susceptible to azole drugs like fluconazole, but many species are intrinsically resistant. For example, see that Candida lusitani, we suppose amphotericin is very potent drug, but it is intrinsically resistant to amphotericin, where amphotericin can fail. Similarly, these are the list of some of the species I gave in this picture, where echinocandins are intrinsically resistant, where azoles are intrinsically resistant. So this is ICMR data 2022, just showing different Candida species and their susceptibility profile. So Candida tropicalis is a nice organism. It is susceptible to many of our antifungals. Candida parapsilosis is also good, but coming to Candida auris, so you can see that fluconazole susceptibility is only 2%, means 98% of the times fluconazole is resistant in Candida auris. Echinocandins like caspofungin and idulafungin is around 70%. So amphotericin also stays around 70%. Sometimes it can be resistant to all the antifungal drugs available. So 2 points I want to tell about Candida glabrata. In Candida glabrata, the fluconazole and voriconazole resistance is high, and Candida krusei is intrinsically resistant to fluconazole and susceptible to voriconazole. So next, whatever drug we want to give, for example, the cheap and best drug, fluconazole, it has to penetrate the organ where the deep-seated infection is. Fluconazole is luckily the cheap and best drug which goes into all the organs. So this is the 0.7, 0.8, this is the ratio of that drug level attained in that particular tissue when compared to the serum levels. For example, if you see the gynecological tissues, the level is almost like blood levels. Even in the prostate, the good levels. In urine, the concentration is 10 times to 13 times more than the blood levels, just like aminoglycosides or something like that, like nitrofurantoin. So that is why fluconazole is always the drug of choice for vulvovaginal candidiasis in women, and we won't use other antifungals. And this is a chart showing different antifungal drugs and different tissue penetration. Only one thing I want to highlight is, if it is Candida pyelonephritis, you can't use the safer drug, liposomal amphotericin, because it doesn't penetrate the urinary tract. We have to use, though the patient is rich, we have to use conventional amphotericin or lipid complex, because it doesn't penetrate the urinary tract. Among the azole drugs, fluconazole is the best drug for urinary penetration or any other tissue penetration. So because I'm coming to Kurnool Medical College, so I just want to highlight this point. Basically, as a student in medical colleges, I also used to deal with a lot of farmers whose monthly wage is 10,000, whereas anidulafungin 1 dose costs 10,000. So how can we use anidulafungin in such patients? So discussing on podium to use echinocandins, IDSA guidelines recommend echinocandins, but we can't use. So basically, I want to highlight this NEJM 2007 study, where they compared anidulafungin and fluconazole for candidemia. So basically, this study has proven that anidulafungin is little bit better than fluconazole, but there are caveats in this study, because as we discussed, the Candida glabrata is more resistant to azole drugs compared to other species. But once the participants is having Candida glabrata in the study group, in both anidulafungin and fluconazole group, it is wrong comparison when there are Candida species in the study. So we should compare with Candida albicans or Candida parapsilosis. So finally, the study shows anidulafungin is better, but basically it is because of the Candida group in the study that made this study popularize echinocandins. So still fluconazole is also a good drug which costs around 500 rupees. There are many studies which I can show, but lack of time. Isavuconazole they compared with caspofungin. There is no difference in mortality. They compared fluconazole and amphotericin B. There is no difference in mortality. There is no difference in success rate. So they compared micafungin versus caspofungin. This is head-on-head between echinocandins. There is no difference. We presume all echinocandins are same in efficacy. So these are IDSA guidelines. IDSA guidelines always recommend echinocandins to start with. And once we know the species, once we know the susceptibility, we can de-escalate to fluconazole, voriconazole, like where we want the drug to act. Okay. I also stand with the guidelines because once we know it is Candida, always better to start echinocandins. Later from microbiology, we receive information that this is Candida glabrata, this is Candida tropicalis. Once I know it is Candida tropicalis or Candida albicans, I know the fluconazole will be very susceptible, then I switch to fluconazole, or I also get a report from microbiology that fluconazole is sensitive, then we can de-escalate to fluconazole. Yeah, thank you. Any doubts?
Thank you, Dr. Harsha, for excellent, elaborate and more informative talk.
Thank you, sir.
We'll continue. We'll just finish it quickly. No issue. Fine. Thank you. Just change the melioid. So I think some of you might have been observing the news, at least for the few months in the past. 2 diseases were there in the state of Andhra Pradesh. So I think probably you might have heard of melioidosis as one of them, and the other one, scrub typhus. So, yeah, not required, I think. So we'll go through quickly of those 2 diseases, why they became such an important diseases. So tropical infections, I would say that is the reason why they name it as neglected tropical diseases. So the word comes when we neglect as Asians or at least as Indians. So there are many tropical diseases just over there, but we generally neglect them because we do not diagnose them. So I remember that day when I met the chief minister. So he was asking me, are you sure that these cases all belong to the same disease, so-called melioidosis? So we had 2 patients who attended our hospital whose blood cultures turned out to be positive for melioidosis. And then, so there were 20 deaths by then, I think 30 deaths by then approximately. After that also some were there. And then the village was in a panicky situation and there was something kind of communal fights coming up stating that Telugulo Bodra antaru, adedo sariga petaledu, that is the reason why everybody were dying, and they started raising certain non-scientific concerns as well. And then 2 cases came. I get a call from Director Medical Education, Raghunandan sir, and then this health secretary, because those were the only 2 cases who had diagnosis. Then we went, and then luckily I had Viren who was also supporting us. And then the committee was constituted immediately, and I think within less than 3 days, Viren completely went to each and every house of these deaths. Every house of the patients who died. And then he got the reports, and then he came to me and said, sir, yanni melioid lane unnai. From the reports, whatever they have approached multiple hospitals, some CT scans were there, some other reports were there, clinically features were there, but none of them were diagnosed. Now I would like to bring to your notice why this happened. Do you think melioid is not there in Kurnool, Kadapa, Anantapuram? It's there only in Guntur, only Thorukapalem? Of course, Thorukapalem had a problem. There was some water contamination, which probably is not proven, but to a certain extent there is an evidence, and once that was stopped, the deaths have stopped, but they still continue to be there. So the biggest thing which I would like to take home message, which I'm starting with a kind of a take home message. I have not seen any of the postgraduates, even in Guntur Medical College, once they come across a patient of fever, what is that you are writing as your provisional diagnosis? That is the crux of identifying the organism. If you think it's a respiratory, write lower respiratory or whatever, pneumonia or community acquired, or if it's an UTI, you write whatever, pyelonephritis. But if you know there is nothing you are able to find out, what should we write?
You have to write it as acute undifferentiated febrile illness. That is the point from where the problem starts. Unless we start writing this acute undifferentiated febrile illness, we may not be able to pick up leptospira, we may not be able to pick up scrub typhus, we may not be able to pick up melioidosis. Because they have to be written, then from there your work starts. Now starting the work for majority of the infection starts with dash, proper clinical examination, a suspicion, followed by a proper certain important cultures like blood culture. So Viren and myself were discussing, where at the end of the day, let us not bombard them again with some CTXM, SHIV-TEM genes and all. So he wanted to ask, how do you collect a proper blood culture? How do you collect a proper blood culture? So this is the most important thing. You have to at least collect 10 ml, 2 bottles, aerobic and anaerobic. If anaerobic is not available, at least collect 2 bottles of proper aerobic culture, and majority of your infections are going to get diagnosed. Properly collect them. 10 ml means collect 10 ml, and I don't want to go through the whole procedure which you probably can see anywhere. But this has to be made mandatory. Turnaround times must be done. A patient coming to the emergency room, now have a question. Kurnool Medical College, do you have in-house, postgraduates are there, do you have in-house blood culture bottles at the emergency room for a casualty? No. You will never get a melioidosis. You will never diagnose a melioidosis. You cannot. Because if it has to be diagnosed, it's a slow-growing organism, it takes time, and if you give some antibiotic, you are not going to identify it. So that is the reason why those are the basic things. Now, because the topic has come, it's a bacteria that's there for hundreds of years, and it is found in soil, surface water, especially seen in monsoon seasons, and it's called, because it's initially seen in Vietnam, it's also called as Vietnamese time bomb. The risk factors everybody knows: diabetes mellitus, alcohol, immunosuppressed states, and especially the agricultural laborers, because they are exposed to soil more common, they are likely to get it. And it can also happen through inhalation as well. There are proven papers that it can happen through inhalation and ingestion as well. Of course, though commonly direct exposure to the wounds or to the skin. So we had 4 patients in a month. The Turkapalayam were the 3. The next case came and 1 was Vinukonda. But the point, this is not the crucial point. Now this is the crucial point. You can see something in the lungs, right? This patient, when he came to the hospital, he came in an hypoxic state, was admitted to ICU, a CT chest was done before other supports were initiated. He also had an ischemic heart disease on antiplatelets. So we sent, the pulmonologist said, it's a speculated mass, we need to do a BAL and then a biopsy probably, but because the patient is on antiplatelets, let's wait. And in less than 48 hours, there was a blood culture flagged. We waited for another 24 hours. And it was identified as Burkholderia pseudomallei. But nothing great in that, because Burkholderia pseudomallei, majority of the times, it presents as sepsis and pneumonia, and in certain other cases, it can present as a chronic melioidosis where the infection can stay in your body and slowly present as a chronic melioidosis or as a latent infection. But what is important in Turkapalayam here is something very, very different. That I'll let you know. This I told I didn't, context of time, I do not want to take much of your time. Generally it presents as a bacteremia and pneumonia, but other presentations can also be there, as you can see here. This is the commonest. The other common things are these. So pneumonia, sepsis, chronic non-healing ulcers, abscess, septic arthritis and encephalomyelitis. But what happened was, we took all those 4 samples and we sent them for whole genome sequencing. And then we did a bioinformatics of those samples, and we found certain virulent loci to which especially certain specific proteins that are responsible for development of septic arthritis were upgraded. So what does this actually say with respect to whether scrub typhus, which Naren is going to speak sometime shortly, or with respect to melioidosis? These organisms, in the morning as I was speaking, I was telling you, bacteria will be there before us and will be there after us. They keep continuously changing. So this is the most important thing. There will be genetic trips, sometimes genetic shifts. So we need to understand, and for that, Probably not everyone will be able to do all these things, but we have to understand, because what happened in this situation was all these patients, especially of Thurukapalam, they had arthritis as the major manifestation. So they were going to orthopedicians more than the physicians initially. And then all these patients, we just did a synovial tap as the other speaker was speaking, and then we did a PCR and we were detecting Burkholderia pseudomallei very quickly. Okay. So the other problems with the Burkholderia pseudomallei is picking up is also difficult. It mimics many other organisms like Sphingomonas pos immobilis, Pseudomonas. So on white egg, it is sometimes very difficult to pick, but the best possibilities would be a PCR or a Malditoff. And then blood culture though remains the gold standard. If you have any aspirates, we feel that they are a better position, like abscess or in what you call, as I have told you, synovial fluid. They are actually very good. On PCR, you can detect them in less than 3 hours. So lab diagnosis, this is one important thing. This is very useful for a microbiologist. But the problem is it takes time. It takes time to grow, and the safety pin appearance, which is very common, is very, very important, along with the metallic sheen, which you can see in the day 4. Again, the same misidentification as Pseudomonas and Sphingomonas is very, very important, especially for the microbiologists and also for the PGs. If you see that, and if you still suspect Burkholderia, you need to repeat or wait. Treatment, I think you just brush through. I'll just leave the slide for a minute. It has got 2 phases, both intensive and eradication phase. Okay, I would like to stop here. Concluding that another important point is we have this whole genome sequencing person with us who is actually from US. So he was saying, sir, if I was in US, I would have been behind the bars. The reason is it is considered as a bioterrorism weapon. So actually you're not supposed to culture them as we like, but still because of the lack of availability of PCR and other tests, we should be careful while doing this investigation especially. And there is one specialized agar which is called Ashdown's medium, but because majority are medicine postgraduates, I would like to bring in scrub typhus. Yes.
Thank you, Dr. Kalyan, for the nice, elaborate and impressive talk.
So, sir talked about one outbreak. So, I'll be more talking about the more common what we have seen that everyone knows about, but we'll learn more about how this is present and how there are new changes when it comes to scrub typhus. See, what we already know, we'll just see. So, we know that it caused by the bacteria Orientia susugamushi, and it is transmitted not by the adult but the larval stage of the mite, which are tromboculid mites. Eschar is present in many of these patients, which is classical. Diagnosis, usually what we have now as the gold standard, what we commonly get deeper into it. So this is also asserted it is a neglected tropical disease. So why tropical? The mite is actually present in an area called the Susugamushi triangle, which starts from Pakistan to Japan to Australia. Only here is where the vector is present. So only here was where scrub typhus was pertinent. So when we had the World War I, when American troops came to Vietnam and all, so this has caused the major deaths rather than any other fevers. So that is why when you know typhoid is there for long, typhoid got its name from the typhus fever, which is the scrub typhus. So that old disease has been the scrub typhus, but still remains a neglected disease. The case fatality rate, when you look at, so it's 30% when you leave it untreated. Okay. So when you look at the transmission cycle, as I said, it is only transmitted by the larval stages, not the adult forms. The adult forms, they actually stay with the rodents. So like Leptospira, this is also at a place where you have more of rodents. The larval stages, they pick up this bacteria, and once larval stage is infected, all the adults also gets infected. So all its progeny also gets infected. This is one of the reasons why the bacteria remains within these population for long, and they keep on transmitting the disease. So when you look at the size, so this is actually, as I show, some of adult, which you will actually may be able to appreciate. But the actual larval stages are much smaller, and they are the color is also much transparent, and you will not be able to actually see the larval stage of this tromboculid mite. So when you have the bite of this chigger, what we call the larval stage, these bacteria are released. They attach mainly to the endothelial cells. So that is where they replicate. The attachment to the endothelial cells is one of the important for the pathogenicity of scrub typhus. So this is an obligate intracellular parasite. So it gets phagocytized, then it escapes from the phagosome to involve the different multiple organs and lead to immune response. Locally, it can also lead to the local regional lymphadenopathy along with eschar formation. So the incubation period, as they say, is actually not that long. So you have only 6 to 21 days. So that is why the scrub typhus cases you see more when the rodents come out or when immediately after the monsoons. So it peaks around the August time and goes down when the winter start in January, February. So that is when you see the maximum amount of scrub typhus cases. In acute phase, what you have is the presence like any other flu-like illness with headache, fevers, chills, especially myalgias. What you can characteristically see is conjunctival suffusion, rash, if it is present, that is good, but very rarely appreciated in Asians with dark skin. Eschar, if it is present, I will talk more about it, where it will be present. But after this, when they land up into complications, that is when it becomes difficult to identify as the scrub, as the causative agents, and to pick up in these conditions when it affects kidneys, heart, meningoencephalitis, and ARDS at the last. So this is how a classical eschar of scrub typhus looks like. It is also called as the smoking gun or the cigar butt sign, and it is usually painless and hidden in some of the areas. So the usual areas are the axillas, the groin areas, neck just above the waistline. So this is where moist areas where the larvae of the tromboculid mite likes to stay and keep having their blood meal. So definitely there have been an increase in the number of cases. I'll show you some of the numbers. The reasons can be different. So simple thing is we are changing our cultures, and that is what is bringing us closer to these mites and closer to these organisms. So women started working. We are having now gardens in the kitchens as well. There is a lot of urbanization and deforestation going on. So all this becomes risk factor where we are going closer to the vector and getting ourselves infected with this scrub typhus. So these were the cases reported in the last 3 years from Andhra Pradesh. So in 2023, there were 1,295 cases of total 7,000 tests done. So in 24, of 10,000 tests, there was 1,600 cases. In 2025, in the last 1 year from January to December, of the total 11,000 tests done, we had around 2,190 cases. So there has been a gradual rising trend that has been going on, but definitely it is alarming that it keeps on increasing. But when you look at some of the states which are nearby, so where do you think, how many are reported from Telangana? Can you guess the number? So there were 2,000 cases. In Telangana, there were 200 cases reported. Definitely that is not the ground scenario that is happening. So even this, I say, is the underreporting of the number of cases. So you don't send the test properly and to correctly tell actually how many cases of scrub typhus were actually present. So when you look at the other states nearby, Orissa, which is above, this reported same 1,000 cases 2 years back. This year it reported 9,000 cases. Tamil Nadu has constantly been reporting these cases over the last 10 years. They have a rigorous network for diagnosis of scrub typhus in Tamil Nadu, even at primary healthcare level. So that's what, when it comes to number of cases is present. So these were actually the reasons why we are seeing a lot of increased cases being reported. Improved diagnostics before wheel felix was the only thing available. Now IgM, ELISA and PCRs are becoming more available and the tests are being done, and we are able to pick up more amount of scrub typhus cases. There is increased exposure due to deforestation and modern urbanization with kitchen gardens and rodent population coming into the urban community. The climatic conditions, as I said, that is why from October to January you will have the peak of scrub typhus cases, and we are getting closer to the vectors than required. ESHA, as I said, when you look at the number of different studies in how many cases ESHA is present, they say it is about 10 to 90%. So this is actually highly variable. But when you, in my clinical practice, I can say, when I'm strongly suspecting scrub, if you look completely thoroughly examine the patient at all the sites that I have told, you'll find it in definitely more than 75% of the cases. You'll be able to identify the ESHA. So you should try to look for this ESHA whenever you suspect scrub typhus. So in whom you should suspect? So sir already told about acute undifferentiated febrile illness. So that is one of the conditions where you should strongly suspect, especially those who have the complications of hepatorenal dysfunction, ARDS and acute kidney injury. And also look at the epidemiological risk factors. What is their occupation? Where do they live at? Especially if their house is surrounding by lands which are uninhabited, there are a lot of shrubs around, and there might be rodents roaming around. So most of these cases were having epidemiological risk as well. So this is how you might be thinking this is something like ARDS, normal pneumonia. This is actually can be scrub typhus, which can be easily treated. So the common clinical manifestations, first we already talked about as the common initial signs when they present as acute undifferentiated febrile illness. Then you can have the complications of ARDS, pneumonia, AKI, thrombocytopenia with hepatic injury, and mainly it can also lead up to septic shock and MODS. But more commonly, the critical and the fatal lesions are usually meningoencephalitis. So in meningoencephalitis, what is the clinical pearl, most importantly, especially during this time with epidemiological risk factors, whenever you have a patient of aseptic meningitis, whenever your sugars are normal, if you have a thrombocytopenia and a hepatorenal dysfunction, treat for scrub and then you diagnose. Because you will lose this patient. You keep on treating for other conditions and you never suspect scrub typhus in this patient. Usually the MRI is normal, the protein very mildly elevated, 50-60 milligram per deciliter. So you will have actually systemic conditions with elevated mild hepatitis, acute kidney injury, may not be, or there can be ARDS in some of the patients. When you look at the kidney injury in scrub typhus patients, it is also again much varied depending on the definition you use. There is around 13 to 53. Overall 30% will have a kidney injury, and all of these are reversible. No patients will actually require dialysis lifelong. So if you actually treat and they come out, everything will be reversible. So what tests you have to diagnose scrub typhus? See, what we know is only about IgM, ELISA. So we also have PCRs that are now available, especially in the acute phase. When they present with acute undifferentiated fever illness, you need to do actually a blood PCR from the Buffy code or the ESHA. So that actually has the highest sensitivity compared to any other organism. IgM ELISA, though has a high sensitivity, there are a lot of false positives possible. So that is why it is still not the gold standard. The gold standard remains IFA, which is very difficult to perform in the normal situations. Okay. So the take-home message when it comes to diagnosis, doing the right test is, in the first week of illness, you try to do a PCR and not an ELISA or an IgM ELISA. So PCR would be a much better test for diagnosing and even confirming your scrub typhus rather than IgM ELISA. In the second week, you can do your IgM ELISA, but if you have an ESHAR, still a PCR would be a better test to confirm scrub typhus. But ESHAR itself, most of the times, will give the diagnosis of scrub. So this is actually the national guidelines for scrub typhus, which for confirmed case, they need to have only a PCR and an IFA. ELISA still remains a case of probable case. So scrub typhus is an obligate intracellular parasite. It's a very small organism and it is not easy to grow this organism. The culture, it is not a culturable organism. It requires viral cultures and other things, and very biohazard level 3, which is very rare. And to see if your doxycycline is going to work or not in this organism, and if there is resistance or not, is another big task, and there are no guidelines on this at all. So that is why it becomes a problem whether to say doxycycline will be working or not in these patients. So you should know the usual pattern, what happens when you treat scrub patients with doxycycline. If it is not responding, then you should think of what is happening with the patient. Okay. So for standard uncomplicated, when you don't have any complications in acute undifferentiated febrile illness, you diagnose the patient of scrub typhus. The first line is doxycycline, which can be oral as well, for 7 days. For pregnants, you can give azithromycin. In severe patients, you give a combination of doxycycline plus azithromycin. So I will talk about this much later. There is a big study published last year from CMC Vellore, which showed that the combination of IV doxycycline and IV azithromycin is much superior than giving doxycycline alone. But what is expected, even patients with severe ARDS or not meningoencephalitis but severe ARDS, hepatorenal dysfunction, by 24 to 48 hours, even if they are on high NIV requirements or even intubated, by 2 to 3 days, they usually get extubated and there is very rapid clinical improvement after starting doxycycline. If that is not happening, you should think about other things. As I said, untreated, it can reach up to 30%, but if you correctly treat, less than 2% actually die. And these two will also be those presenting late with complications like severe ARDS, myocarditis, and meningoencephalitis. So post-fever also, some of these are vasculitis mediated or immune mediated. You can have persistent symptoms like EKI and hearing losses. So the resistance, difficult to identify, but more common is to look for the clinical failure. There can be many reasons like late presentation, continued inflammatory response, poor absorption when you continue to give oral doxycycline only instead of IV doxycycline in sick shock patients. Also, as I said, if it is not responding, look for other alternative diagnosis. Lepto closely resembles it clinically. You should also look for dengue whenever there is thrombocytopenia, leukopenia. And again, as I said, INTEREST trial, which showed almost 30% reduction in mortality when you combine IV doxycycline with IV azithromycin. So the troubleshooting points, mainly what you need to remember in the current times when treating scrub typhus is, when there is an absorption problem, try to use IV doxycycline. I hope IV doxycycline, is it available? Very few. Available. I think they have made sure this time that it is available. Since long, nice. Then good that it is available, but you should use it when it is available. Okay. So the supportive care, for whenever antibiotics, as I said, it also infects endothelial cells, and there is also a lot of vasculitic inflammation that happens in scrub typhus. Severe, add azithromycin. So last time that I've given, I was not aware of it because tetracyclines were drugs that were there long back. So then the typhus was the problem there, that is why that worked. We forgot about it and now it has come back and we are using the age-old drugs, doxycycline. But still that hopes to be working most of the times. But they asked me about tetracycline only because of toxicities. Tetracycline will also work only because of the better safety profile, doxycycline. I have not used, sir, but maybe your experience only will help it. As I said, what I was told is the safety profile is better for doxycycline compared to, and also availability of oral forms is one advantage. So twice daily doxycycline is an advantage. Yes. So there are actually two forms of doxycycline, hyclate and monohydrate. So someone who has taken doxycycline, they would know how much of acidity and esophagitis it causes. Some of the people, when you give oral doxycycline, they just vomit out the drug along with whatever they have eaten. So it is very important on how you control this. So you should ask the patient to stay upright after taking the drug, take it with a full glass of water, and you should ask them to avoid especially dairy products when you take them. Avoid something that has more calcium or iron products when they are taking this doxycycline. So that is piloesophagitis does happen, sir. Yes, sir. So the key take-home points is definitely there are a lot of scrub patients. We are starting diagnosing it because of the more availability tools. We should still catch them because still there are severe cases where a lot of deaths happening due to scrub typhus. We have to increase the awareness, see for SRs in these patients, and treat them with simple antibiotics like doxycycline. The standard doxycycline still works. Very rarely you can think of diagnosis in the initial 1 week. Think of PCR more than ELISAs. After 7 days, you can use rapid tests or ELISAs. Severe management, think of adding IV azithromycin as well, along with IV doxycycline. Thank you.
Thank you, Dr. Naren, sir. Excellent presentation of this very commonly presenting case, scrub typhus. We are also getting a lot of typhus positive cases nowadays. Thank you, sir.
Hello everyone, good evening. Meanwhile, let the presentation get loaded. So basically I'm going to talk on mimics of infections. So in my clinical practice as an infectious disease consultant, at least 25% of my referrals or consults are actually to diagnose non-infectious conditions. So usually I'll be going and stopping the antibiotics rather than giving them suggestions about antibiotics. I have a lot of cases, but due to time constraints, I will be going through certain cases which seem more important to me. Anyway, I'll be sharing the presentation so that for postgraduates at least they can go through the cases. Okay. So many non-infectious conditions masquerade infections. Typically these present with fever or as a hallmark or a syndrome which is actually looking like an infectious syndrome. So based on this, I have structured my talk into like, there can be fever mimics, there can be sepsis mimics, skin and soft tissue infections mimics, pneumonia mimics, mimics of infectious diarrhea or infectious lymphadenopathy, some autoimmune disorders, or CNS infection mimics. So everybody knows when we come across fever, which is, even Harrison says the most common presentation in the OPDs or even the IPDs is either fever or pain. So by this you know how important is fever. So as soon as we see fever in the OPD, usually many doctors jump into the conclusion that it is an infection and we need to start an antibiotic. It has become so prevalent that patients do not come to you if you are a private practitioner and not writing an antibiotic if the patient has fever. If you order them tests, they are not happy. You need to write an antibiotic, which usually is the cause for raising antimicrobial resistance. I won't be going into detail of what is fever and what is the normal circadian regulation of fever. So basically fever and hyperthermia syndromes are well known, like these are popular questions even for the medicine postgraduates. So these are the things where we need to know what is the difference between fever and the rest of the hyperthermia syndromes. So most of the hyperthermia syndromes we need to differentiate from infectious causes of raising temperature or fever. I won't be going into detail. So we have neuroleptic malignant syndrome or serotonin syndrome
malignant hyperthermia. So we need to know how to differentiate between fever and hyperthermia. Usually fevers, like the effect of antipyretics is the main thing. Like usually what happens is fever, it will come down with antipyretics, but hyperthermias, they don't have any effect. And more important than this is taking a good history. There will be a preceding factor in hyperthermia because every type of hyperthermia has some preceding factor. Exposure to long times, long periods under the sun, or some anesthetic, inhalation anesthetic usage or something, or some motor features like rigidity or clonus. So that is more important. So with this background, I'll go into some clinical cases. Like we have a 31-year-old woman seen in the emergency department with fever and lymphadenopathy of acute duration, 3 days duration. There was some remote history of IV drug use, and 1 month ago she was treated with carbamazepine after an evaluation of a new onset seizure. So these are the physical examination findings and some basic labs. There's basically some LFT derangement. She was admitted to the hospital due to high spikes of fever. So blood cultures are negative, mononucleosis panel like CME, EBV were negative. Day 2 of hospitalization, she developed some patchy erythematous macular rash on her face, and WBC count jumped to 14,900 with increased neutrophils and no eosinophils. LFTs continued to rise. So this is one scenario where history becomes very important. If at all you miss the anticonvulsant history, you would not keep this as your differential diagnosis. This patient would have probably received a diagnosis of pueri sepsis and meropenem, teicoplanin, something else would have gone for at least 5 days. We would have waited for cultures would have come negative. So this is the importance of taking good history. So basically infectious disease is all about very good general medicine practice. Like you never miss anything in your history. So coming to drug fever, everybody knows how drug fever is present. So diagnosis is often made when fevers resolve quickly after stopping the offending agent. So in daily practice, what I find where I diagnose drug fever is patient will be on antibiotics for about 14 days. The primary care consultant initially doesn't call me. So they treat the patient is ready to go home. Every organ failure is improved, even if the patient is in sepsis, but fever is the only problem. Then they call me whether we should suspect a hospital-acquired infection, new infection, or is it something else. Patient will be inappropriately well in all these cases because he has already improved from the initial infection for which antibiotics were put. Then you suspect a drug fever, stop the offending agent, there is no fever within 72 hours or 48 hours after stopping the drug. So what we usually learn is there will be some rash, some eosinophilia, which are actually uncommon in most clinical studies where drug fever was studied. You have a long list of drugs. You need to understand what are the common drugs. Some antibiotics and some anti-epileptics are most common. So this is another case where a 37-year-old man was seen for fever and hypotension. For past 3 months, he has been receiving treatment for disseminated TB. He has been feeling weak, anorectic. 3 days ago, he underwent some emergency open reduction and internal fixation for a fracture of his leg, which he has sustained during a car accident. The night of the surgery, he has developed fever. He has been given broad spectrum antibiotics. The next day morning, he has some vague abdominal pain and hypotension persisted with need for vasopressor agents. These were the physical findings and some basic labs. So here you suspect two things. Either it is a surgical site infection or it is something to do with a non-infectious syndrome. If the surgeon, usually this case would have gone to the surgeon, if the surgeon or the surgeon's assistant did not take a history of recent TB drug usage, probably it is a little difficult to guess whether the patient had the diagnosis of adrenal crisis. So they won't call the medicine people to take history before going for an open reduction and internal fixation. If they miss the history, it is difficult to diagnose. Eventually they'll be giving antibiotics, it won't work. Sepsis has been discussed in detail. I won't take the chance to go into detail into sepsis, but we need to understand that sepsis is the most misunderstood infection mimic of all. You know what is sepsis? We need to understand the other causes of SIRS response. So there are many conditions that would mimic sepsis whenever you go into the ICU. These all conditions should be noted and try to diagnose these conditions. So So skin and soft tissue infections are quite common, but there are some mimics which can mimic skin and soft tissue infections. When we come to mimics of cellulitis, there can be either stasis dermatitis. This is very common. Patient coming with fever and he has some redness in the limb. Usually it is mistaken as some cellulitis and sepsis, but the patient would have this at long term. Always look for superficial thrombophlebitis. The only thing that can differentiate this from sepsis is usually the inflammation is along the line of the vein. You always search for a superficial thrombophlebitis when the patient is having fevers. Otherwise, the patient is well in the ICU, and especially when they are recovering. So what is this? So this is one of the complications of acute DVT. When he has vascular compromise, usually sometimes it leads to amputation of the limb also. So this was the case where they have, when the interventional radiologist could not pass the guide wire, so eventually it required an emergency surgery. This was the size of the thrombus. So always look at non-infectious conditions when especially the fever is not coming down with antibiotics. So lymphedema is one of the other differential diagnoses of cellulitis. Usually whatever looks red and warm, it is misdiagnosed as cellulitis. At least 20 to 30% of cases are actually not infectious cellulitis. So always, if you miss a history of lymph node, recent lymph node dissection and all, you would miss a diagnosis of lymphedema. These are slightly rare things. I will not go into this. So paniculitis. So paniculitis, most common form of paniculitis we see in our clinical practice is erythema nodosum. This is localized, not difficult to differentiate from cellulitis. So this is one thing I wanted to highlight, that never miss vasculitis. You miss vasculitis, the treatment is entirely different. You can't give antibiotics and wait. So usually biopsy helps us, which shows leukocytoclastic vasculitis. So we have this around 70-year-old woman who has presented with 1 month history of painful red plaques on her right knee. She had been diagnosed with MDS three years back and was in follow-up without medication. She had undergone pan hysterectomy for uterine cancer from 20 years previously. This is what she showed. Ill-circumscribed, tender, warm and red plaques with subcutaneous induration in her right leg. So initially cellulitis was suspected, however intravenous antibiotics had no effect. So please, whenever intravenous antibiotics did not help you in a case of cellulitis, please think of non-infectious conditions. So this was the biopsy. So this was the case of sweet syndrome. So this will resolve only when you give steroids. So it is seen in many autoimmune or hematological malignancies. So the background of the patient is very important when you see non-infectious causes of any fever or cellulitis. This is to summarize. So these are the key points. Cellulitis is rarely bilateral. When it is bilateral, think of other things, some systemic thing going on. So when you come to desquamating skin lesions, on the left you can see non-infectious conditions, on the right you can see typical infectious conditions. Sorry. So next we come to pneumonia mimics. I would just summarize this case for the sake of time. So basically this is a case which was diagnosed eventually as adenocarcinoma of the lung. So all cases of lung opacities or even consolidations may not be pneumonia. It could be just cancers or some other things. This would summarize the non-infectious causes of pneumonia. There are also some mimics of infectious diarrhea. So diarrhea is not always an infectious etiology. So I just summarized the non-infectious causes of diarrhea. So whenever diarrhea is continuing, and don't just write antibiotics and wait. So always think of other things. What is the background history of the patient? Whether the patient has other systemic diseases or any intestinal diseases which are of non-infectious origin. So many drugs that cause diarrhea, always look at your drug chart. Usually we get ICU consults having diarrhea. Either it is a C. difficile infection or it is usually something like some laxative. Initially they would have started, it is continuing. Once you stop the laxative, the patient is good. I would just, okay. So these are the mimics of infectious lymphadenopathy. Lymphadenopathy is always not infectious in origin. You have many non-infectious conditions of lymphadenopathies. And many times empirical TB treatment will be going on for cervical lymphadenopathy patient. Eventually the patient will have either Kikuchi's disease or it is, even in a bad case, it is a lymphoma and the diagnosis was not caught. So these are risk factors for malignancies, lymphadenopathy, and there are some medications that can cause lymphadenopathies, chronic usage of these medications. When you come to CNS infections, you need to know how to differentiate between encephalitis and encephalopathy. So encephalopathy is just diffuse disturbance of brain function without inflammation. Encephalitis is with inflammation. It is always important to differentiate between encephalitis and encephalopathy. So don't write just encephalitis for all altered sensorium patients because the differential diagnoses are different. So there will be cells, obviously pleocytosis, CSF pleocytosis, obviously in encephalitis patient, not in encephalopathy patients. So even in encephalitis, you have infectious causes, which you would have all seen, and there are certain non-infectious causes where history becomes very important. There is some recent vaccine usage, patient got a vaccine like 3 to 4 weeks back. Always think of non-infectious causes also of encephalitis. So these are the common causes of encephalopathy, not encephalitis. So I'll just summarize this case for the interest of time. So basically this 80-year-old male child had been suspected to have encephalitis, proven to have HSV1 encephalitis, received acyclovir, IV acyclovir, and thereafter he recovered and went home. He was on continuous follow-up with the pediatric neurologist. So 4 weeks later, he showed behavioral disturbances. Behavioral disturbances, thereon the child had some, so initially he was shown to a psychiatrist. So behavioral disturbance, eventually he was shown to a psychiatrist. Psychiatrist ruled out other things. He was even given syrup risperidone at that time. So the repeat CSF analysis showed anti-NMDA receptor antibodies. So there was no signal change or new infection. It was just anti-NMDA receptor encephalitis in the child who recently got HSV1 encephalitis. Treatment with IV immunoglobulins improved the child. So these are HSV encephalitis mimics. So you can see many non-infectious conditions there. So this is important in clinical practice and the ICUs. There are certain antibiotics that can cause encephalopathy. So whenever the patient is on imipenem, usually imipenem is the most common thing I have seen in my practice, or even some like fluoroquinolones, you always suspect these antibiotics whether they are leading to any neuropsychiatric manifestations. Of course, this is a diagnosis of last thing. You don't suspect these initially. So there are even some non-infectious diseases that mimic bacterial meningitis. Usually SH is a common thing we see. So with this is my last case. So this is a 42-year-old man who was seen with his third episode of so-called cellulitis of his external ear. So the previous 2 episodes he was given some antibiotics, but he slowly responded to antibiotics, so never showed again. So he had some chronic nasal stuffiness and episode of even knee arthritis the past year, but was otherwise normal. So these were his physical findings, and labs were basically routine and normal. So this is relapsing polychondritis. So whenever you come around autoimmune diseases, don't miss asking for history of joint pains or history of skin rash. Patient of autoimmune disease will not have all the factors at once. We read about 4 out of 11 conditions for criteria for SLE. How many SLE patients clinicians have seen? All 4 out of 11 every time they come. They don't present with 4 out of 11 every time you see the patient. Always ask for history. There will be history of some pleural effusion, some joint pains. Whenever pleural effusions, third space fluid loss, joint pains or skin rash, always keep autoimmune diseases on the back of the mind. So there are many autoimmune diseases that can mimic infections. There is one more case. Okay. So there is a middle-aged woman who has got some fever and leukocytosis. Fever has been present for about 4 weeks and has been accompanied by some arthralgias around wrists and ankles as well as myalgias. She had some severe sore throat which was present during the first week of illness. So the fever was of high grade, and the patient, when she was stripped, there was evanescent salmon-colored maculopapular rash. The important thing here is most of the Indians are dark-colored. Luckily, this patient was of fairer complexion, so rash was visible. Or else, very difficult to catch this rash, although textbooks classically say about rash in this particular disease, we are going to uncover. There were some tender cervical lymph nodes, both wrists were tender, and the spleen was enlarged. So these were the lab values: leukocytosis, elevated ferritin, CRP and ESR really raised, elevated LFTs, transaminases. You can see the autoimmune workup. So autoimmune disease was slightly correctly suspected, and ANA but ANA-RF were negative. Throat and blood cultures, all the cultures were negative. Crocalstone was initially high, but it's not very specific as we talked about it. All cultures were negative, and CTD and malignancy cover, basically it was negative. So such patients you need to suspect adult onset Still's disease. Even in children, when we suspect Still's disease, you need to look at the ferritin. Whenever you ask for ferritin in the lab, one thing I practically noted is many labs give ferritin is greater than 2000, greater than 1000. All infectious diseases, all inflammatory diseases will have elevated ferritin. It doesn't mean everybody has Still's disease. Still's disease, usually ferritin is above 5000, above 10,000, it will go like that. So always ask your lab to give an absolute value of ferritin rather than some value. Anyway, all infections will have increased ferritin, just like D-dimer. So raised ferritin with negative autoimmune workup, recent rash, subacute febrile illness, not going down, cervical lymphadenopathy, plus minus splenomegaly, should make you suspect Still's adult onset Still's disease. So we have many criteria. Yamaguchi criteria was famous in diagnosing adult onset Still's disease. So this is what you need to look at when you think of adult onset Still's disease. So with this I would end my presentation. So, thanks for giving this opportunity.
Thank you, Dr. Neeral.
Thank you, Dr. Veeran sir, for that illustrative presentation. Now, last topic of this CME today, I would invite Dr. Maheshwar Reddy sir over to the dais.
Continue.
I would request Dr. Vidyasagar sir and Dr. Mohan Reddy sir to chair the session.
Sir, I will complete within 10 minutes. Don't worry, sir. So today, good evening all. So this is the last session. So in fact, it was been in the middle. So I sacrificed for my seniors and my even the people who has come all over from other places. So I am going to discuss regarding HIV recent trends and recent advances in treatment. Can anybody say what are the precautions you will advise while taking TLD regimen? So you are giving fixed dose combination for patients, na? Any pages? Any instructions you are giving to them? When to take the drug? How to take the drug? Is there anything? Anybody? So actually, all of you should know that even antacids, calcium, iron preparations, all these things will decrease the absorption. So we should ask them to take 2 hours before or 6 hours after the meals. So that is the important thing. Any specific thing regarding diabetes patients with the TLD regimen? So we should ask the patient not to exceed the metformin for 1 gram. So you should not give more than 1 gram per day. So that is the instructions we have to give. For any anti-epileptic patients? So these are all the things you should know. Actually, okay, we'll go into the topic. These slides for all. So HIV virus remains one of the most significant health challenges worldwide, but thanks to the ongoing research and medical advances, the landscape of the treatment has evolved dramatically well over the years. As of 2025, new developments in HIV treatment are helping patients to live longer, healthier, and with fewer complications. Actually, I am having nearly some 50 patients who are there with me for about 10 years till now. They are all doing well. Only 2 patients were dropped out with my treatment. So in this block, we will explore the latest advances in HIV treatment and focusing on breakthrough therapies and improved medications and personalized care options that are shaping the future of HIV care. So when HIV was first identified in 1980, it was almost near certain death sentence. So the development of ART in 1990 marked a turning point. So ART is the combination of medications that works by suppressing the HIV virus and preventing it from multiplying in the body. So over the years, the ART has dramatically improved the life expectancy of people living with HIV. So these are the various steps where the HIV drugs, what we are giving is targeting. So recent drugs these are the recent drugs. So one is the IgG monoclonal, humanized monoclonal antibodies, that is abelazimab, so which is CC5 antagonist, and it decreases the post-attachment inhibitor. And then the other drug is cabotegravir. So that is the drug, and which is an integrase inhibitor. And the other drug is NNRTI, that is doravirine, and then fostemsavir. So these are all the drugs, entry inhibitor. So this is GP120 inhibitor. So, and then islatravir. So this is the drug which is NRT, that is nucleotide reverse transcriptase translocation inhibitor, where the translocation inhibition will be there and the chain termination will be prolonged. That is why this is acting over 96 hours. So even the drug is stopped also, it will be working for some time. So these are the newer drugs in the treatment of HIV. So in 1987, zidovudine was been first introduced, and of late now in 2020, these are all the drugs like fostemsavir, and then dolutegravir with rilpivirine, and then cabotegravir. All these drugs have come. Even cabotegravir, which is used for every 2 months, so it is used in pre-exposure prophylaxis also. Of late it is coming like that. Lenacavir and riponavir. So these 2 drugs which are being given 800 milligrams of lenacavir and then rilpivirine. So this is given as 600 milligrams tablet. Every day we can give. So in 2025, ART has become more effective and accessible, and several new classes of drugs are now available. These therapies are helping patients manage the virus better with fewer side effects and improved drug regimens, and decrease the risk of HIV transmission to others. So the latest advances in HIV treatments, what's new? So one is the long-acting injectable therapies and advances in HIV cure research, mRNA. So this mRNA vaccine, which was being previously done research for HIV, of late, actually because of the COVID, they have used for COVID in this vaccine. So these are the things which are coming up. mRNA and novel drug delivery technologies, dual therapy. Previously we used to give triple therapy. Now dual therapy, which is simplified regimen, which is coming up, and personalized HIV treatment and integration of telehealth and digital tools into the HIV treatment armamentarium. So this is the evolution of HIV treatment. Previously we had so many drugs. Of late we had fixed dose combination, and then now we are going for long-acting injectables. So these are long-acting injectables. One of the most exciting developments in the treatment of HIV is long-acting injectable antiretroviral therapies. So these treatments offer much needed alternative for individuals who struggle to have daily pill burden, and those who are not able to take the drugs regularly. And in 2025, cabotegravir and rilpivirine. So these are the things which has already gained approval in many countries for monthly or bi-monthly treatment. And then long-acting injectables like capsid inhibitor like lenacapavir. So this is one drug which is approved, and then this drug can be given twice a year. So because of this, so many people are even complained to take the drug, and there may be marked shifting in the treatment of HIV. So because of its flexible nature, and then which the patients may easily take the drug, lenacapavir, which is an capsid inhibitor. So as in 2025, long-acting injectables are moving from NIC use to the mainstream care. So this may be the mainstream care over a period of time. So over a period of time, because of demonstrable viral suppression and then stable health with minimal side effects. So there are two types of treatments. Advances in HIV cure research is like functional cure will be there and sterilizing cure. Sterilizing cure means eliminating completely from the body the virus. So functional cure means which can be controlled without the ongoing treatment. So that is a functional cure. And these are the types of HIV treatments. One is stem cell based gene therapy. So that genetically engineered hemopoietic stem cells which can be given which are like anti-HIV genes can be implanted into the patient, and badly neutralizing antibodies, the rare type of antibody that works to kill most of the HIV variants. So administered through the vaccine. So this is coming up, broadly neutralizing antibodies. And latent reversal, that is shock and fire. Fire will fire the cells and will treat that. Like a latent virus will be there, like reservoirs will be there. So we'll fire the cell to, and then we'll reactivate it, and we'll give the anti-HIV drugs or the immunoglobulins or immunotherapy to suppress that. That is called a fire and kill. So one of the thing is CRISPR gene editing, that is a precision targeting of HIV. So this is one thing which is coming up. It is a promising tool in all the which to fight against the HIV. So Excision Biotherapeutics, it was been tried, but it is not effective. So over a period of time this may come. So latency reversing agents. So awakening the dormant HIV virus. So one of the major challenges in curing HIV is the presence of latent reservoirs. So that's where the virus remains hidden and inactive. So that latency reversing agents aim to shock the dormant virus. So the virus which is dormant can be reactivated. So the active virus will be there, and then it is for the immune clearance, or we'll give the antiretroviral therapy or immunotherapy or broadly antibodies to suppress that. So combining that latency reversing agents with immune-based therapies to enhance the clearance of reactivated HIV infected cells is in the focus of the day. So is the future of an orchestrated immune strategy. So like that, immunotherapy means we will vaccinate, so to prime the immune system to fight dormant HIV virus, and we will activate and we will use the drug to wake up the latent virus, and we will attack the wake up virus with the anti-HIV antibodies to target the virus. So that is the immunotherapy which is coming up. So next is the stem cell transplant. So there are some insights into potential cures. So stem cell transplant are led to long-term HIV remission in selected number of patients. This has been notably which has been done in Berlin and London patients. So these procedures typically involves transplanting stem cells from donors with a rare CCR5 delta 32 mutation, so which confirms resistance to HIV. So there is one patient in 2024 Geneva patient. So he is not this without this mutation also. He suggested that alternate pathways are there for cure because he has achieved remission without this mutation. So this led to so many discoveries that there are so many other things which are there. Stem cell transplants are not considered a scalable solution for the broader HIV positive population. So why HIV vaccine is not really that much easy to do things, because it mutates very rapidly, whereas influenza virus mutates every year, but this HIV virus mutates every day. So that is why it is very tough to find out any solution like vaccines. So the virus has developed multiple mechanisms to evade the body's defense, and it targets CD4 to coordinate the immune response to viral infections. And this is broadly neutralizing antibodies usually appear 2 to 4 years. So by that time the mutation might have occurred. So that's why HIV vaccines are now, as of now, it is very tough. So previously they did like AIDS vax, so which failed in phase 2 trials, and then recombinant adeno-associated virus vaccine, so failed in men, sex to men. So paradoxically it increases the risk of infection. And then RV144, this is one thing which is monomeric GP120 boost, so which is coming up, the vaccine with the greatest promise till date. 31% efficacy is there in phase 2 clinical trials. So novel immunotherapies enhancing the body defense. So innovative immunotherapies are being developed to bolster the body's ability to combat HIV. So that IMC M113V therapy employs T-cell receptor bispecific approach to target and eliminate the HIV infected cells. So this is one thing which is coming up for the functional cure of the patient. So mRNA, that I have already told you, mRNA vaccines which were being which the trials were done for HIV. In fact, this technology was being used for COVID-19. So I think researchers are doing great research to get back the mRNA-based HIV vaccines to stimulate the robust immune responses against multiple HIV strains. So mRNA 1644 vaccine candidate, so this has been entered into the clinical trial and showed a promising early results in generating broadly neutralizing antibodies. So beyond vaccines, novel drug delivery system are revolutionizing how antiretrovirals are administered. One nanoparticle based delivery. So this decreases the side effects, increases the efficacy, and then decreases the dosing. Frequent dosing will be decreased. And microneedle patches will come over a period of time, which deliver the HIV virus through the skin in a painless, easy use to format. This may be ideal for remote and resource limited settings. And then these innovations highlight a move towards greater acceptability and patient-centered, paving the way for treatment that are not only effective, but also more discreet, manageable, and widely available. So dual therapy, so the simplified therapy is going to come in 2025. There is a shift from fixed drug combination of 3 drugs to dual therapy. So dolutegravir with lamivudine has been tried, and because it decreases the side effects and even long-term effectiveness is there in clinical trials, new combinations are entering into the market, and this may be even over a period of time this may come, dual therapies. So it is beneficial in aging population who are having so many multiple comorbids and associated drugs. Drug pill will be more, and it decreases the drug interactions also, drug-to-drug interactions. And then dual drug therapy is becoming the cornerstone of modern HIV care, offering patients simpler yet powerful treatment strategies. So one is personalized HIV treatment like precision medicine is transforming the HIV care landscape in 2025. So this may study how the genes affect the person's response to drugs. Clinicians can now tailor HIV treatment to individual patients more accurately than even before. So genetic testing, so to identify the person who can metabolize certain antivirals, helping providers choose medications that are both effective and less likely to cause side effects. Then genetic testing is one thing which can be tailored to the treatment to that person. And resistant testing may also come over a period of time, and then we can find out the low level of resistance mutations, and then the treatment can be effectively adjusted according to the patient. So then artificial intelligence is playing a greater role, and then AI-based platforms helping providers to predict the best treatment regimens based on patient's history, resistance profiles, and other clinical data. So with these advances, that prioritized individual care will be there, ultimately improving long-term outcomes and quality of life of the patient, people living with HIV. So
we have to tailor to according to the patient, treatment according to the patient. So integration of telehealth and digital tools, because the patients will be remotely placed in rural areas, so they may need even telehealth platforms to refill the prescriptions and to provide remotely to discuss lab tests without needing to visit the clinic, because social phobia will be there. So whenever a patient comes, they will have some inhibitions to attend a clinic. So mobile apps and wearable devices are being used to enhance medication adherence and overall health monitoring. And some tools send discrete reminders to take medications, track viral loads, and even detect early signs of side effects and treatment complications. And digital innovations empower patients to take a more active role in their health and facilitate real-time communications with care teams. And integrating technology into routine care, health care providers can deliver more responsive, continuous, convenient support, helping patients stay engaged and adherent throughout the HIV treatment journey. So in conclusion, as we step further into 2025, the landscape of HIV treatment continues to evolve with remarkable speed, from long-acting injectables to mRNA-based therapies to gene editing and personalized medicine. Each new advances bring us closer to more effective, manageable, and potentially curable options. So these innovations not only improve health outcomes, but also reduce stigma, simplify care, and support long-term wellness for people living with HIV. So, thank you.
Thank you, Maheshwar Reddy sir, for that clear and insightful update on the recent advances in the management of HIV. I would now request Dr. Vidyasagar sir and Dr. Somappa sir to present a memento to Dr. Maheshwar Reddy sir.
Check your moment.
I would request Dr. Malakonda sir, retired professor, to present a memento to Dr. Sagar sir and Dr. Somappa sir. I would request Dr. Sivarajappa sir and Dr. Lakshmi Bai madam to come out to the dais to present these mementos to the speakers. I would request Dr. Harsha M sir to come out to the dais and hand over the memento from our chairpersons. I would invite on stage Dr. K. Kalyan Chakravarti sir to come over to the dais. Sir, I would request Dr. Neeran Ravela sir to come out to the dais. would request Dr. Viren Ganta sir to come out of the dais. Sir. To present the mementos to our chairpersons, I would request Dr. Sudhakar sir to come out to the dais and hand over the mementos to our chairperson sir. Avunu sir. Thank you, sir. Thank you very much. I would request Dr. Nurjahan madam to come out of us and present the vote of thanks.
Good evening, respected esteemed faculty, speakers, delegates, and dear students. As we come to the close of this enriching CME program, it gives me great pleasure to offer a few words of gratitude. On behalf of organizing committee, I extend our sincere and heartfelt gratitude to our esteemed chief guests, Dr. P. Chandrasekhar sir, Dr. K. Chitti Narasamma ma'am, Dr. K. Venkateshwarlu sir, and Dr. K. C.S.K. Prakash sir for graciously accepting our invitation and being here. We are extremely grateful for your time and valuable contribution. Our heartfelt thanks to Dr. P. Chandrasekhar sir, Vice Chancellor, NTR UHS, for assuring postdoctoral fellowship in infectious diseases. This initiative reflects your vision in fostering growth and advancement. Thank you, sir. We extend our sincere thanks to the APMC observer, Dr. P. Rajesh sir, Professor and HOD of Pharmacology, for being present today and adding credibility and academic rigor to the CME. It is my privilege to acknowledge the President of ID Society, Dr. Kalyan Chakravarti sir, Secretary Dr. Viren Ganta sir, and Treasurer Dr. Niren Ravela sir, whose visionary leadership has transformed challenges in infectious diseases into opportunities for learning. This CME itself stands as a testament to that commitment. Thank you, sir. We are deeply honored by the gracious presence of our respected senior professors, Dr. Y. Bhaskar sir, Dr. M. Malakondaya sir, Dr. G. Bhavani Prasad sir, Dr. P. Sudhakar sir, Dr. Nagaraju sir, Dr. Muvagopal sir, Dr. Devanand sir, Dr. Sivarajappa sir, Dr. Chandrasekhar sir, and Dr. Vasantrao sir. Your presence added immense academic value and dignity to this CME and reminds us that true excellence comes from years of learning, teaching, and service. Thank you, sir. We express our heartfelt gratitude to all the speakers who have taken time out of their busy schedules and traveled long distances to be with us today and for generously sharing their expertise. I extend my sincere thanks to all the delegates and students for choosing growth over comfort by being present here today. I thank the organizing committee led by Dr. D. Sriramulu sir, HOD of Medicine. From planning to execution, every detail was handled with commitment and teamwork. I thank the scientific committee led by Dr. K. Vidyasagar sir, Professor of Medicine, and Dr. Niren Ravela sir for curating a relevant and evidence-based academic program. And special thanks to Dr. Somappa sir for his tireless efforts in execution. I thank the registration and reception committee led by Dr. S. Lakshmi Bai madam, Professor of Medicine, for ensuring a smooth and well-coordinated experience for every delegate. I extend my special thanks to the food committee led by Dr. M. Maheshwar Reddy sir, Professor of Medicine, which added comfort to the learning environment. Special thanks to Ishwar Etcon for their financial investment and insurance to many doctors. We thank the CIPLA team for conveyance, culinary service, and accommodation arranged. We thank Biomurix team for their generous logistical support. Thank you to the technical team for audio-visual support and uninterrupted scientific sessions. Special thanks to Mr. Samad. We thank print media and electronic media for their valuable coverage and helping us to disseminate the academic message of the CME to a wider audience. Special thanks to Mr. Damodar. And finally, a very big thank you to our PGs for their invaluable support and dedication throughout this CME. Special thanks to Sivanna, General Medicine DEO, for his efforts in seamless execution. I conclude by hoping that the knowledge gained today will inspire us to practice with greater confidence, compassion, and commitment. Thank you all for your presence and participation. Wishing you all continued success. Thank you.
We request Dr. Nalgonda sir, senior physician, and Dr. Sudhakar sir.
నన్ను పిలవలేదు మా మహేశ్వరికి రానే వద్దా ఏం పిలవకపోతే ఎట్లా స్పీకర్స్ అయిపోయినాయి ఊరికి అన్ని మొహమాట పడాలి
for their hard work to make the program a grand success. ఇదే సార్
Scientific committee is being headed by Dr. Vidyasagar, Professor of Medicine, and it is being coordinated by Somappa, Nurjahan, and the postgraduates of Scientific Committee, please join. Postgraduates of the Scientific Committee. Master,
కెమెరా కొద్దిగా
సార్ రండి సార్ మీరు చైర్మన్ సార్.
సార్ ఒకసారి దగ్గర రండి సార్. సార్ రెడీ? సార్ 1 second.
Next comes the registration committee. It is being headed by me, Dr. Lakshmi, and supported by Vali Basha and Durga Prasad. Registration committee.
సార్ కొంచెం ఇలా రండి. ఓకే ఓకే సార్ ఒకసారి రెడీ మేడం, కొంచెం వెనక్కి మేడం. సార్ దగ్గర రండి కొంచెం మేడం. సార్ మీరు కూడా కొంచెం సార్ ఒకసారి దగ్గర ఇట్లా మేడం దగ్గర రండి. ఈ లాస్ట్కి వెళ్ళిపోయినారు, కొంచెం దగ్గర రండి సార్. దగ్గర రండి ఒకసారి సార్. రెడీ? ఓకే
And it's being coordinated by Gopichan, Dr. Gopichan, Inka, Assistant Gopichan, and also other PGs. Karthik, Ravikiran, Shashi Praveen, Pranay Machanti, Ravi Verma. So food committee.
సార్ ఒకరి వదలండి సార్. రెడీ?
Srinivas, ready. Treasurer committee, Srinivas, Umesh, main I think. Umesh, Kumaraja, Nishan.
సార్ ఒకసారి
నిశాంత్ వచ్చేసి ఇంకా కుమారాజా సైకిల్ కంటే భాస్కర్ వచ్చినావా
సార్?
ఇంకా ట్రావెల్ వచ్చేసి సో ట్రావెల్ కమిటీ డాక్టర్ స్వర్ణ, డాక్టర్ మనోహర్, డాక్టర్ ఇమ్రాన్ లేదా స్వర్ణ ఉంది స్వర్ణ. సో బాయ్స్ పీజీ సెవెన్ ట్రావెల్ కమిటీ. సార్ అంటే స్పీకర్స్ వాళ్ళ కోఆర్డినేట్ చేసుకోవడం కమిటీ పెట్టుకున్నాం సార్. ట్రావెల్ అకామిడేషన్ కమిటీ అని. అదే సార్ నలుగురు అసిస్టెంట్స్, చైర్మన్ లేరు. స్వర్ణ ఒక్కటే మిగిలేదు. సో ఇంకా అకౌంటేషన్ వివేక్, విద్యాసాగర్, వేణుగోపాల్, హరి పవన్ కుమార్ రెడ్డి, చంద్ర ప్రకాష్. ఏమైనా పిల్లలు? ఓకే Sarna. Travel and accommodation. Dialogue ఏమంటే నాకు సైకిల్ తొక్కడం రాదు, టూ వీలర్ కూడా రాదు, నేనైతే ట్రావెల్ అండ్ అకామిడేషన్ కాబట్టి జోక్ చేస్తాను. నెక్స్ట్ రిసెప్షన్ కమిటీ సార్, చాలా పెద్ద కమిటీ. So it is being headed by me, Dr. Lakshmi, and I was being supported by Seema, Blessy Manohar, Surya Kala, Arshad, Divya, Arshad, and Noor Jahan, yes, Noor Jahan, Malakla kuda eskuntam. And postgraduate sir, Manindra, mainly asalu, sir, excellent job sir, very focused. అన్నారు సార్, అందుకు ఆఫ్టర్నూన్ సెషన్ మెయిల్ మెయిల్ ఇచ్చాం సార్, మమ్మల్ని తొక్కేసుకున్నామని సాగర్ చాలా బాధపడతా ఉన్నారు. ఇట్లా అందరు రండి, రిసెప్షన్ కమిటీ అందరు ఉన్నారు. సాయి ప్రియాంక, ఎస్ అర్పిత, వినీత, సుధా జయంతి, భాను. ఏ కమిటీ భాను ఉందే కదా, రిజిస్ట్రేషన్ కదా మా దాంట్లోకి వచ్చి. ఇది కూడా సార్, ఇది సార్ చాలా పెద్ద టీం, మళ్ళీ మాకు పెద్ద ఫోటో కావాలి.
మేడం
చాలా ఫోటో కెమెరా పడ్డం లక్ష్మీ మేడం ఆర్మీ ఉన్నట్టుంది కాదు, కెమెరా ముందు వెనక్కి పరిగెడుతుంది.
మేడం
నేను వెళ్ళి తీసుకునేది మేడం ఈ మూమెంట్ చాలా రెండు పెట్టినట్టు
ఒక్క నిమిషం అండి, ఒక్క నిమిషం సార్. రెడీ సార్, ఇక్కడ చూడాలి సార్.
డిపార్ట్మెంట్ సార్, ప్రతి ఒక్కరు ఇచ్చిన పని అందరూ చేస్తున్నారు సార్. ఎవ్రీబడి వి డిస్ట్రిబ్యూటెడ్ ద వర్క్ అండ్ వెరీ కోఆర్డినేట్. పనులన్నీ అయిపోయినాయి సార్. అసలు క్రెడిట్ గోస్ టు హెచ్ఓడి శ్రీరామ్ సార్. సార్ మాకంతా ఫ్రీ హ్యాండ్ ఇచ్చారు సార్.
I congratulate Dr. Sriramlu, HOD of Medicine Department, and all his colleagues, professors, associate professors, assistant professors, and PGs for excellent conduction of this particular CME on infectious diseases. It cannot be done by one person. Without the cooperation of others, any conference cannot be done. So that unity is there in our department, medicine department. I very much thank all the PG students and his colleagues for cooperating in conducting this conference excellently. Thank you very much.
I thank all the faculty, all postgraduates, by them everybody for successfully completing this SEAL program. I thank one and all. Thank you.
I am here since 3.5 decades. The last time we met like this was, I think, in 2012. After that, there is a long gap, and all credit to the current team, which have actually conducted in such a good way, and we are very happy, very happy, because I cannot praise more, because I was given the maximum importance in this conference. I am really indebted to Department of Medicine, Dr. Sriramlu, and all the committee members for having given me this honor. I can never forget this day in my life. And this happened after my retirement. That is the real happy thing. I'm so happy to be back. I'm always there for the department anytime, and I feel a part of this department anytime. Thank you for giving me this chance.
అయిపోయింది